The in-between area is known as clavipectoral fascia. From minor to here, in between, the fascia is known as clavipectoral fascia. This is one of the important area.
Sir, can't see the slide, sir.
So, you can't see the slide? It is just a
Yes,
minute.
sir, I can't see the slide.
No, we can see, madam. We can see. You
Okay.
check with your device. You log out and log in again.
Okay, okay, sir. Okay.
Yeah.
Sir, I also can't see, sir. Sir, the screen is not visible for me also, sir.
Now is it visible, all of you?
Yes, sir.
Yes, sir, it's
Yes, sir.
visible.
It's visible.
Yeah. So pectoral region, the superficial most muscle, the muscle is pectoralis major. If we remove the pectoralis major, we can see the pectoralis minor muscle. So here the important thing, pectoralis minor muscle, the nerve supply is supplied only by medial pectoral nerve. Okay, so pectoralis major muscle, which is supplied by both lateral pectoral nerve as well as medial pectoral nerve. So pectoralis major is supplied by both nerve, but pectoralis minor muscle, which is supplied by only medial pectoral nerve. Then we can move to the clavipectoral fascia. Clavipectoral fascia is here. After removing pectoralis major, clavicle. Then below pectoralis minor, from this clavicle to pectoralis minor muscle fascia is stretching. That fascia is known as clavipectoral fascia. Here, the clavipectoral fascia, which is pierced by three important structures. So the names are very important. The first, the one is cephalic vein. Cephalic vein. So this is one of the structure piercing the clavipectoral fascia. Okay. So after piercing clavipectoral fascia, cephalic vein, which will drain into subclavian vein. So the first number one structure is cephalic vein. Then second, lateral pectoral nerve. The second, lateral pectoral nerve. Okay. So there are two nerve. One is lateral pectoral nerve, another one is medial pectoral nerve. Okay. So here, lateral pectoral nerve, which is piercing the clavipectoral fascia, but medial pectoral nerve not piercing the clavipectoral fascia. So always we have to remember one is cephalic vein, another one is lateral pectoral nerve. Then third, one more structure is thoracoacromial artery. So always they will confuse, they will give sometime basilic vein, they will give, or medial pectoral nerve, they will give. Cephalic vein, lateral pectoral nerve, both are piercing clavipectoral fascia. Okay, we have to remember that. Then what are the muscle enclosed by clavipectoral fascia? That is also important. Okay, so here, for example, if you take section from above downward, here clavicle is there, clavicle, below the clavicle, subclavius muscle. So this is clavicle, here below subclavius muscle, here still below pectoralis minor muscle. So from this clavicle to pectoralis minor muscle, fascia is extending. That fascia is known as clavipectoral fascia. So this area is known as clavipectoral fascia. Okay. So what are the muscle enclosed by clavipectoral fascia? Two muscles are enclosed by clavipectoral fascia. One is pectoralis minor, another one is subclavius. Okay. So this is also important. What are the muscle enclosed by clavipectoral fascia? Below the clavicle, subclavius muscle is present. That is also enclosed. Pectoralis minor muscle also enclosed. What are the structure piercing clavipectoral fascia? Always very important things are cephalic vein. Another one is lateral pectoral nerve. Okay. Then third important pectoralis minor muscle, which is dividing the axillary artery into. We will come to axillary artery later. But by using this axillary artery, for example, axillary artery, if it is present like this, mean pectoralis minor muscle crossing the axillary artery in front of that. Okay. So by using this pectoralis minor muscle, by using this pectoralis minor muscle, axillary artery divided into first part, second part, third part. These are the points we have to remember. Then one more thing, pectoralis minor muscle inserted into coracoid process. Coracoid process. Sometime in osteology, it is very important. So here there are four things we have to important. What are the structure enclosed by clavipectoral fascia, pectoralis minor and subclavius enclosed by clavipectoral fascia. Clavipectoral fascia pierced by what are the structure? Cephalic vein, lateral pectoral nerve. Please remember lateral pectoral nerve, not medial pectoral nerve. Lateral pectoral nerve. One more structure, thoracoacromial artery. Sometimes some more lymphatics also can pierce clavipectoral fascia. Then pectoralis minor muscle used to divide the axillary artery into 3 parts. Pectoralis minor muscle, where it is inserted, it is originated from this third rib, fourth rib, fifth rib. Then it is spreading upward and inserted into coracoid process. So these are the things we have to remember. Then we can move to the next one, little bit deeper. Then, so first, let us move on to the scapular region. Okay, back. Okay, so here, back after removing skin, we can see one diamond-shaped muscle. The diamond-shaped muscle is known as trapezius. The name of the muscle is trapezius. Trapezius, which is used to shrug our shoulder like this. Okay, it is used to shrug our shoulder. So this is also known as shrugging muscle. Origin insertion not so important. Okay, so back after removing skin, superficial fascia, we can see the trapezius muscle, trapezius, which is used to shrug our shoulder. So shrugging muscle. Here nerve supply is very important, which is supplied by one of the cranial nerve. That cranial nerve is known as spinal accessory nerve. Okay, so trapezius, which is supplied by spinal accessory nerve. Okay, one of the component of accessory nerve, 11th cranial nerve, spinal accessory nerve. Then what are the actions of trapezius? Trapezius, which is used for overhead abduction. Abduction of shoulder joint, very important. From beginning, we can repeat first 15 degrees. Go to 15 degree abduction of shoulder joint. First 15 degree abduction is caused by supraspinatus cell. First 15 degree is caused by supraspinatus muscle. We will come to supraspinatus muscle later. Okay, first 15 degree supraspinatus. Then 15 to 90 degree is caused by deltoid muscle. Then overhead abduction above 90 degree. Okay, above 90 degree overhead abduction, that is done by two muscle. One muscle is trapezius. Another one muscle is serratus anterior. Please remember, that is very important. One more muscle is serratus anterior. Okay, so these are the muscle used for abduction of our shoulder joint. So the next one is serratus anterior muscle. Excuse me. One more muscle is serratus anterior muscle. Okay, so here please remember, first 15 degree, that muscle is supraspinatus. 15 to 90 degree caused by deltoid. Then 90 degree overhead abduction, that is done by the first muscle trapezius. Another one muscle serratus anterior. Then one more very important point additional to that, scapulohumeral rhythm. What is the normal scapulohumeral rhythm? If scapula move 1 degree, mean clavicle move 2 degree. Okay, for each degree movement of scapula, humerus will move 2 degree. So that is known as scapulohumeral rhythm. Okay, so these are the 5 factors very important for abduction of our shoulder joint. Okay, first 15 degree supraspinatus, 15 to 90 degree deltoid muscle, overhead abduction 90 degree and above, trapezius muscle as well as serratus anterior. Then additionally scapulohumeral rhythm. What is the normal thing? Scapula, if it is moving 1 degree, mean humerus will move 2 degree. So that is scapulohumeral rhythm. So these are the points are important. Trapezius muscle is supplied by spinal accessory nerve. Shrugging muscle is supplied by spinal accessory nerve. What is the action? Overhead abduction. Okay, so in case of any lesion to the spinal accessory nerve, trapezius muscle will be paralyzed. So at that time, abduction difficulty will be there. Then partial winging of scapula. I will show you the picture. Winging of scapula. Winging of scapula is mainly a characteristic feature of serratus anterior palsy. Serratus anterior muscle, if it is paralyzed, mean that will lead to winging of scapula. But a trapezius also can cause winging of scapula. We have to remember that. But full winging of scapula is seen in serratus anterior. That is followed by trapezius, partial winging of scapula. We will come to that next one. So here, just now we finished trapezius, the now action, everything over. The trapezius is also known as shrugging muscle. Little bit below here, we can see the latissimus dorsi. Latissimus dorsi, also known as climbing muscle. Latissimus dorsi, also known as climbing muscle. This is supplied by spinal accessory nerve. But here, latissimus dorsi is supplied by thoracodorsal nerve. Thoracodorsal nerve. Okay, so here we have to remember climbing muscle as well as thoracodorsal muscle. Then this small triangle above trapezius, below latissimus dorsi, laterally scapula. Okay, so here it is forming one small triangle. Here trapezius, below latissimus dorsi, laterally here scapula. So this triangle is known as triangle of auscultation. Triangle of auscultation. Okay, so here trapezius over latissimus dorsi, then outside is thoracodorsal nerve. Then here, still deep, there are three muscles are there. One is levator scapulae, another one is rhomboides minor, another one is rhomboides major. Rhomboides as well as levator scapulae. All the three muscles are supplied by dorsal scapular nerve. All the three supplied by dorsal scapular nerve. Okay, so pectoralis major, minor, muscles of back, their nerve supply we have completed. Okay, so little bit deep, we have to know about rotator cuff muscle. Rotator cuff muscle. So here, this is anterior view of scapula. Here, posterior view of scapula. Anterior view, posterior view. Anterior view of scapula. Here, from the anterior aspect, one muscle is originating. That muscle is known as subscapularis. That muscle is known as subscapularis. So subscapularis, from where it is originating? It is originating from anterior aspect of here, from the here. Anterior aspect of scapula, then it is inserted into humerus. This is known as lesser tubercle of humerus. Lesser tubercle of humerus. This is muscle number 1, forming the rotator cuff muscle. What are the muscles forming rotator cuff? First muscle is subscapularis. Then if you rotate here, scapula behind, here 3 muscles originating. Here, this muscle is known as, just now we have completed the muscle causing first 15-degree abduction. It is known as supraspinatus. Below, this muscle is known as infraspinatus. Here, see, infraspinatus. Then one more muscle, teres minor. Teres minor. So these are the 4 muscles collectively. Muscle number 1, subscapularis. Muscle number 2, infraspinatus. Muscle number 3, supraspinatus. Muscle number 4, not teres major, teres minor. These are the 4 muscle for mainly maintaining the stability of shoulder joint. Okay, very close. I mean, it is providing stability to the shoulder joint. So these are the 4 muscles are known as rotator cuff muscle. Rotator cuff muscle. What are the muscles are known as rotator cuff muscle? Sometimes they will give teres major, but a teres major not forming rotator cuff, only teres minor. Okay, so here itself we can complete the nerve supply. Supraspinatus, infraspinatus. So here there are 4 components. Just now one is supraspinatus, another one is infraspinatus. Supraspinatus, infraspinatus, both are supplied by suprascapular nerve. Both are supplied by suprascapular nerve. So supraspinatus muscle is the initiation of abduction of shoulder joint. So the nerve, which nerve is responsible for that? Suprascapular nerve. Suprascapular nerve. So shortly we are going to discuss Erb's palsy. In Erb's palsy, suprascapular nerve will be paralyzed. If suprascapular nerve is paralyzed, mean supraspinatus gone. Supraspinatus gone mean initiation of abduction is not possible. So abduction is lost. So that will leads to Erb's palsy. The final position is adduction of shoulder joint because opposite action. So abduction gone. So adduction will that action will that will become dominant. So Erb's palsy, adduction of shoulder joint or arm seen. That the reason is suprascapular nerve gone. So supraspinatus, infraspinatus, both are supplied by suprascapular nerve. Suprascapular nerve. Then if you come subscapularis muscle. Subscapularis muscle. So subscapularis, which is supplied by upper and lower subscapular nerve. So scapularis, which is supplied by, there are 2 other nerve, upper and lower subscapular nerve. Upper and lower subscapular nerve. Here, the very important one, teres minor nerve supply. Okay, only 2 axillary nerve, the root value is 5. The root value is going to is going by teres minor. Teres minor. teres minor is
Sir, audio not audio is
Hello?
breaking.
Can you hear, ma'am?
Yes, sir. Yes, sir.
Ma'am, please check your net connection.
Okay, sir.
Okay. Okay. Others, can you hear me?
Your voice is breaking, sir.
Voice breaking only. Okay. So if again this problem occurs, please let me know. Okay. So I'm going to continue. So axillary nerve, which is going to supply two muscle. One is deltoid, another one is teres minor. Then here one of the common doubt is the nerve to
The audio not clear, sir.
okay. So slowly I'm going to continue. Okay, we will check. Maybe
Yes,
network
sir.
issue. Okay. So the next muscle, teres major muscle. Next muscle, teres major muscle. So teres major muscle, what is the nerve supply? What is the nerve supply? So teres major is supplied by lower subscapular nerve. Lower scapular nerve. Very important. Always will give confusion. So teres minor is supplied by axillary. Teres major is supplied by lower subscapular nerve. Teres major not a component of rotator cuff. Which is the component of rotator cuff? Teres minor is a component of rotator cuff. So we have to remember that. Supraspinatus, infraspinatus, both are supplied by suprascapular nerve. Suprascapular nerve. What is the root value for suprascapular nerve? Axillary nerve, suprascapular nerve, both are the root value is C5, C6 only. C5, C6 only. Okay, so these are the muscles are rotator cuff muscle. We'll move to the next. Here, deltoid, the one more muscle, deltoid. Okay, so the rounded contour of shoulder joint. So here, you can see the deltoid, rounded contour of shoulder joint. Shoulder is mainly because of deltoid. In deltoid, it is one of the classical example of multipennate muscle. Multipennate muscle. One of the example for multipennate muscle. Here we can see it very clearly. It is originating from clavicle, which is originating from here scapula, acromion process, as well as spinous process of scapula. So continuous origin, clavicle, acromion process, as well as spinous process. After that, the muscle which is converging down and inserted into humerus. Humerus. This point is known as deltoid tuberosity. Point is deltoid tuberosity. Here, what is the nerve supply? It is supplied by again axillary nerve. Axillary nerve. So axillary nerve, the root value is C5, C6. Axillary nerve, which is going to innervate two muscle. Muscle number 1, deltoid. Muscle number 2, teres minor. Muscle number 2, teres minor. Teres major is supplied by lower subscapular nerve. Okay, subscapular is supplied by upper and lower subscapular nerve. Then suprascapular nerve going to supply two muscles, supraspinatus, infraspinatus. Then one muscles of back is supplied by cranial nerve, that is spinal accessory nerve. Then thoracodorsal nerve, which is going to supply climbing muscle, latissimus dorsi. Then dorsal scapular nerve, which is going to innervate a rhomboids minor, major. Another one is levator scapulae. Levator scapulae. Then pectoralis major is supplied by both medial pectoral nerve as well as lateral pectoral nerve. But pectoralis minor is only supplied by medial pectoral nerve. Pectoralis minor going to divide the axillary artery into 3 parts. Then clavipectoral fascia is pierced by cephalic vein. Another one is lateral pectoral nerve, thoracoacromial artery. So these are the points, very, very important. Then serratus anterior muscle. After removing all the muscle here, serratus anterior muscle originating as A digitation from the ribs, A digitation. After that, so it is originating from 8 rib as 8 digitation, then inserted into scapula. Inserted into scapula. So here, this muscle is very, very also known as boxer's muscle. This muscle is known as boxer's muscle because by using this muscle only, scapula moving forward. Okay, punching action, scapula moving forward, boxer's muscle. So 3 muscle. One is shrugging muscle, another one is climbing muscle, another one is boxer's muscle. This boxer muscle, serratus anterior, is supplied by long thoracic nerve of bell, long thoracic nerve of bell, or nerve to serratus anterior. Nerve to serratus anterior. Again, I am repeating, Abduction of shoulder joint is very, very important. First 15 degree supraspinatus muscle until 90 degree, 15 to 90 degree deltoid. After that, 90 to 180 degree caused by two muscle. One of the muscle is this serratus anterior muscle. Another one muscle is trapezius muscle. Okay. So serratus anterior gone mean abduction problem or difficulty in abduction, not complete loss. Difficulty will be there. Okay. So here winging of scapula. So here see medial border of scapula become prominent. We have to ask the patient to push against wall, give the pressure against wall. At that time, here scapula medial border become prominent. So this is known as winging of scapula. Winging of scapula, complete winging of scapula seen in serratus anterior palsy. In case of trapezius also partial winging seen. Partial winging that is possible in trapezius palsy. Trapezius palsy. Okay, so we can move to the next arm region. Arm region, totally three muscles we are able to see. Here, the first muscle, front of arm. Here, biceps. Biceps. Okay, so the biceps, it will perform two functions. One is flexion. Another one is the very, very important function, supination. Supination of forearm. So this one we will miss. Supination of forearm. Supination of forearm. So it will perform two important functions. One is flexion, another one is supination. Another one is supination. So these are the two action which is caused by biceps muscle, which is originating as two head. One is long head, another one is short head. Short head which is originating from coracoid process. The same coracoid process only receiving pectoralis minor muscle insertion. Pectoralis minor muscle. So the first muscle, biceps, it is performing two important functions. If we remove this biceps, we can see the next immediately coracobrachialis, one more muscle, another one muscle, deepest muscle, that is brachialis. So front of arm totally contain three important muscle. One is biceps, another one is coracobrachialis, another one is brachialis. All the three muscles are supplied by musculocutaneous nerve. Deltoid teres minor is supplied by axillary nerve, root value is C5, C6. Here musculocutaneous nerve. Okay, front of arm, which is supplied by musculocutaneous nerve. The root value is C5, C6, C7. C5, C6, C7, which is going to supply three muscle. Muscle number one, biceps. Muscle number two, coracobrachialis. Muscle number three, brachialis. All the three muscles are supplied by the musculocutaneous nerve. Then very important thing, musculocutaneous nerve piercing one muscle. That muscle is coracobrachialis. During this course, coracobrachialis muscle is pierced by which nerve? That is pierced by musculocutaneous nerve. So here we can see the coraco. So here this is coracobrachialis muscle. So musculocutaneous nerve is piercing and coming down. It is supplying biceps, it is supplying brachialis. After supplying all the thing, it is going to continue down as lateral cutaneous nerve of forearm. Lateral cutaneous nerve of forearm is a branch of lateral cutaneous nerve of forearm. Lateral aspect. So here you can see the forearm. So this is the lateral aspect of forearm. Lateral aspect of forearm. This is medial aspect of forearm. So lateral aspect of forearm is supplied by lateral cutaneous nerve of forearm. Lateral cutaneous nerve of forearm is not a direct branch of brachial plexus. It is a continuity of musculocutaneous nerve. So only it is going to supply the some muscle. So musculo is also innervating skin. So cutaneous, musculocutaneous nerve. The root value is C5, C6, C7. We can move to the next. Back of forearm, triceps muscle we are able to see. Triceps totally three heads. Okay, long head, medial head, and lateral head. So three heads are there. So it is known as triceps. The triceps is supplied by radial nerve. Triceps is supplied by radial nerve. So axillary nerve, 5, C6 is a root value. Musculocutaneous nerve, C5, C6, C7 is a root value. Radial nerve, so is the root value is C5, C6, C7, C8, and T1. C5 to T1 continues. Okay, so this is the largest branch of brachial plexus. Which is the largest branch of brachial plexus? Radial nerve is the largest branch of brachial plexus. Okay, so biceps, that will biceps, brachialis all will perform flexion of elbow joint, but this triceps will extension of elbow joint, that is controlled by or supplied by radial nerve. Additionally, we have to remember biceps is additionally performing supination. Additionally performing supination. Okay, so here some of the scapular intermuscular spaces we have to know. Scapular intermuscular spaces. Okay, so here this is scapula, which is articulating with humerus. So here there are three muscles. One muscle, this is long head of triceps. Long head of, just now we have seen. So this muscle is long head of triceps. See here, this muscle is triceps. Then here there are two other muscle. This muscle is teres minor. So here we can see teres minor, teres minor. Here teres major. Okay. So this muscle is teres minor, teres minor. This muscle is long head of triceps. Then one more muscle here. This muscle is teres major. Teres major. So by using these three muscle, we will get three spaces. Okay. So here there are four boundary here. So this space is known as quadrangular space. Quadrangular space. So the quadrangular space boundary, very easily we can tell above teres minor, below teres major. Then one side long head of triceps, one side humerus. The content is very important. Quadrangular space mainly contains the axillary nerve. Axillary nerve is a content of quadrangular space. Axillary nerve is a content of quadrangular space. Then which is accompanied by one more artery. That artery is posterior circumflex humeral artery. That artery is posterior circumflex humeral artery. Very important, not anterior. So axillary nerve and posterior circumflex humeral, because it is binding around the surgical neck of humerus. So posterior circumflex humeral artery. Okay, posterior circumflex humeral artery as well as axillary nerve. So these are the structure. One is axillary nerve, posterior circumflex humeral artery. Both are content of quadrangular space. Very, very important. Quadrangular space. So axillary nerve immediately lies below the head. So here, head of humerus we can see immediately below the head axillary nerve is present. So in case of shoulder subluxation, axillary nerve is easily damaged one because it lies very close to head. So if it is dislocation taking place, mean axillary nerve will be compressed, axillary nerve palsy will taking place. So axillary nerve, posterior circumflex humeral vessel, both are content of quadrangular space. Then another one is here we can see one more triangular interval. Before that, that is quadrangular, rectangular in shape. Now this is triangular in shape. So this is lower triangular space. This one is known as upper triangular space. There are two things. This is upper triangular space. This one is known as lower triangular space. Out of that, lower triangular space is very, very important. This lower triangular space, it will transmit radial nerve. Radial nerve. So lower triangular space, what are the structure? One is radial nerve. So here it's mentioned one is radial nerve. Another one is profunda brachii vessel. So profunda brachii vessel, radial nerve. Both are passing through lower triangular space. Quadrangular space transmit axillary nerve, posterior circumflex humeral. Then upper triangular, we can complete. It will transmit the circumflex scapula. It will transmit what? Circumflex scapula. So these are the we have to know. So boundary, more than boundary, the things are very important.
Sir, audio breaking, sir.
Okay, so quadrangular space which contain axillary, lower triangular space which is containing radial nerve. Is it clear now, ma'am? Is it
Yes,
audible?
sir. Yes, sir. Yes, sir.
Then let us move on to one more important area. It is cubital fossa. So cubital fossa, where it is located? Cubital fossa, totally the boundaries are important. Cubital fossa boundaries are important. Contents are important. Boundaries are important. Contents are important. Floor also you have to know. Roof structure. Totally 4 structure we have to remember. The content, the very important one. Out of all the things, content, the very important mnemonic is MBBS. The mnemonic is MBBS. Okay. So here we can see in front of elbow joint, cubital fossa is present. So cubital fossa, this is medial side. This is medial side. This is lateral side. Medial side, this muscle is known as pronator teres. So one of the forearm muscle, pronator teres. So medially it is bounded by pronator teres. Laterally it is bounded by radialis. These two very important landmarks. Okay. So cubital fossa, this side pronator teres muscle, this side brachioradialis. Then base line connect to epicondyle, medial epicondyle as well as lateral epicondyle. So collectively forming one triangle. The triangle is known as cubital fossa. Okay, so medially pronator arteries, laterally brachioradialis. So this is the boundary. The content medial to laterally, the mnemonic is MBBS. MBBS. M for medial nerve. M for medial nerve. So here we can see the median nerve. So medial most content is medial nerve. Next to medial nerve, we can see brachial artery. Brachial artery. So here we can see the median nerve, we can see the brachial artery. Then still lateral to brachial artery, we can see the one more thing is tendon. Tendon. So this one is biceps. This one is biceps tendon. Biceps tendon. Then lateral more one is radial nerve, but not complete radial nerve. Superficial branch of radial. Superficial branch of radial nerve. Superficial branch of radial nerve. So here superficial branch of radial nerve. Okay, so these are the four content: boundary over, content over. So boundary pronator arteries brachioradialis, content MBBS. Floor, please remember the deepest two muscle. One is brachialis. One is brachialis muscle forming the brachialis muscle forming the floor. Another one muscle supinator. Another one muscle is supinator. So brachialis supinator, both are forming the floor. Both are forming the floor. Here, the roof. So this picture roof. This picture are roof. What are so here the cephalic vein, lateral forearm, cephalic vein, medial aspect, basilic vein. So,
Sir, I think so. Your headset or
sorry, ma'am.
something is not. Sir, I think so. Your mic is not working, sir.
Still
While
problem
writing,
is there, huh?
while writing, you're blocking the mic, I think, sir. Your voice is not clear.
Okay. Which camera is working? Now, I couldn't இல்ல picture is not so important, sir. Picture வேண்டியது நீங்க எனக்கு இப்ப content நம்ம எழுதுறதுக்கு ஃப்ரீயா இருக்கணும். That is important. Yeah. Okay, so here the roof, one is cephalic vein, another one is basilic vein. Both are connected to median cubital vein. Median cubital vein. Three veins are there: cephalic vein, basilic vein, medial cubital vein. Then two other cutaneous nerve. Here one cutaneous nerve on the lateral aspect, that is lateral cutaneous nerve of forearm. Here one more cutaneous nerve is medial cutaneous nerve of forearm. Here medial cutaneous nerve of forearm is a branch of brachial plexus, but lateral cutaneous nerve of forearm is a branch of musculocutaneous nerve. That is a branch of musculocutaneous nerve. Musculocutaneous nerve. So regarding cubital fossa, these are the points we have to remember. Then let us move on to brachial plexus. So brachial plexus here, it is formed by totally 5 roots: C5, C6, C7, C8, another one is C1. So these are the 5 roots. Out of that, C5, C6 join together and form one trunk, that is upper trunk. C7, which is going to continue, so this is upper trunk. C7, which is going to continue as middle trunk. Then C8 and T1 immediately join together and form lower trunk. So here, these are the levels are known as roots. These are the levels are known as trunk. These are the levels are known as trunk. Immediately, all the trunk divided into anterior, posterior. All the trunk divided into anterior, posterior. Out of that, here, all the posterior of upper trunk, posterior of middle trunk, posterior of lower trunk join together and form one cord. That cord is known as posterior cord. Okay. Then remaining. So this is posterior, all the posterior division. So this level is known as division. This level is known as division. Then next level is known as cord. Okay. So first root, then roots are joined together forming trunk. Then trunk are divided into division. Division, here all the posterior join together and form posterior cord. Like that, anterior division of upper trunk, anterior division of middle trunk join together and form lateral cord. Then anterior division of lower trunk, which is going to continue as lateral cord, posterior cord. Another one is medial cord. Medial cord. Okay. So like this, all the cords are formed. Now, which level there is no branches given? In division level, there are no branches. Brachial plexus never give any branch in division level. Is in root level, is it giving any branch? Yes. In root level, C5 root, dorsal scapular nerve. So dorsal scapular nerve. So which is the which is the branch of root of brachial plexus? Like that question can come. So dorsal scapular nerve. What is the root? So C5 is giving one root, that is dorsal scapular nerve. Then like that is C5, C6, C7. All the three join together forming one nerve. That nerve is known as, just now we have discussed, long thoracic nerve of Bell, which is going to supply the serratus anterior muscle, long thoracic nerve of Bell. So please remember, dorsal scapular nerve, long thoracic nerve of Bell, both are branches of root. Both are branches of root. Let us move on to next one, trunk. Trunk level, upper trunk, middle trunk, lower trunk. Out of that, upper trunk giving two branches. One is above, another one is below. The upper one. So the upper one, here see, known as suprascapular nerve. That is known as suprascapular nerve. Okay. Lower is known as nerve to sclavia. The suprascapular nerve only going to supraspinatus muscle, infraspinatus muscle. We have discussed already. This dorsal scapular is from not track, it is originated from root. It is originated from root, C5 root. It is when C levator scapulae, rhomboid is minor.
Audio not audible.
Rhomboid is minor. Another one is rhomboid is major. There are three muscles between dorsal scapular nerve. Long thoracic nerve is going to supply serratus anterior, which is going to supply serratus anterior. Now to subclavius is going to subclavius. Here one more information. Now to can give accessory phrenic nerve. Accessory phrenic nerve is a branch of. So here accessory phrenic nerve is a branch of. Accessory phrenic nerve is a branch of now to subclavius. Then middle trunk never give any branch. Lower trunk never give any branch. Division level no branch. All came. So division
Sir,
level.
voice not audible.
Ma'am, I think network issue, madam. So then next, let us move on to the cord. Cord, the very important, now I'm going to tell lateral cord. The main nerve is musculocutaneous nerve. So here lateral cord, the very important nerve is musculocutaneous nerve. Musculocutaneous nerve, which is coming from lateral cord, very important one. Then this posterior cord, very important nerve, axillary radial. Axillary radial. Okay. In your notes, I mean, completely we will give all the thing. But here, the very important one, lateral cord giving musculocutaneous nerve. Here, your this thing, I mean, posterior cord, which is going to give, one is axillary nerve, another one is radial nerve, another one is radial nerve. Then medial cord, which is going to give ulnar nerve. Medial cord, which is going to give ulnar nerve. So here, again, shortly, join together, coming front, here, subfront being suprascapular nerve, now to subclavian, now to subclavian. Okay? So here, in case of any, it is
Sir, voice is not audible, sir. So one suggestion, sir, like maybe while writing, you're blocking the mic, I think so, sir. Not sure.
no, sir, I'm not blocking here.
While writing alone, we cannot able to hear you, sir.
Okay, okay. Okay, if it continue, please let me know. Okay, so one time we can try. So here, Erb's palsy mean, I mean, injury to the upper trunk is point is known as Erb's point. Here, this point, this region, this point is known as Erb's point. Erb's point. Okay, so here totally C5 came here, C6 came here. It is giving origin to suprascapular nerve. So here, this Erb's point usually contains C5 fiber as well as C6 fiber. Okay, so here this is C5, C6, both fibers are coming to the upper trunk. So this point is Erb's point. Erb's point. So here, in case of any injury to this upper trunk, it will lead to Erb's palsy. It will lead to palsy. That palsy is as Erb's palsy. In Erb's palsy, I mean, fibers are C5, C6 fibers are. What are the nerves mainly in C5, C6? Think there are two nerves mainly formed by C5, C6. One is axillary nerve. The root value is C5, C6. Another one is musculocutaneous nerve. Musculocutaneous nerve. So for this also root value mainly C5, C6, C7. So C5, C6, axillary nerve also C5, C6. Erb's point, the mainly C5 as well as C6 fiber is affected. Then one more thing here, one more nerve is suprascapular nerve. So these are the three nerve mainly affected. Just think, suprascapular nerve. It is going to supply what are the muscle? So what are the muscle? Yeah, what is Erb's palsy? Erb's palsy means injury to the upper trunk. Injury to the upper trunk. What are the fibers are affected? C5, C6 fiber. What are the nerves mainly formed by C5, C6? Three nerve mainly formed by C5, C6. What are the three main nerve? Axillary nerve, musculocutaneous nerve, suprascapular nerve. Mainly formed by C5, C6. Suprascapular nerve going to innervate what are the muscle? Suprascapular nerve, which is going to innervate supraspinatus muscle. Supraspinatus muscle. Supraspinatus for what it is important? Abduction of shoulder joint is important. So in Erb's palsy, abduction of shoulder joint will be gone. Yes, abduction of shoulder joint will be gone. Then one more muscle, one more nerve, axillary nerve. Axillary nerve root value is C6, which is to innervate deltoid. Deltoid also very, very important for abduction of shoulder joint. So this is also causing abduction of shoulder joint. Yes. This is also causing abduction of shoulder joint. Yes. So abduction of shoulder joint is not possible. Yes. So adduction of shoulder will become prominent. Yes. So here see, Erb's palsy, completely adduction of shoulder joint. Completely adduction of shoulder joint. Adduction of shoulder joint, we able to see. Okay. Then one more thing, musculocutaneous nerve. Just now we have seen musculocutaneous nerve is going to supply biceps, brachialis. Another one is brachialis. Another one is brachialis. So these are the three muscles are mainly supplied by musculocutaneous nerve. So all the muscles are gone. So biceps, brachialis, everything paralyzed. So what will happen? Flexion of arm is not possible because these are flexors. Okay. flexion of arm not possible. So triceps become dominant. So what will happen? Extension of forearm. Extension of forearm. So first adduction of shoulder joint, second extension of forearm. Then already we have discussed the biceps. It will perform additional to this thing flexion. It will produce supination. So supination also gone. So what will happen? Pronation. It will become dominant. Pronation of forearm. Pronation of forearm. So here see, here you can see adduction. Here we can see extension. Here we can see pronation. Pronation. All are characteristic features of Erb's palsy where injury is taking place, upper trunk injury is taking place. Like that, one more thing, lower trunk any injury is known as clump is paralysis. Clump is paralysis. Injury to the upper trunk is paralysis, but the nerves affected is a clinical outcome. Okay, adducted shoulder joint, elbow, pronated forearm. Then clump is paralysis, lower trunk is secured, lower trunk is fiber, T1 fiber. C8 and T1 mainly going to supply hand muscle. So if clump is paralysis, hand muscle means will lead to claw hand. That will lead to claw hand. Okay. So person fingers will be flexed. Claw hand. So clump is paralysis. One of the clinical outcome is claw hand. Erb's palsy clinical outcome already we have discussed. Then one more thing, T1 fiber also T1 root also carrying sympathetic. So in clump is paralysis, that sympathetic tract also gone. That will lead to Horner syndrome. So Horner syndrome, claw hand, both are characteristic feature of clump is paralysis. What are the component of Horner syndrome? Meiosis, anhydrosis, ptosis. So there are three things. So here Horner syndrome meaning meiosis can see, anhydrosis can see, hydrosis can see. I mean loss of hydrosis can see. Then another one is
Sir, audio not.
Another one is meiosis, anhydrosis. Another one is ptosis. Okay, so claw hand and Horner syndrome both are seen in clump palsy. Erb's palsy mainly, I mean adducted shoulder joint, extended elbow, pronated forearm. So this is about the brachial plexus. Let us move on to one of the important nerve is radial nerve. That nerve is radial nerve. Okay? Radial nerve. What are the points are important? Radial nerve. This is the largest branch of brachial plexus. So this is the largest branch. Largest branch of brachial plexus. So here radial nerve first. So here it is descending down. When it is descending down in the axilla, here itself, the axilla is the level at what level it is supplying, very important. So triceps is going to supply axilla. So maximum at the level of axilla itself, it will supply triceps. Then at one point it is crossing the humerus. So here there is a groove. That groove is known as spiral groove. The groove is known as spiral groove. Groove is spiral groove. In spiral groove, it is going to supply one muscle. Muscle is known as unconeus. That muscle is known as unconeus. The second one. Then third, very important. So by using this only, many things came. Here is level of elbow. Above the level of elbow, here this is trunk of radial nerve. Here it is supplying two muscles of forearm. So in arm itself, it is going to supply two muscles of forearm. One is brachioradialis, another one is extensor carpi radialis longus. In arm itself, it is going to supply three forearm muscle. We have to remember that in arm itself, when it is descending down, so it is a content of spiral groove. Radial nerve, it is going through lower triangular space. Already we have discussed, it is a content of spiral groove. Then in axilla, it is supplying triceps. In spiral groove, it is supplying unconeus. Unconeus is one of the forearm muscle. Then before crossing elbow, it is also supplying. So already spiral supplied unconeus. Now it is going to supply brachioradial. Another one muscle extensor carpi radialis longus. So here, for example, if this is elbow level mean radial nerve is coming, Above the elbow itself, it is supplying unconeus. Properly unconeus, it is received its supply at spiral groove. At the spiral groove. Then before crossing elbow, it is supplying two other muscle. Brachioradialis muscle. Brachioradialis muscle. Another one is known as extensor carpi radialis longus. Then after crossing elbow, it is divided into superficial branch, deep branch. Deep branch is known as posterior intraosseous nerve. Posterior intraosseous nerve. Deep branch is known as posterior intraosseous nerve. It is going to supply all the other forearm muscle. Okay. Posterior and here question is all the muscles of back of forearm is supplied by posterior intraosseous nerve except three muscle. What are the three muscle? One is unconeus, another one is brachioradialis, another one is extensor carpi radialis longus. Because extensor carpi radialis longus, brachioradialis, unconeus, all are not supplied by posterior intraosseous nerve. It is supplied by trunk of radial nerve. It is very, very important. Because why this is important? In case of posterior intraosseous nerve injury, okay, is wrist drop taking place or not? Like that question will come. Okay, so here, what is this? Superficial branch. Superficial branch which is going to innervate the dorsum of hand. Okay, sensory innervation. See, here there are so many muscles are there. Okay, out of that, this muscle is brachioradialis, which is supplied by trunk of radial nerve. Trunk. Then this is extensor carpi radialis longus. This picture is back of forearm. So this is also supplied by trunk of radial nerve. Okay. Then here this muscle is unconeus. This is also supplied by trunk of radial nerve. Unconeus. These are the three muscles only supplied by trunk of radial nerve. All the other, whatever it is. Okay. So here there are extensor digitorum, extensor digite minime, extensor carpi. So there are so many muscles. Everything is supplied by posterior intraosseous nerve. Everything is supplied by posterior intraosseous nerve. Okay. So here, then one more thing. It is also giving superficial branch. The superficial branch, which is we will come during ulnar nerve and median nerve this area. Here on the dorsal aspect, sensory supply is provided by superficial branch of radial nerve. Okay. So here, this is extensor muscles of forearm. We can be able to see here extensor muscles of forearm. Extensor muscles of forearm. This extensor muscle mainly used for like this. So this is extension of shoulder joint. Sorry, extension of elbow joint. So by using this extensor muscle, we can extend the elbow joint. In case of any lesion to the posterior intraosseous nerve or radial nerve, that will lead to wrist drop. Wrist drop. Here, one thing we have to remember: if radial nerve is injured, mean complete wrist drop is possible. Radial nerve is injured, mean complete wrist drop is possible. But posterior intraosseous nerve, if it is injured, mean complete wrist drop is not possible. Because here posterior intraosseous nerve, below the elbow only lesion, posterior intraosseous nerve. Still, three muscles can be supplied by what are the three muscles? Radial nerve, brachioradialis, another one is extensor radialis longus. So complete wrist drop is possible only in trunk of radial nerve injury, not intraosseous injury. Posterior intraosseous nerve injury, weakness in extension seen, but wrist drop only seen in trunk. Wrist drop only seen in trunk of radial nerve injury. Okay, so we have to remember that point. So various level, origin, muscle supply, we have to know. What are the other thing? One is crutch palsy. Crutch palsy means axilla. So compression of the nerve when we walk with prolonged walking with crutches. So that is crutch palsy. So crutch palsy, axilla itself compression is taking place. So for example, just to see in the axilla, it is giving which muscle? Triceps. Triceps. Then spiral groove, it is giving unconeus. Below it is giving brachioradialis. Then it is giving extensor carpi radialis longus. Then it is divided into two branches. It is going to supply skin. Then this is posterior intraosseous nerve, which is going to supply all the other muscles of forearm. Here compression is taking place, mean complete radial nerve gone. Crutch palsy. What are the muscles are paralyzed? Triceps gone. Triceps gone mean extension not possible. So what will taking place? Flexion. In this way we have to remember. Clutch palsy only, complete lesion of radial nerve. Then brachioradialis gone, extensor carpi radialis gone. So here is compression. So posterior intraosseous nerve also gone. So entire forearm gone. That will lead to. So here flexion of elbow joint, wrist drop. Wrist drop. Then here nerve also, superficial nerve also gone. So that will lead to what is that? Sensory loss on the dorsum of hand. So crutch palsy, how many characteristic feature? Because triceps paralyzed, what will taking place? Biceps overaction, so flexion of elbow joint. Then second one is wrist drop. Third one is sensory loss on the dorsum of hand. So all are characteristic features of crutch palsy. But posterior intraosseous nerve injury, it will cause only weakness in extension, not wrist drop. So this differentiation, various levels supply, we have to know. So if we know the proper level of supply, I mean, we can answer any type of clinical question. Then let us move on to next nerve, that is median nerve. Median nerve. Okay. So the median nerve, we have discussed median nerve. Yeah, it is descending down through the arm, front of our arm. It is very close to brachial artery. So here see, brachial artery, we are able to see. Initially, it lies lateral to brachial artery. Median nerve lies lateral to brachial artery, but when it is descending down, so if this is brachial artery, median nerve initially lies laterally, then it is crossing the brachial artery, then coming medially, then enter into cubital fossa. So brachial artery is crossed by median nerve. After that, it enter into cubital fossa. Cubital fossa already we have discussed. MBBS. So medial most content is median nerve, then brachial artery, then biceps tendon, superficial branch of radial nerve. Okay. Then this median nerve, okay, when it is descending down, so in the course, median nerve is coming down. This is level of elbow joint. In arm, it is not having any branch. After that, it enter into forearm. In forearm, totally front of forearm, totally 8 muscles are there. 8 muscles are there. Okay. The 8 muscle is paired by 2 nerve. One is median nerve, is going to supply 6.5 muscle. Remaining 1.5 muscle is supplied by ulnar nerve. So median nerve, another one is ulnar nerve. Both are going to supply total muscles of front of forearm. What are the muscles? The pronator tibialis. What is the nerve? Median nerve. Pronator tibialis, median nerve. Okay. Flexor carpi radius. Median nerve. Palmar is
Sir, audio breaking, sir.
Ma'am, is it audible now?
Yes,
Ma'am,
sir.
audible now? Yeah. So here, pronator teres, flexor carpi radialis, palmaris longus, all are supplied by median nerve. So here in forearm, just to remember what are the things are supplied by ulnar nerve. Ulnar nerve, then remaining things are supplied by median nerve. We can answer very easily. Okay. So ulnar nerve, which is going to supply 2 muscle. One muscle is flexor carpi ulnaris. One is flexor carpi ulnaris. So ulnar nerve, ulnar side, flexor carpi ulnaris, muscle number 1. Then second muscle, that is flexor digitorum profundus. It is a hybrid muscle, which is off muscle is supplied by ulnar nerve, off by ulnar nerve, off by median nerve. So what are the muscles of front of forearm? Front of forearm, so many muscles are there. Please remember ulnar nerve. Other things are supplied by median nerve. Ulnar nerve, what are the muscles of front of forearm is supplied by this thing? Flexor carpi ulnaris. Flexor carpi ulnaris is supplied by which nerve? It is supplied by ulnar nerve. One more thing, if you remove all superficial muscle, deep muscle, flexor digitorum, not superficialis, flexor digitorum profundus. Medial half of flexor digitorum profundus. So these 1.5 muscle is supplied by ulnar nerve. Remaining all the 6.5 muscle in the sense of pronator teres, flexor carpi radialis, palmaris longus, flexor digitorum profundus, flexor pollicis longus, okay, pronator quadratus, whatever it is supplied by median nerve. Remaining 1.5 muscle is supplied by ulnar nerve. So this thing we have to know. Then one more thing, median nerve, like radial nerve giving posterior intraosseous nerve, median nerve itself giving one branch. That branch is known as anterior intraosseous nerve. The name is anterior intraosseous nerve. This anterior intraosseous nerve going to innervate. Sometimes questions come. Anterior intraosseous nerve. Anterior intraosseous nerve innervating. I mean, that is itself a branch of median nerve. Anterior intraosseous nerve innervating 3 muscle. One is pronator quadratus. One muscle is pronator quadratus. Second muscle is flexor pollicis longus. Then third muscle is flexor digitorum profundus off, because remaining off already supplied by ulnar nerve. So please remember, forearm contain, front of forearm contain 8 muscle, 6.5 muscle supplied by median nerve. In median nerve also 2.5 muscle that is supplied by anterior intraosseous nerve. Okay, deepest muscles. What are the three deepest muscle? Here we can't see pronator quadratus because it lies deeply. Pronator quadratus, flexor pollicis longus, flexor digitorum profundus. These three supplied by anterior intraosseous nerve. What are the muscles are supplied by ulnar nerve? Flexor carpi ulnaris, then medial half of flexor digitorum profundus. So these are the things we have to know. So median nerve totally supplying 6.5 muscle in forearm. 6.5 muscle in forearm. Radial nerve already we have completed. So in forearm, median nerve going to supply 6.5 muscle. Then in hand, totally 20 muscles present. In hand, totally 20 muscle present. Out of 20, median nerve going to supply only 5. Median nerve going to supply only 5. What are 5? It is going to supply this eminence. That eminence is known as thenar eminence. Okay, close to the base of the thumb. That eminence, that elevation is known as thenar eminence. Here it is going to abductor, flexor, these are the three muscle. Okay, so pollicis. So this is thenar eminence. Here hypothenar eminence. Thenar eminence totally three muscles: opponens pollicis, abductor pollicis, flexor pollicis brevis. Okay, so these are the three other muscles. Three other muscles are supplied by. So in forearm, totally 20 muscle. Here in in forearm, please remember what are the muscles are supplied by ulnar nerve. Only two supplied by ulnar nerve. One is flexor carpi ulnaris, another one is medial half of profundus. Then in hand, totally 20 muscle. Out of that, minimum number you remember. So how many muscles are supplied by median nerve? The thenar muscle. What are the thenar muscle? Everything pollicis. The name pollicis will come. What are the pollicis? Opponent pollicis, abductor pollicis, flexor pollicis brevis. So these are the three muscles are supplied by median nerve. Deep to that, one more is known as abductor pollicis. So here also pollicis is there. Here they will catch you. Okay, opponent pollicis. All the name pollicis is there, but adductor pollicis is supplied by ulnar nerve. Please remember. Adductor pollicis, what is the nerve supply? Adductor pollicis is supplied by ulnar nerve. This is very, very important. So we have completed about median nerve supply. Then two other thing here, 6.5, 3 muscle plus 2 lumbrical muscle. 2 lumbrical muscle. Hand totally contains 4 lumbrical. Out of that, 2 lumbricals are supplied by median nerve. See here, median nerve is going. This median nerve, it is going to supply flexor pollicis brevis, abductor pollicis brevis. Another one muscle is opponent pollicis. Here lumbrical we able to see first lumbrical, second lumbrical. 4 lumbricals are there. Third lumbrical, fourth lumbrical. Fourth lumbrical is supplied by ulnar nerve. These are the 5 muscles. So totally in forearm 6.5 muscle, in hand 5 muscle are supplied by median nerve. Is supplied by median nerve. So we have to remember that.
So mine is not audible, sir. We're not able to hear any information.
Okay, so like that, hypothenar muscles, if we go, hypothenar muscle, everything will come digiti minimi because this is little finger side. Little finger side, what are the muscles are there? Opponents digiti minimi, abductor digiti minimi, flexor digiti minimi. All the things are supplied by ulnar nerve. Everything is supplied by ulnar nerve. So digiti minimi, medial side is supplied by ulnar nerve. But pollicis, we have to remember carefully. Adductor pollicis also is supplied by ulnar nerve. Ulnar nerve totally going to supply 15 muscles in hand. Okay. After supplying all the thing, ulnar nerve will end in adductor pollicis. Finally, terminate in adductor pollicis. So that is also known as graveyard of ulnar nerve. Adductor pollicis muscle only, ulnar nerve will end. So that is also known as graveyard. Okay, of this thing, ulnar nerve. So we have to remember that. Then here lumbrical muscle, where it is originating, that is very important. Lumbrical muscle which is originating from flexor digitorum profundus tendon. It is not originating from any bone. It is originating from flexor digitorum profundus tendon. Lumbrical muscle totally 4 in number. First 2 unipennate. See, single side origin. First 2 unipennate. Then remaining 2 bipennate. Here now supply actions are very important. First 2 lumbricals are supplied by 1 and 2 is supplied by median nerve. 3rd and 4 is supplied by ulnar nerve. So median nerve, another one is ulnar nerve. Okay. So it is originating from flexor digitorum profundus tendon. So lumbrical muscle, what is the action? Okay, lumbrical. So we have to keep our finger like this. This is metacarpophalangeal joint. Okay, metacarpophalangeal joint. Okay. So here see this finger. Okay, metacarpophalangeal joint, flexion, interphalangeal joint extension, like this, interphalangeal joint extension. Okay, so this is the action of lumbrical. If lumbrical muscle paralyzed, mean opposite. Okay, interphalangeal joint flexed, metacarpophalangeal joint extended. So that clinical condition is known as phalangeal joint extended, interphalangeal joint flexed, mean that clinical condition is claw hand. First two lumbrical is supplied by median nerve, third and fourth is supplied by ulnar nerve. Okay, ulnar nerve. So it will lead to claw hand. So what is the normal action? Flexion at metacarpophalangeal joint, extension at interphalangeal joint. Then one more group of muscle is known as palmar intraossei. Palmar intraossei, the actions are very, very important. Palmar intraossei. So here the mnemonic is pad. Already we know padded tab, that we will remember. Pad tab. P for palmar intraossei. D for dorsal intraossei. P for palmar intraossei. P for dorsal intraossei. Pad. Palmar intraossei are adductor. Palmar intraossei are adductor. Dorsal intraossei are abductor. Okay, dorsal intraossei are abductor. So palmar intraossei, adduction of finger. Dorsal intraossei, abduction, widening. Okay, adduction, abduction. So all are supplied by ulnar. So palmar intraossei, dorsal intraossei, third lumbrical, fourth lumbrical, all the hypothenar muscle, including adductor pollicis. So totally 15 muscles are supplied by ulnar nerve. Remaining muscles are supplied by this thing, I mean median nerve. Okay. Then here one more important thing, structure passing superficial and deep to flexor retinaculum. For example, here carpal bones are there. Carpal bone, flexor retinaculum is stretching. So what are the structure passing superficial to flexor retinaculum? What are the structure passing deep to flexor retinaculum? Very, very important. Out of that, the main one is artery. The main one is nerve. Flexor retinaculum, deep to that one nerve is going. That nerve is known as median nerve. Median nerve passing deep to flexor retinaculum. Ulnar nerve along with ulnar artery passing through superficial to retinaculum. Very important. Okay. So deep to retinaculum, what nerve is going? Flexor retinaculum. Deep to that, median nerve is going. Superficial to that, because median nerve, ulnar nerve, both are going to supply the hand muscle. So both should enter into hand. So it should cross flexor retinaculum. In front of retinaculum is there. In front of wrist, flexor retinaculum. So both cross this thing. So through the flexor retinaculum, median nerve is going. Superficial to that, what is this? Ulnar nerve is going. Then one more thing, this ulnar nerve, which is actually passing through, this is flexor retinaculum. Here there is a ligament that is known as palmar carpal ligament. So this is flexor retinaculum, this is palmar carpal ligament. It is forming on canal. That canal is known as Guyon's canal. So here there is a question, what nerve which is passing through Guyon's canal? Guyon's canal, it will transmit ulnar nerve. Ulnar nerve, is it passing through flexor retinaculum? No. Ulnar nerve passing superficial to flexor retinaculum. Okay. So ulnar nerve passing through one named canal. That canal is known as Guyon's canal. In Guyon's canal, ulnar nerve is accompanied by ulnar artery. So ulnar nerve, ulnar artery, both are passing through Guyon canal, superficial to flexor retinaculum. Deep to flexor retinaculum, median nerve is going. Please remember, median nerve is going. So here, in case of any carpal tunnel syndrome in compression in this area, which nerve will be involved? Median nerve will be involved, or this thing, ulnar nerve. Carpal tunnel syndrome in here, in this area, compression, median nerve will be compressed. But in sometime in Guyon canal syndrome, ulnar nerve can be compressed. So this point we have to remember. Then additionally, what are here? See, this is flexor retinaculum. So if flexor retinaculum means deep to that, additionally here forum, deep to that median nerve is one. Then flexor digitorum superficialis, long tendon, forearm tendon. This also entered into flexor digitorum superficialis, passing deep to that, right? Deep to flexor retinaculum. So median nerve, flexor digitorum superficialis.
Sir, audio breaking, sir.
Flexor digitorum superficialis, flexor digitorum profundus tendon also going. Flexor digitorum profundus, flexor digitorum superficialis. Then flexor carpi radialis. So these are the tendons are passing through this, but almost, I mean, which one is important? Mean which nerve passing deep to that? Median nerve passing deep to that. Which one is passing superficial to that? Ulnar nerve passing superficial to that. In case of carpal tunnel syndrome, Okay, so here median nerve very easily can say carpal tunnel. It will transmit median nerve. See,
Sir, we are not able to follow, sir. Voice is breaking, sir.
Ma 2 minutes break. Okay, we will continue. 2 minutes break. Okay. Okay, can we continue? Is it audible? One of you please reply. Can you hear me? Now is audio is clear?
Yes, sir.
Yes, sir.
Okay. So these are the things are passing deep to that, superficial to that, but please try to concentrate which nerve is passing deep to that, which is passing superficial, median nerve passing deep to that. That is very important. Median nerve which is passing deep to that. So median nerve, in case if it is compressed, mean what will happen? If it is compressed, mean median nerve. If it is compressed, mean already we know here it is going to supply the thenar muscle. Okay. So median nerve, if it is compressed in carpal tunnel, mean here thenar muscle. There are 3 thenar muscle supplied by median nerve. We already know. So all the muscle that won't receive nerve supply. So that will leads to wastening of this muscle. Wastening of this muscle. What are the 3 muscle? Opponent pollicis, abductor pollicis. Another one is flexor pollicis. So here abductor pollicis is gone. But in this region, one more muscle is remain intact. That is supplied by ulnar nerve. What is that? Adductor pollicis. Because adductor pollicis is supplied by, already we have discussed many times, adductor pollicis is supplied by ulnar nerve. Adductor pollicis is supplied by ulnar nerve. So that will lead to adduction of thumb along with wastening of this thenar eminence. So it will mimic like ape thumb. I mean monkey's thumb. Okay, ape thumb deformity. Okay, so one of the characteristic features of carpal tunnel syndrome is ape thumb deformity. Very important, ape thumb deformity. Then another one is this median nerve. It is not only supplying this muscle, also supplying first lumbrical, second lumbrical. So first lumbrical, second lumbrical already we know. First lumbrical, second lumbrical, it is supplied by median nerve. Median nerve, lumbrical muscle, very important for flexion of metacarpophalangeal, extension of interphalangeal. Now first lumbrical, second lumbrical will be paralyzed. That will lead to claw hand. That will leads to claw hand of what are the finger? This finger and this finger, claw hand. So first one is ape thumb deformity. The first one is ape thumb deformity. Ape thumb deformity. The second one is claw hand. Okay, median claw hand. Okay. Then additionally some tingling sensation here. Median nerve is compressed here, so that will leads to compressed, resulting in numbness or pain in 3 end of finger, thumb, second, third, and 4. Medial 3 end of finger. Because lateral side, this side is supplied by ulnar nerve. So these are the 3: ape thumb deformity, then numbness or pain in 3 end of finger, sometimes claw hand. All are characteristic features of carpal tunnel syndrome. But in case of carpal tunnel syndrome, whether pointing index can be able to see. Pointing index mean we have to ask the person to flex their finger. Pointing index classically seen in higher level median nerve injury. For example, above the elbow joint, supracondylar fracture, humerus fracture. Okay, at that time that will leads to pointing index. But here carpal tunnel syndrome, it can cause ape thumb deformity, it can cause claw hand, it can cause some sensory deficit. Okay, but it never cause pointing index. So That is a main differentiating point. For like radial nerve, if trunk is involved, mean that will leads to wrist drop. But posterior intraosseous nerve only injured, mean that is not leads to wrist drop. That will leads to only weakness in wrist extension. Like that, higher median nerve injury leads to pointing index, but claw hand, carpal tunnel syndrome, that will leads to that won't produce pointing index. Pointing index is a characteristic feature of higher level median nerve injury, for example, supracondylar fracture. Then some of the spaces of hand, one of the classical one is pulp space. Okay, so for example, here we can see the distal phalanx. Here we can see the distal phalanx. So here skins, here nail. Okay, so this is distal phalanx. Here middle phalanx. Here from the skin to distal phalanx, many septae. It is divided into many compartment. It is supplied by some digital artery. It is supplied by digital artery which is passing through the septum only. So see here, digital artery which is passing through this septum, many septum. Okay, so here, for example, if this is phalanx, this 1/4 only lying outside, remaining 1/5, remaining 4/5 lies within this septa only. Only this 1/5 lying outside. So in case of any infection in this area, that is pulp space infection, are also known as Whitlow. Whitlow, here it is divided into many compartments. So pus collection mean here pressure will be high. So this digital artery passing through these spaces only. So it can't provide blood supply to distal phalanx. So this digital artery can't supply, in case of any Whitlow, can't supply this much of area. Distal 4/5 divide of blood supply, that will leads to avascular necrosis. So in case of pulp space infection, which phalanx is affected? Terminal phalanx will be affected. Distal phalanx, entire distal phalanx, no. I mean only distal 4/5. Here this area, I mean proximal 1/5 never affected because it lies outside. So it is not affected. So pulp space infection is also known as Whitlow. What is the clinical outcome? It may leads to what complication? Avascular necrosis of distal phalanx. Entire distal phalanx, no, only distal 4/5. Then some of the spaces of hand, thenar space. Here thenar space, this space is mid palmar space. Okay, so additional to pulp space, here pulp space is seen. Pulp space, it will leads to avascular necrosis. Thenar space, hypothenar space. So in case of anything, here we have to first cleft, we have to cut to drain the thenar space. We have to put the incision in first cleft. We have to put the incision in third cleft for this mid palmar space. Then like flexor retinaculum, extensor retinaculum is there. But extensor retinaculum, here I like to stress only one point. That point is this fourth compartment. Very important one is fourth compartment. Okay, because this fourth compartment, it will transmit 4 structure. Extensor retinaculum, where it is seen on dorsum of wrist. Okay, so it is divided into 6 compartments. See here, compartment number 1 to 6. All are transmitting some structure. Out of that, fourth one is very important because it will transmit extensor digitorum tendon. Additionally, extensor indices. Extensor digitorum, extensor indices 2. Okay, here it will transmit posterior intraosseous nerve. So posterior intraosseous nerve passing through which compartment of extensor retinaculum? Posterior intraosseous nerve passing through 4th compartment. Then additionally, one more artery, anterior intraosseous artery, posterior intraosseous nerve. So here this is anterior intraosseous artery, not posterior intraosseous artery. Anterior intraosseous artery, posterior intraosseous nerve. Both are passing through 4th compartment of extensor retinaculum. Please remember, both are passing through 4th compartment of extensor retinaculum. Then let us move on to one more thing, anatomical snub box. Okay, on the dorsum of base of thumb, we can see the anatomical snub box. Here in anatomical snub box, what is the content? What are the roof structure? Both are very important. Anatomical snub box, the content is radial artery within the anatomical. So this area is known as anatomical snub box. What is the content of anatomical snub box? Anatomical snub box, the content is radial artery. Anatomical snub box, the roof is formed by, the content is radial artery. The roof, which is formed by cephalic vein. So here we can see the cephalic vein passing through roof. Additionally, one more nerve is going, that is superficial branch of radial nerve. Superficial branch of radial nerve along with cephalic vein. Both are roof structure. What are the structure passing through roof? Roof, it will transmit superficial branch of radial nerve, cephalic vein. The content is radial artery. So this is very important. Then here some of the nerve injury. Here, surgical neck of humerus. Neck of humerus closely related to axillary nerve. So surgical neck of humerus fracture, which nerve is affected? Axillary nerve is affected. Then through the spiral groove, radial nerve is going. Okay, so spiral groove level injury, radial nerve will be affected. Ulnar nerve, which is running behind the medial epicondyle. So medial epicondyle fracture, ulnar nerve will be paralyzed. Then radial nerve. Okay, it can be affected in medial epicondyle fracture. Median nerve exactly running down like this. Supracondylar fracture, it will be affected. So these are the points we have to remember. Then one more thing, there is a ligament just above the, so here this is lower end of humerus. We can see the medial epicondyle. Okay, from medial epicondyle to the shaft of humerus, there is a ligament. That ligament sometime can present. That ligament is known as Struther's ligament. If Struther's ligament, if it is present, mean what are the structure can be compressed? So here there are two structure can be compressed. If Struther's ligament present, mean one is median nerve, another one is brachial artery. So this is humerus picture. So brachial artery, median nerve, both can be compressed by Struther's ligament. Then in this picture, anastomosis around scapula. So here what are the parts are connected by this anastomosis? Okay, here many artery anastomosing around this scapula. Okay, so for example, here this is subclavian artery. Subclavian artery going to continue down as axillary artery. Okay, the subclavian artery divided into three parts by one muscle. That is known as scalenus anterior. By using what muscle subclavian artery is divided? Scalenus anterior. Axillary artery divided into three part by using pectoralis minor. So subclavian and axillary both are continuous with each other. So subclavian artery. So here by using scalenus anterior, first part, second part, this is third part. Axillary artery also divided into first part, second part, third part. Here first part, here it is giving many branches. Out of that, one is thyrocervical trunk. Like that. So this is first part of subclavian. Third part of axillary, here it is giving subscapular artery, posterior circumflex humeral, okay, anterior circumflex humeral. So this first part of subclavian, please remember what are the parts are interconnected. These two, first part of subclavian anastomosing with third part of axillary. First part of subclavian, what are the, by using this anastomosis around scapula, what are the parts are connected? First part of subclavian artery connected with third part of axillary artery. They will give many choices. I mean, third part of subclavian artery connected with the first part of axillary, like that. No, first part of subclavian artery connected with third part of axillary artery. Here many other important points are subclavian artery divided into three parts by scalenus anterior, like already we have discussed. Axillary artery divided into three parts by pectoralis minor muscle. Okay, so we have to remember that thing, anastomosis around scapula. What are the parts are connected? First part of subclavian artery with third part of axillary artery. So like that, axillary artery, some of the branches. Axillary artery here, first part, second part, third part by pectoralis minor muscle. By using this muscle, so this muscle running, so this part is first part, second part, this part is third part. First part giving superior thoracic artery. First part giving which artery? Superior thoracic artery. Second part, that is giving lateral thoracic artery. Another one is thoracoacromial artery. Third part, which is going to give, here see, subscapular. Here it is giving subscapular artery, anterior circumflex, posterior circumflex, anterior circumflex. So these three branches of third part, these two branches of second part. Superior thoracic artery is a branch of first part. So these are the branches of axillary artery. Excuse me. So with this, we conclude upper limb. We can move to the lower limb. Okay, 2 minutes break. Okay, can we start? Is it audible now? Okay, we can move to the lower limb. Lower limb, the first one is iliotibial tract. Okay, so the thigh which is covered by one D fascia, that fascia is known as fascia lata. Okay, that fascia is known as fascia lata. On the lateral aspect, so thigh, it is entirely covered by fascia lata, but lateral aspect, it is thickened itself. The thickening is known as iliotibial tract. The thickening is known as iliotibial tract. Here, iliotibial tract, which is extending from knee joint level to here below, hip joint level to below, it is crossing the knee joint and inserted into tibia. The tubercle, there is a tubercle, the tubercle is known as Gerty tubercle, that is not so important. Iliotibial tract is a thickening of fascia lata. Above, it is receiving two muscle. One of the muscle is known as gluteus maximus. Another one muscle is known as tensor fascia lata. So how many muscle inserted into iliotibial tract? Question. Two muscle inserted into iliotibial tract. Okay. So what are the muscles are inserted? One is tensor fascia lata. Another one is gluteus maximus. These are the two muscle inserted into iliotibial tract. Okay. So we can move to the anterior compartment of thigh. Anterior compartment of thigh, here we can see one longitudinal muscle. That muscle is known as sartorius. So sartorius. Then below the sartorius, here we can see quadriceps femoris. quadriceps femoris. Quadriceps mean 4 muscle. What are the muscles are we able to see? Vastus medialis, vastus lateralis, another one muscle is rectus femoris. If we reflect this rectus femoris, deep to that one more muscle is seen. That muscle is known as vastus intermedius. So 3 vasti plus rectus femoris. So these are the muscles are known as quadriceps femoris. So this quadriceps femoris muscle only, okay, going to form the patellar tendon. Patellar tendon. So there is a sesamoid bone. I mean, if bone developed within the tendon mean that is sesamoid bone. So patella is a sesamoid bone which is developed within the quadriceps femoris tendon. So this is quadriceps femoris. This is sartorius. Everything is supplied by femoral nerve. Everything is supplied by femoral nerve. So what is the nerve supplied to sartorius? Femoral nerve. Okay. Front of thigh muscles are supplied by femoral nerve. Femoral nerve root value L2, L3, L4. Femoral nerve, the root value is L2, L3, L4. Now, above the sartorius muscle, here we can see one small triangle. The triangle is known as femoral triangle. The triangle is known as femoral triangle. Okay. See here, this is the inguinal ligament. This ligament is known as inguinal ligament. So we can see inguinal ligament. Here sartorius we able to see. This side adductor longus muscle. This muscle is adductor longus muscle. So this is collectively forming one triangle. The triangle is known as femoral triangle. The triangle is known as femoral triangle. So here femoral triangle. What are the boundary of the femoral triangle? What are the boundaries of the femoral triangle? Here the femoral triangle which is formed by here laterally sartorius muscle, okay, medially adductor longus muscle, then above inguinal ligament. So these are the structures forming femoral triangle. Then floor which is formed by this muscle is iliacus muscle. So this muscle here iliacus, this muscle is psoas major, this muscle is pectineus, this muscle is adductor longus. So these are the muscles forming floor from lateral to medial side. Here important thing is content. So here totally 4 contents are there. What are the 4 content? The contents are medial to laterally. So already we have discussed the boundary. Here above our base is created by inguinal ligament. Then here adductor longus muscle medially. Then laterally sartorius muscle. Then floor we have completed. These are the content. The contents are femoral vein, medial most femoral vein, little bit laterally femoral artery, still laterally femoral nerve, still laterally there is one more nerve, that is lateral cutaneous nerve of thigh, So totally 4 content. The contents are femoral vein, femoral artery, femoral nerve, here lateral cutaneous nerve of thigh, totally 4 content. Out of these 4 content, here one more thing, what is this vein? If this is femoral vein, what is this vein? This vein is great saphenous vein. Great saphenous vein, it is going to pierce the roof. So here, this is roof of the femoral triangle. See, the same thing. Here we can see the boundaries of the femoral triangle. Here, the fascia lata completely enclosing the femoral triangle. Okay, so that is going to form the roof because that is the fascia. That itself has an opening. That opening is known as saphenous opening. That opening is known as what? Saphenous opening. The saphenous opening through which great saphenous vein is going. Okay, enter and drains into femoral vein. So roof of the femoral triangle is pierced by great saphenous vein. Okay, then finally here now only we have discussed within this what are the structures are seen. Femoral vein is there, femoral artery is there. Okay, femoral vein, femoral artery is there. Both are collectively enclosed by one sheath. That sheath is known as femoral sheath. So femoral sheath, which is what are the structure enclosed by femoral sheath? So femoral vein is enclosed by femoral sheath. Femoral artery is enclosed by femoral sheath. Okay, in front of femoral artery there is one more nerve. That nerve is known as genitofemoral nerve, femoral branch of genitofemoral nerve. That is known as femoral branch of genitofemoral nerve. Okay, but femoral nerve never covered by femoral sheath. So femoral sheath only enclosing femoral vein, femoral artery, femoral branch of genitofemoral nerve, These are the structures only. These 3 structures only enclosed by femoral sheath. Okay, but outside to that femoral nerve is there. One more content of femoral triangle. What is that? Lateral cutaneous nerve of thigh. What are the content of femoral triangle? Not enclosed by femoral sheath. Femoral nerve not enclosed. Like that, one more structure is lateral cutaneous nerve of thigh. That is also not enclosed. What are the structures are enclosed? 3 structures are enclosed. What are the structure? Here, femoral sheath, which is divided into 3 compartments. So this is the middle compartment contain femoral vein. Lateral compartment contain femoral artery as well as genitofemoral nerve. Medial most compartment. This compartment contain one lymph node. This lymph node is known as lymph node of Koncpt. This lymph node is known as lymph node of Koncpt. Koncpt lymph node of Koncpt, which is also known as Rosenmuller. Lymph node of Koncpt or Rosenmuller. That is the medial most content of femoral sheath. Okay. This lymph node of Koncpt or Rosenmuller drains glans penis in male, glans clitoris in female. Glans penis or glans clitoris. Okay. Both are drained by this Rosenmuller or Koncpt lymph node. So femoral nerve, is it enclosed by femoral sheath? No. Then femoral nerve, already we have discussed here. Femoral nerve, which is going to supply sartorius muscle. Another one is quadriceps femoris in the sense of vastus medialis, lateralis, rectus femoris, vastus intermedius. Then one more thing we have to remember: saphenous nerve is a branch of femoral nerve. Saphenous nerve, okay, is a branch of, see, saphenous nerve is a branch of the one thing we have to remember. Saphenous nerve is a branch of sciatic nerve, obturator nerve. Another one is femoral nerve. So saphenous nerve is a branch of which nerve? Femoral nerve. Very, very important. Saphenous nerve is a branch of femoral nerve. What is the root value? Root value is L2, L3, L4. Root value is L2, L3, L4. So femoral nerve giving saphenous nerve gives one branch, cutaneous branch known as saphenous nerve. Okay. So then we can move to the, so here femoral triangle region we have completed. Here femoral vein is there, femoral artery is there, nerve is there, but nerve is not enclosed by femoral sheath. Femoral sheath only enclosing 3 structure: femoral vein, femoral artery, in front of femoral artery, genitofemoral nerve, but femoral nerve not enclosed. Then medial most one lymph node is there. That lymph node is known as Koncpt lymph node or Rosenmuller lymph node, which is going to drain glans penis or glans clitoris. So all the things already we have covered. Then here, please come to this area. Okay, here what is this? Here some of the adductor muscle is coming. Here what is this? Vastus medialis. What is this? Vastus medialis. So in between this adductor muscle and vastus medialis, one more canal is there. That canal is known as adductor canal. See here, if you come here we can mark it. Okay, so here what is this? This is vastus lateralis. Vastus lateralis. This is vastus intermedius. Above to that, this is rectus femoris muscle. If you come, this is vastus medialis. Vastus medialis deep to that. Here adductor muscle, adductor longus. So here vastus medialis, here adductor longus. See, deep to this. Here vastus medialis. If we reflect this, deep to this, some adductor muscle. So that is the orientation. So vastus medialis in front, behind some adductor muscle. So the same thing. Vastus medialis in front. This is femur. So vastus medialis in front. Here adductor longus. In between there is a space. That is known as adductor canal. That is known as adductor canal. That is roofed by sartorius muscle. That is roofed by sartorius muscle. See here, anterior boundary vastus medialis, roof is formed by sartorius. If you reflect these two, you can see adductor muscle. That is adductor longus. That is the posterior boundary. So what are the boundary for the adductor canal? Adductor canal, very simple. Anteriorly vastus medialis, roof is caused by sartorius muscle. Posteriorly we can see some adductor muscle, the properly adductor longus muscle. Adductor longus, here it is continuous coming down. So adductor longus muscle. In between we can see few structure. What are the structure we able to see? Okay, like femoral triangle, what are the content? Very easily we can say femoral vein is a content, femoral artery is a content, femoral nerve is a content, femoral nerve is a content. But here, what are the content? Femoral artery is a content, femoral vein. So here femoral artery. So from the femoral triangle, femoral vein enter here, femoral artery enter here. But femoral nerve, it is here itself divided. Saphenous nerve also only enter here. Saphenous nerve only enter here. Here, what are the content? If question come in, femoral vein is a content, femoral artery is a content, but femoral nerve not a content. Only saphenous nerve. It is a branch of femoral nerve. That is a content. Here is the catch. Okay. So femoral artery, femoral vein. Another one is saphenous nerve. That is the content. That is the content. Then here vastus medialis muscle already forming the floor. So now to vastus medialis. So again I am repeating totally 4 content for adductor canal. Femoral artery, content number 1. Femoral vein, content number 2. Then saphenous nerve, content number 3. Then vastus medialis forming one of the boundary. So now to vastus medialis, content number 4. nerve to vastus medialis. So this is the adductor canal. Adductor canal. So see, adductor canal, anterior boundary is formed by vastus medialis, posterior boundary is formed by adductor longus. Then here what muscle? Roof is created by or formed by sartorius. Here one more thing, subsartorial plexus. We have to get the orientation for subsartorial plexus. So subsartorial, immediately deep to the sartorius, there is a plexus of nerve. There is a plexus of nerve. That plexus is known as subsartorial plexus. That plexus is known as subsartorial plexus. So the subsartorial plexus is formed by what are the nerve? Here there is a question. Subsartorial plexus is formed by totally 3 nerve. Totally 3 nerve. So subsartorial plexus formed by the nerve number 1, saphenous nerve. The nerve number 1, that is saphenous nerve. The nerve number 1, saphenous nerve. Then nerve number 2. Here see, here only adductor canal is there. Here after removing this sartorius muscle, we can see that. So saphenous nerve, here it is coming. So it is contributing to subsartorial plexus. This is medial aspect of thigh. This is lateral aspect of thigh. Here what one more nerve will come? Medial. So this side lateral cutaneous nerve of thigh. Here intermediate cutaneous nerve of thigh. Here medial cutaneous nerve of thigh. So here saphenous nerve is coming. Here medial cutaneous nerve of thigh is coming. Like that, this is adductor compartment. Adductor compartment is supplied by obturator nerve. Okay. So obturator nerve. So totally 3 branches. Saphenous nerve from here, medial cutaneous nerve of thigh, anterior division of obturator nerve. Anterior division of obturator nerve. These are the 3 contributing to the formation of subsartorial plexus. So again, I'm repeating, adductor canal contain femoral vein, femoral artery, saphenous nerve, nerve to vastus medialis. Okay. Then the subsartorial plexus formed by 3 nerve. The nerves are saphenous nerve, medial cutaneous nerve of thigh. The one more one is anterior branch of obturator nerve. Anterior branch of obturator nerve. So these are the nerves forming subsartorial plexus. Then medial compartment, we already know medial compartment of thigh, which is supplied by obturator nerve. Obturator nerve, what is the root value? L2, L3, L4. So here what is the difference? Femoral nerve also formed by L2, L3, L4. Obturator nerve also formed by L2, L3, L4. Then how to differentiate both? For both, the root value is L2, L3, L4 only. But obturator nerve is formed by ventral division of L2, L3, L4. Please remember, ventral division of L2, L3, L4. Okay. So which is the ventral division of L2, L3, L4? Okay. So the choice number A, femoral nerve. That is wrong. Femoral nerve is formed by dorsal division of L2, L3, L4. L2, L3, L4 each divided into ventral dorsal. L2 divided into ventral dorsal, L3 divided into ventral dorsal, L4 divided into ventral dorsal. All the ventral join together forming obturator nerve. All the dorsal join together and forming femoral nerve. That is the concept here. So ventral division of L2, L3, L4 forming what nerve? Obturator nerve. Dorsal division of L2, L3, L4 forming what nerve? That is femoral nerve. Femoral nerve forming saphenous nerve. Obturator nerve, which is going to innervate all the adductor muscle in the sense of adductor longus, adductor magnus, adductor gracilis muscle, all are supplied by which one? Obturator nerve only. Here, the very important one is any muscle supplied by both femoral nerve as well as obturator nerve. Yes, one of the hybrid muscle is there. That muscle is known as pectineus. That muscle is known as pectineus. So pectineus is supplied by both femoral nerve as well as obturator nerve. In upper limb, please remember, upper limb, in forearm, front of forearm, flexor digitorum profundus muscle. Flexor digitorum profundus muscle. Flexor digitorum profundus muscle. Medial of is supplied by ulnar nerve. Medial of is supplied by ulnar nerve. Lateral of only supplied by median nerve or properly anterior intraosseous nerve. Properly anterior intraosseous nerve. Like that, pectineus in lower limb supplied by femoral nerve as well as obturator nerve. So this point we have to remember. Femoral nerve as well as obturator nerve. So here one more thing. Here this is adductor magnus muscle. Adductor magnus muscle. It is having many opening. Out of that, one of the here it is inserted into here lower end of femur. Here this opening is known as adductor hiatus. This opening is known as adductor hiatus. So what are the structure passing through this adductor hiatus? This is the adductor magnus muscle. What is the nerve supply? Adductor magnus is supplied by obturator nerve. But part of the adductor magnus also hybrid muscle. In lower limb, adductor magnus, it is belong to medial compartment as well as it is belong to medial compartment. It is belong to medial compartment as well as medial compartment. So that is supplied by obturator nerve. It is partially belong to posterior compartment also. So sciatic nerve. So in lower limb, 2 muscles we have to remember. Pectineus is supplied by dual nerve supply. What are the nerve? Femoral nerve, obturator nerve. Adductor magnus, it is supplied by obturator nerve as well as one more nerve, sciatic nerve. Okay, so here this is adductor hiatus. It is transmitting totally 3 structure. Adductor hiatus, it is transmitting totally 3 structure. The femoral artery, the femoral so this is the adductor hiatus. So it is transmitting 3 structure. So femoral artery is going through this. Femoral vein is, so femoral artery, if it is going through this, mean it will continuous as popliteal artery. It will continuous as popliteus artery. Then femoral vein, it is also continuous with popliteal vein. Then one more branch is genicular branch of obturator nerve. Genicular branch of obturator nerve. So content of femoral triangle, very, very important. Content of femoral triangle, femoral artery, femoral vein, then this thing, femoral nerve. Another one is lateral cutaneous nerve of thigh, genitofemoral nerve. Totally five content. Adductor canal, four important content: femoral artery, femoral vein, saphenous nerve, now to vastus medialis. So 4 important content. Adductor canal, it is transmitting totally 3 important structure. One is femoral artery, another one is femoral vein. Then one more thing is that obturator nerve giving one genicular branch to the knee joint. Okay, genicular branch of the obturator nerve. These are the 3 structure passing through adductor hiatus. Adductor hiatus. So let us move on to the gluteal region. Gluteal region. So after removing skin and all, we can see the gluteus maximus muscle. Gluteus maximus muscle. Main extensor of hip joint. Main extensor of hip joint. Gluteus maximus muscle. What is the nerve supply? Gluteus maximus already we have discussed. It is going to insert it into iliotibial tract. Okay, along with the tensor fasciae lata. Along with the tensor fasciae lata. So gluteus maximus and tensor fasciae lata inserted into which tract? Iliotibial tract. So gluteus maximus, what is the nerve supply? Superior gluteal nerve or inferior gluteal nerve? Okay, usually we will go with superior gluteal nerve, but the correct answer is inferior gluteal nerve. Gluteus maximus is supplied by inferior gluteal nerve. Then superior gluteal nerve, it is going to supply. If we remove this gluteus maximus, we can see gluteus medius, we can see gluteus minimus, gluteus medius, gluteus minimus. Then one more muscle is here, tensor fasciae lata. So here, please remember gluteus maximus, the nerve supply is gluteus maximus is supplied by inferior gluteal nerve. Inferior gluteal nerve. Okay. Then gluteus medius, minimus, tensor fasciae lata. These are the 3 muscles are supplied by gluteus medius, minimus, tensor fasciae lata. Supplied by inferior gluteal nerve. So how many muscles are supplied by inferior gluteal nerve? 3 muscles are supplied by inferior gluteal nerve. Can you name it? Yes, gluteus medius, minimus, tensor fasciae lata. Tensor fasciae lata. Gluteus medius is supplied by inferior gluteal nerve. Please remember. Then if you come here, piriformis muscle. What is the main action of this gluteus medius and minimus? So gluteus maximus mainly performing extension of hip joint. The main action, extension of hip joint. What is the main action of gluteus medius and minimus? Gluteus medius and minimus mainly performing abduction of hip joint. Abductions of hip joint, like supraspinatus delta, it is performing abduction of shoulder joint. Here gluteus medius and minimus performing abduction of hip joint. Gluteus medius minimus performing abduction of hip joint. Okay, extension of hip joint mainly done by gluteus maximus muscle. Then immediately below to that piriformis muscle, we able to see piriformis muscle. This piriformis muscle passing through greater sciatic notch. Here 2 notches. So this is one of the very, very important area. Here hip bone we able to see. In hip bone, here see this upper component is known as ilium. Then here this is pubis, this is ischium. Ischium. Here 2 notches we able to see. This notch is known as greater sciatic notch. This notch is known as what? Greater sciatic notch. Below to that, this notch is known as lesser sciatic notch. So this is greater sciatic notch. Yes. This is lesser sciatic notch. Yes. So greater sciatic notch, what are the structure passing? Very, very important question. So greater sciatic notch, which is traversed by one important muscle, that muscle is known as piriformis. So here see, can you able to see? So this is greater sciatic notch level. It is transmitting one muscle. That muscle is known as piriformis, one of the very important lateral rotator of hip joint. So extensor of hip joint, gluteus maximus, gluteus medius and minimus performing abduction of hip joint. Piriformis, lateral rotator of hip joint, very important lateral rotator of hip joint. So this is the piriformis muscle. Is piriformis passing through greater sciatic notch? Yes. So here this greater sciatic notch divided into 2 by this piriformis muscle. Above the piriformis, below the piriformis. See, above the piriformis, superior gluteal nerve and vessels are going. So what are the structure passing through greater sciatic notch? So piriformis muscle is going. So above the piriformis, superior gluteal nerve and vessels are going. Below the piriformis, inferior gluteal nerve and vessels are going. Very simple. So piriformis muscle traversing through which sciatic notch? Greater or lesser? Greater sciatic notch. Above the piriformis muscle, superior. So additionally, greater sciatic notch also transmitting superior gluteal vessel, inferior gluteal vessel. One main nerve is descending down. That nerve is known as sciatic nerve. Sciatic nerve is accompanied by, because sciatic nerve which is going to enter into back of thigh, so which is accompanied by posterior cutaneous nerve of thigh. It is very simple. Okay, so piriformis muscle which is travel through which one? It is travel through this greater sciatic notch. Above to that superior gluteal vessel, below to that inferior gluteal vessel, accompanied by sciatic nerve, that is accompanied by posterior cutaneous nerve of thigh. Additionally, pin structure, many times we have crossed pin structure. So pudental nerve, internal pudental vessel. Okay, so here pudental nerve and internal pudental vessel. So these are the structures. So very simple. What are the structure passing greater sciatic notch? Greater sciatic notch transmitting piriformis muscle, above the piriformis muscle superior gluteal nerve vessel, below the piriformis muscle superior inferior gluteal nerve vessel, which is accompanied by sciatic nerve, posterior cutaneous nerve of thigh, pin structure. Very easy. So like that, lesser sciatic notch. What are the structures are going through lesser sciatic notch? Lesser sciatic notch only transmitting pin structure. So here many structures are going. Pin structure common for greater sciatic notch as well as lesser sciatic notch. Okay. So here, what is this lesser sciatic notch transmitting? What are the structure? Pin structure. So what are the pin structure? P for pudental nerve, internal pudental artery, nerve to obturator internus. Then if piriformis muscle passing through this, is any muscle passing through this? Yes, tendon of obturator internus, just tendon, not entire muscle, tendon of obturator internus passing through lesser sciatic notch. So this is about greater sciatic notch, this is about lesser sciatic notch. Lesser sciatic notch transmitting obturator internus tendon as well as pin structure. Here many structures are going: piriformis muscle, superior gluteal nerve vessels, sciatic nerve, pin structure, all are going. Okay, then Trendelenburg sign. So here mainly we have to ask the patient to stand on one leg. Okay, so here patient stand on right leg, left foot is unsupported side. Here right side only working. So for example, patient is standing on right leg, so right gluteus medius minimus muscle is working. Right gluteus medius, this side is relaxed. Right gluteus medius and minimus muscle is working. This right side gluteus medius and minimus muscle, that is supporting opposite pelvis. So Trendelenburg sign mainly for checking gluteus medius minimus muscle. What is the nerve supply? Inferior gluteal nerve and vessel. Inferior gluteal nerve, which is going to supply one more muscle. What is the tensor fasciolata? So this is gluteus medius muscle, which is supporting unsupported pelvis, unsupported side pelvis. If this side is injured, mean this pelvis is sagging down, will sag down. Patient can't maintain the hip position when we stand on one side. Okay, if it is paralyzed, mean opposite side will, that is drop down. So that is Trendelenburg sign. Trendelenburg sign mainly to check gluteus medius minimus. Gluteus medius minimus supported by superior gluteal nerve and superior gluteal nerve. L5 S1 S2 superior gluteal nerve. Okay, so we have completed about this gluteal region. Then let us enter into the hamstring. I mean posterior compartment of thigh. Posterior compartment of thigh, it is easy. Posterior compartment of thigh mainly it contain here semimembranosus muscle, semitendinosus muscle. So this is semitendinosus muscle. Here this is medial side, this is lateral side. Okay, so here this is semitendinosus, semimembranosus, semitendinosus, semimembranosus. One more muscle is biceps femoris. So biceps femoris. Then one more muscle, adductor magnus. Adductor magnus. Already we have crossed. Adductor magnus is a composite muscle because partially it is present in medial compartment, partially it is belong to the posterior compartment of thigh. Okay, so here semimembranosus, semitendinosus, adductor magnus, biceps femoris, all the muscles are present in back of thigh. Back of thigh muscles are collectively known as hamstring muscle. Back of thigh muscles are collectively known as hamstring muscle. Okay, out of that semimembranosus, semitendinosus. So these two is purely or true hamstring. Adductor magnus partially belong to medial compartment. Okay, so biceps femoris. Okay, it is also having two head, long head of biceps femoris belong to the hamstring muscle. All the hamstring muscles are like front of thigh is supplied by femoral nerve, medial aspect, adductor compartment is supplied by obturator nerve, but except pectineus is dual nerve supply. So adductor compartment, adductor magnus, gracilis, everything is supplied by obturator nerve. Like that, this posterior here, gluteus maximus is supplied by inferior gluteal nerve, medius minimus is supplied by superior gluteal nerve. Like that, hamstring compartment, posterior aspect, semimembranosus, tendinosus, biceps femoris, everything is supplied by sciatic nerve. Everything is supplied by sciatic nerve. That too in sciatic nerve, that is sciatic nerve is a combination of tibial as well as common peroneal. So it is supplied by tibial component of this thing. Hamstring muscle, one of the criteria we have to know, hamstring muscle, all the hamstring muscles should originating from ischial tuberosity. All the muscles are originating from ischial tuberosity. So what are the hamstring muscle? Semimembranosus, semitendinosus, biceps femoris, adductor magnus. These are the 4 muscles are known as what? Hamstring muscle. Hamstring muscles are originating from ischial tuberosity. Hamstring muscles are supplied by sciatic nerve. Which division of sciatic nerve? Tibial division of sciatic nerve. That's all. Let us move on to the popliteal fossa. Let us move on to the popliteal fossa. So here popliteal fossa, if you enter the same thing, here it is bounded by one side semitendinosus, semimembranosus. Can you able to see? Semimembranosus, semitendinosus. So here popliteal fossa, below the hamstring muscle only it is seen. So the bound, it will be bounded by semitendinosus, semimembranosus on one side, biceps femoris on other side. Biceps femoris on other side. Then below it will be founded by leg muscle. The leg muscles are gastrocnemius. The leg muscles are gastrocnemius. Very simple. So popliteal fossa, so which lies in between leg and back of thigh, which lies so behind the knee. So here above semitendinosus, semimembranosus, biceps femoris. So both side boundary. Then below gastrocnemius. Okay, medial head, it is having 2 head, lateral head, another one is medial head. So it is forming on diamond shaped space. The diamond shaped space is known as popliteal fossa. So here popliteal fossa, femoral triangle roof is pierced by, already we have discussed, femoral triangle roof is pierced by great saphenous vein. Like that, here popliteal fossa, the roof is pierced by what? The popliteal fossa, the roof is pierced by, that is small saphenous vein. Small saphenous vein. So in femoral triangle, great saphenous vein, if after piercing the roof, it enter into or drained into femoral vein. It drained into femoral vein. So here also short saphenous vein, it is piercing the roof and drained into popliteal vein. Here deep to this popliteal vein is there. So this vein after piercing, it drained into popliteal vein. Then one more structure, that is already we know posterior, this is hamstring compartment. So here sensory innervation provided by posterior cutaneous nerve of thigh. So that is also present in roof. So roof of popliteal fossa pierced by short saphenous vein. Roof of femoral triangle is pierced by great saphenous vein. Roof of the popliteal fossa also transmit one cutaneous nerve, that is posterior cutaneous nerve of thigh. Then the content, if you come, the contents are 3 main content. Okay, so here popliteal artery, popliteal vein, sciatic nerve enter. Sciatic nerve divided into tibial nerve. Another one is common peroneal nerve. Another one is common peroneal nerve. So it is very easy. So already we have discussed first femoral artery, femoral vein in femoral triangle. Then from here it enter into adductor canal. From here it enter into popliteal fossa. So adductor canal and popliteal fossa connected by that adductor hiatus. So already we have discussed adductor hiatus transmitting femoral artery. So after passing through adductor hiatus, it is continuous with popliteal artery. Very simple. Then this is popliteal vein. Through the adductor hiatus, it is continuous with femoral vein. Logical. Then posterior compartment of the one nerve is descending down. That nerve is sciatic nerve. Here sciatic nerve divided into tibial nerve, common peroneal nerve. Tibial nerve, common peroneal nerve. So tibial nerve is here, common peroneal nerve is here. So here this order sometime important. So which is the deepest structure in popliteal fossa? Artery is the deepest structure in popliteal fossa. Vein is the intermediate structure in popliteal fossa. Tibial nerve is the superficial most structure in popliteal fossa. We have to remember that. Okay. So nerve is the superficial most structure. Vein is the intermediate structure. Artery is the deepest structure. We have to remember this. Then here one more question. After removing all the structure, popliteal fossa content, everything if we removed, mean here these are the floor of the popliteal fossa. Floor of the popliteal fossa. Again, we are repeating cubital fossa. The floor is formed by 2 muscles. The muscles are, one is biceps. Sorry, the muscles are brachialis. Another one is supinator. So cubital fossa, the floor structures are 2 in number. What are the structures forming floor? One is brachialis. Another one is supinator. Like that, here floor of the popliteal fossa is formed by popliteus muscle. Popliteus muscle, unlocking muscle of knee joint. Locking, unlocking. Which is the unlocking muscle? Popliteus muscle is the unlocking muscle. Which is the locking muscle? Quadriceps femoris, front of thigh muscle. That is the locking muscle. Unlocking muscle is popliteus muscle. What is the nerve supplied to the popliteus? Popliteus muscle is supplied by, please remember, tibial nerve. What is the nerve supplied to the popliteus? Popliteus muscle is supplied by tibial nerve. Is supplied by tibial nerve. Then the floor of the popliteal fossa also contain one more ligament. That ligament is known as, please remember, oblique popliteal ligament. Why it is important? Oblique popliteal ligament is a remnant of, this is semimembranosus tendon. So here totally 3 ligament remnants of something. So we have to remember that the ligament number 1, oblique popliteal ligament. Ligament number 1, oblique popliteal ligament. This oblique popliteal ligament is a remnant of semimembranosus. Oblique popliteal ligament is a remnant of what? Semimembranosus. Semimembranosus. Like that, this side fibular collateral ligament is there. This side tibial collateral ligament is there. Tibial collateral ligament or medial collateral ligament. This is lateral collateral ligament or fibular collateral ligament. So oblique popliteal ligament is a remnant of semimembranosus. Point number 1. Point number 2. This medial tibial collateral ligament is a remnant of adductor magnus. Is a remnant of adductor magnus. Then fibular collateral ligament is a remnant of peroneus longus. Is a remnant of peroneus longus. So these are the 3 points we have to remember. Oblique popliteal ligament is a remnant of semimembranosus. Medial or tibial collateral ligament is a remnant of the second one, adductor magnus. Then fibular collateral ligament is a remnant of peroneus longus, one of the leg muscle. One of the leg muscle. Adductor magnus, one of the thigh muscle. So we have to remember these 3 points. Okay. Then we can move to the anterior compartment of leg. Okay. Leg region, anterior compartment. Anterior compartment, very simply, 2 things we have to remember. So if anterior compartment, so here the bone of the leg is known as, what is that? Tibia. Bone of the leg, that is known as tibia. Okay. Then fibula and tibia is there. In front of tibia, so front of leg we are discussing. Leg is divided into totally 3 compartments. In front of tibia, tibial is anterior. Tibial is anterior. Like that, anteriorly placed muscles are extensor, or collectively, simply you remember the front of leg that contain dorsiflexor. That contain what? Dorsiflexor. I mean, it will, so if food is there, mean, so it will use it to here, elevate the food. Okay, dorsiflexion of food. So tibialis anterior is one of the dorsiflexor. Extensor digitorum longus, extensor hallucis longus, all are dorsiflexor. This dorsiflexor is supplied by one of the nerve. That nerve is known as deep peroneal nerve. Please remember. So here, front of leg, dorsiflexors are there. The dorsiflexors are supplied by what? Already popliteal fossa contain tibial nerve, common peroneal nerve. Okay, the tibial nerve classically supplying back of leg. Okay, back of leg. Then that common peroneal nerve at the neck of fibula divided into deep peroneal nerve. Another one is deep peroneal nerve. Another one is superficial peroneal nerve. So common peroneal nerve, which is divided into 2 nerve in this level. 2 nerve in this level. So here it is going to supply, this entire thing is supplied by deep peroneal nerve. So deep peroneal nerve, in case of any injury, deep peroneal nerve, any injury that will leads to foot drop, that will leads to foot drop. We have to remember that. That will leads to what? Foot drop. That will leads to foot drop. Like that, posterior compartment. See here we can see the posterior compartment. The posterior compartment, initially we able to see the gastrocnemius muscle. Gastrocnemius muscle. Okay. Deep to that, here we can see the soleus muscle. So gastrocnemius muscle, also soleus muscle. Soleus muscle also known as peripheral heart, because rich venous plexus is there. It is undergoing contraction. So pumping of blood is taking place. So it is also known as what is that? Peripheral heart. So soleus muscle, gastrocnemius, collectively forming tendo-Achilles tendon. Tendo-Achilles. So collectively triceps surae, collectively known as what? Triceps. 3 things. 2 heads of gastrocnemius, soleus. So totally 3 muscles join together and form one muscle, that is known as triceps surae. So here in arm, triceps brachii. Here triceps surae. Triceps surae. Okay. So here this entire back. So here if we remove this gastrocnemius soleus muscle, we can see next group of muscle. Here this is posterior aspect. So tibialis posterior. Tibialis posterior. That is tibialis anterior. Dorsiflexor. Here their anterior muscles are extensor in leg region. So that is extensor digitorum, extensor hallucis. Here back of leg, flexor. Flexor digitorum, flexor hallucis. Flexor hallucis. Everything is supplied by one nerve. That nerve is known as tibial nerve. That nerve is known as what? Tibial nerve. So tibial nerve, which is going to supply popliteus muscle, which is going to supply gastrocnemius muscle, which is going to supply soleus muscle, plantaris muscle, which is going to supply tibialis posterior. All the muscles are, above sheath muscles are known as, these muscle, tibialis posterior is known as plantar flexor. Plantar flexor. Tibialis anterior is known as dorsiflexor. Tibialis anterior is supplied by deep peroneal nerve. Dorsiflexors are supplied by tibial nerve. Tibial nerve. Okay. So we have to remember this. Then here lateral aspect. So here posterior aspect muscles are supplied by tibial nerve. Posterior aspect muscles are supplied by tibial nerve. What are the muscle present posteriorly? Gastrocnemius seen, deep to that soleus, deep to that tibialis posterior. All are plantar flexor, plantar flexor. So supplied by tibial nerve. Anterior compartment muscles are these are dorsiflexor. Tibialis anterior, which is supplied by deep peroneal nerve. Deep peroneal nerve. In case of injury, foot will drop down. Foot drop. So which one leads to foot drop? Foot drop is because of deep peroneal nerve injury. Deep peroneal nerve injury leads to dorsiflexor paralysis. Foot drop is taking place. Foot drop is taking place. Then here lateral muscle, there are two in number, peroneus longus. So not only anterior compartment, posterior and anterior compartment, lateral compartment also there. This lateral compartment is contain two muscle. One is peroneus longus, another one is peroneus brevis. Peroneus longus muscle, peroneus brevis muscle. Both are supplied by superficial peroneal nerve. Please remember, both are supplied by superficial peroneal nerve. So nerve of the back of leg, nerve of the back of leg, that is tibial nerve. Nerve of the front of leg or plantar flexors are supplied by tibial nerve. Dorsiflexor is supplied by deep peroneal nerve. These are lateral muscles are known as evertor. Evertor of foot. Evertor of foot is supplied by superficial peroneal nerve. So superficial peroneal nerve supplying peroneus longus brevis. Yes. Gastrocnemius soleus tibialis posterior supplied by tibial nerve. Yes. Anteriorly tibialis anterior, which is supplied by deep peroneal nerve. In case of any injury to deep peroneal nerve, that will lead to foot drop. Here superficial peroneal nerve, deep peroneal nerve, I mean branch of common peroneal nerve. So in case of neck of fibula fracture, like in upper limb, neck of humerus fracture, axillary nerve will be gone. Okay, so like that spiral groove fracture, what will radial nerve will be injured. Like that here fibula, head of fibula fracture, which nerve will be affected? Peroneal nerve. Peroneal nerve gone mean deep peroneal nerve gone. Deep peroneal nerve gone mean foot drop. Very simple, foot drop. So then finally here, like popliteal artery. Popliteal artery, femoral artery through the adductor hiatus enter into popliteal fossa, that is known as popliteal artery. Popliteal artery divided into anterior tibial, posterior tibial artery. Okay, anterior tibial, posterior tibial, that will traverse the entire leg. Here see, anterior tibial artery is coming down. This anterior tibial artery continues with dorsalis pedis artery. Anterior tibial artery going to continues as what tibial artery? Dorsalis pedis artery. Dorsalis pedis artery. Here dorsalis pedis artery is a continuity of anterior tibial artery. Anterior tibial artery, which is going to give some of the branches. One of the branches is known as arcuate artery, then lateral plantar artery, medial plantar artery. So here medial plantar, lateral plantar, medial plantar, arcuate artery. All are branches of dorsalis pedis. Here very important thing, dorsalis pedis artery usually used for peripheral pulsation. Peripheral pulsation, lower limb pulsation you will feel in between two medial malleolus, dorsalis pedis artery. It is a continuity of anterior tibial. Anterior tibial is a branch of which one? Popliteal artery. Then here the very important one, like hand, palmar aspect if we consider, if we consider here, first medial 3.5 finger, here this side anterior aspect 3.5 finger. 3.5 finger mean here thumb, here second, that is index finger, middle finger, ring finger, off of the ring finger. Everything is supplied by median nerve. Everything is supplied by medial 3.5 median nerve, lateral 1.5 ulnar nerve. This is for which side? This is for palmar side. Dorsal side here, I mean the same thing. 1.5 that is supplied by ulnar, remaining is supplied by radial. So this is for hand. Foot region, if we consider, this is very, very important. Here almost all the dorsum of foot is supplied by superficial peroneal nerve. Superficial peroneal nerve, it is going to supply two muscle. Which muscle? Lateral compartment muscle. What are the lateral compartment muscle? Peroneus longus, peroneus brevis is supplied by superficial peroneal nerve, but except deep peroneal nerve, it is going to supply dorsiflexor. In case of injury, foot drop. Additionally, deep peroneal nerve going to supply first web space in between great toe and second toe. In between area is supplied by deep peroneal nerve. Very, very important. In between area is supplied by deep peroneal nerve. Most of the dorsum is supplied by superficial peroneal nerve. Very important. Superficial peroneal nerve, deep peroneal nerve. Okay. So these two very, very important. Dorsum, cutaneous supply is very, very important. Like that here, this is here, saphenous nerve. Okay. So along the great toe until the ball of great toe, that is saphenous nerve. It is a branch of femoral nerve. So lateral aspect, sural nerve. The remaining things are plantar nerve. That is not so important. Medial side saphenous nerve, lateral side sural nerve important. Here superficial peroneal nerve, deep peroneal nerve. These two very important. Okay. Then finally here we can discuss about great saphenous vein. great saphenous vein. Here, this is the dorsal venous arch, dorsal venous arch, dorsal venous arch. Medially, this is medial marginal vein. Join together and form great saphenous vein. So, dorsal venous arch, medial marginal vein, both are joined together and form great saphenous vein. Here, great saphenous vein is accompanied by saphenous nerve. Saphenous nerve. Great saphenous vein, which is running in front of medial malleolus or behind the medial malleolus. 1.25 centimeter in front of medial malleolus, it is running. After that, it is ascending up. After that, it is ascending up. Then crossing the medial aspect of knee. Then it is piercing the roof of femoral triangle and finally opens into which vein? Femoral vein. Finally, it is opens into femoral vein. Then here, this is one of the superficial vein, which is connected with deep veins of lower limb through perforator. Many perforators are there. Perforator only allowing blood from superficial to deep side only allow. Okay. So this perforator insufficiency, it will leads to varicose vein. Varicose vein. So great saphenous vein formation, that is medial marginal vein and dorsal venous arch, medial end of dorsal venous arch. What happened on the lateral side? Lateral end of dorsal venous arch, lateral marginal vein. So here lateral marginal vein, lateral end of dorsal venous arch join together and form which vein? That is small saphenous vein. Small saphenous vein formed on lateral side, great saphenous vein formed on medial side. Medial side. Here both are connected by some perforator, named perforator. Above knee perforator, below knee perforator, ankle perforator, mid thigh perforator. Like that, many perforators are there. Okay, the perforator names are so here in this level, I mean above the knee, the perforator is known as dots perforator. That perforator is known as what? DADD, dots perforator. Below knee, the perforator is known as Boyd perforator. Boyd perforator. Okay, below knee, Boyd's perforator. Above knee, dots perforator. Mid thigh level, there is a perforator. That perforator is known as Hunterian perforator. Hunterian perforator. Ankle level perforators are there. That perforator is known as Koncpt perforator. Koncpt perforator. So these are the perforator. These are the perforator. Then here it is draining here superficial external pudendal, superficial circumflex iliac vein, superficial epigastric. Like that, some of the veins drained into great saphenous vein. Okay, let us move on to the foot. Foot, sometime this layers of the sole of foot sometime important. Okay, so here first and third layer we have to remember. Fourth layer, so sole which is arranged in 4 layer. Sole which is arranged in 4 layer. Like hand, it is containing totally 20 muscle. Out of 20 muscle, 5 muscles are supplied by median nerve, remaining muscles are supplied by ulnar nerve. Out of that, adductor pollicis is important. So like that we have discussed. Sole, fourth layer, what are the structures seen? Third layer, what are the structure? Usually first layer you have to remember, third layer you have to remember. The remaining 2 layer easy. Fourth layer, it is very easy. It only contain intrasci. Intrasci. Okay, here what are the intrasci? Dorsal intrasci, plantar, dorsal intrasci, plantar intrasci. Both are seen in, all are seen in fourth layer. So fourth layer over. Second layer also easy. Second layer, which some of the muscles of leg enter here. See here, flexor digitorum longus tendon, flexor hallucis longus tendon enter. So longest tendons seen in second layer. Fourth layer contain intrasci. Make it simple. So longest tendon seen in, that is long tendon. From where it is coming? It is coming from leg region. It is seen in second layer. Okay. Also, so we already know lumbrical muscle which is originating from in hand, flexor digitorum profundus. Flexor digitorum profundus. So like that here also flexor digitorum longus giving lumbrical muscle. Lumbrical. So second layer contain longus, lumbrical. Okay. Then one more important muscle, quadratus plantae. Quadratus plantae. So these are the muscles seen in second layer. Fourth layer contain intrasci. Second layer contain longus. Longus tendon will give origin to lumbricus. So lumbrical also seen in second layer. Intrasci seen in fourth layer. Lumbrical seen in second layer. Please remember. Additionally, quadratus plantae, that is also seen in second layer. Then first layer, third layer, very important. First layer for here, please remember, this is great toe, this is little toe. Okay, we are going to remember by using action. First layer contain abductors of great toe and little toe. Please remember, first layer contain abductors of what? Abductors of, it is not applicable for middle toe. Abductors of great toe, abductors of little toe. Then third layer contain flexors of great toe, flexors of little toe. Please remember. So make it simple. First layer, what are the structure? Abductors of great toe, so single line. Abductors of great toe, abductors of little toe seen in first layer. Flexors of great toe, flexors of little toe seen in third layer. Lumbrical seen in second layer, interosseous seen in fourth layer. Lumbrical attached with the longest tendon, so longest tendon also seen in second layer. Okay, so quadratus planta also seen in second layer. Make it simple. So here first layer, we are going to complete that. What are the abductors of great toe? Abductors of great toe, abductor hallucis. Abductor hallucis, abductors of little toe, abductor digitae minimi, abductor digitae minimi. So abductors of great toe, little toe, middle flexor digitorum from brevis. Brevis means smaller. Okay, it is not longest. Flexor digitorum brevis seen in first layer. Okay, so flexor digitorum brevis, abductor digitae minimi, I mean abductors of great toe, abductors of little toe, in between flexor digitorum brevis. This is first layer. Second layer contain lumbricus, longest tendon, quadratus plantae. Third layer contain flexor of great toe, flexor hallucis. Okay, flexor of little toe, flexor digitae minimi. Then one more thing, adductor, opposite, adductor hallucis muscle. Okay, because abductor already seen in first layer. Here adductor seen. So in some way you have to remember, if any question coming in, we have to answer. Okay, then here this is the femur, lower limb femur. Here this is lesser trochanter, this is greater trochanter. Okay, one is lesser trochanter, another one is here we can see the greater trochanter. Lesser trochanter receiving iliopsoas muscle. Here it is receiving gluteus maximus medius pyriformis muscle. So these are the two important points we have to remember. This is line is known as linea aspera. Linea aspera usually providing attachment to vastae, three vastae muscle. Okay, let us move on to the next area, that is abdomen. So here abdomen, here at the central line, this line is known as linea alba. Central line is known as what? Linea alba. On both sides of linea alba, we can see rectus abdominis muscle. We can see rectus abdominis muscle. So rectus abdominis muscle, the central line is known as linea alba. Then laterally, so close to the central midline, we can see the close to the central midline, we can see the rectus abdominis muscle. Lateral side, we can see three oblique muscle, outer to inner, external oblique muscle, internal oblique muscle, some transverse abdominis muscle. So these are the layer: external oblique muscle, internal oblique muscle, transverse abdominis muscle, This is rectus abdominis muscle. So here we can see the complete external oblique muscle. So lateral aspect here, this is rectus sheath, which is enclosing. Here rectus abdominis muscle not seen. So rectus sheath, how it is formed, shortly we are going to discuss. So rectus sheath, which is enclosing rectus abdominis muscle, this is the linea alba. Now laterally external oblique muscle we are able to see. External oblique muscle direction is very important. It is running downward and medially. It is originating from ribs, running downward and medially, replaced by aponeurosis, inserted into linea alba. So this is external oblique muscle, external oblique aponeurosis. Inferiorly, external oblique aponeurosis thickened and form inguinal ligament. Inguinal ligament is a modification of external oblique aponeurosis. Inguinal ligament is a modification of external oblique aponeurosis. Like that, this external oblique aponeurosis forming two modification. One is inguinal ligament thickening. Inguinal ligament, also here it present on opening. That opening is known as superficial inguinal ring. So superficial inguinal ring is a defect of external oblique aponeurosis. Yes. Inguinal ligament is a thickening of external oblique aponeurosis. Yes. If we remove this, we can see next muscle. So see here already external oblique muscle that is running downward and medially, but internal oblique muscle which is running upward and medially, opposite side, internal oblique muscle. If we remove that muscle also, transverse muscle we are able to see. Transversus abdominis. If we remove this transversus abdominis, we can see fascia transversalis. Next muscle, fascia transversalis. Okay. So now here, so three muscle. First external oblique muscle, then internal oblique muscle, then transversus abdominis muscle. Here this is the midline, close to midline. Rectus abdominis muscle is present. Rectus abdominis muscle. Here it is enclosed by rectus sheath. Here one thing is clear. Here see, here external oblique muscle which is forming aponeurosis, that aponeurosis, it can cross rectus abdominis muscle either anteriorly or posteriorly. So this aponeurosis of external oblique, aponeurosis of internal oblique, aponeurosis of transverse abdominal only more logically can form rectus sheath, because rectus sheath, here rectus abdominis can't see because that is covered by external oblique aponeurosis. So what is the meaning? Rectus sheath is formed with this aponeurosis only. Okay, so we are going to draw our own diagram, rectus sheath formation. So for the rectus sheath formation, see here, this is the linea alba. This is the how rectus sheath is formed. For the rectus sheath formation, we have to here this is umbilicus level. Here this is the costal margin. Here umbilicus level. Here this is the pubic symphysis level. Pubic symphysis level. In between this umbilicus and pubic symphysis, there is a line. That line is known as arcuate line. That line is known as arcuate line. So we have to learn above the arcuate line how rectus sheath is formed. Okay. For example, here if you're taking section, if you're taking section, what are the structure above the arcuate line? How rectus sheath is formed? Below the arcuate line, how rectus sheath is formed? So first we are going to draw our picture for above the arcuate line. Then we will come to below the arcuate line. So first above the arcuate line, then below the arcuate line. So here this is the central line, that is linea alba. Both side of that, here rectus abdominis muscle is there. Rectus abdominis muscle is there. This is rectus abdominis muscle. Still laterally, here external oblique muscle, internal oblique muscle, transverse abdominis muscle. External oblique muscle, internal oblique muscle, transverse abdominis muscle. So this is EO, external oblique. This is IO, internal oblique. This is transverse abdominis muscle. So external oblique, that aponeurosis is running in front of that and attached to linea alba. External oblique running in front of that attached to linea alba. Internal oblique aponeurosis, when it is reaching this rectus abdominis muscle, it is divided into two lamina. One is running in front, one is running behind. Internal oblique, one lamina running in front, anterior lamina, one lamina running behind. Then this transverse abdominis running behind. So this picture for so here one thing we can say it very clearly, that is this picture for above the arcuate line. Above the arcuate line, here this is rectus abdominis muscle. Here it is covered by rectus sheath. Anterior layer is formed by external oblique, external oblique aponeurosis as well as internal oblique aponeurosis. Posterior layer is formed by the same internal oblique aponeurosis as well as transverse abdominis aponeurosis. So rectus sheath above the arcuate line, anterior layer is formed by external oblique aponeurosis as well as anterior lamina of internal oblique aponeurosis. Posteriorly, it is bounded by posterior lamina of internal oblique aponeurosis as well as transverse abdominis aponeurosis. Very simple. Then if we draw one more thing also, here fascia transversalis forming posterior layer. Very simple. But below the arcuate line, if you draw mean the same arcuate linea alba, here we can see the rectus femoris, rectus abdominis. Here external oblique muscle, internal oblique muscle, transverse abdominis muscle, the same external oblique muscle, internal oblique muscle, transverse abdominis muscle. All the lamina running in front of that. Below the arcuate line, all the lamina running in front of that. So anterior lamina here below the arcuate line, here above the arcuate line, below the arcuate line, anteriorly all the three external aponeurosis. Then posteriorly it is bounded only by fascia transversalis. Posteriorly this is fascia transversalis. Posteriorly only fascia transversalis. So in this way rectus sheath is formed above the arcuate line, below the arcuate line. Where arcuate line is seen? Here in between umbilicus and pubic symphysis seen. Then through the rectus sheath, what are the content of the rectus sheath? Rectus sheath which contain totally two muscle. One muscle already we know, rectus abdominis muscle, which also contain pyramidalis muscle. So rectus abdominis pyramidalis muscle, yes. Then it contains two artery. What are the artery? One is superior epigastric artery, another one is inferior epigastric artery. Two muscle. What are the two muscle? One is rectus abdominis, another one is here pyramidalis muscle. Pyramidalis, the nerve supply is very important. Pyramidalis is supplied by subcostal nerve. Root value T12. Subcostal nerve. Pyramidalis is supplied by subcostal nerve. Then the content are rectus abdominis, another one is pyramidalis, then superior epigastric artery, inferior epigastric artery, another one is inferior epigastric artery, then which also contains subcostal nerve, intercosto-abdominal nerve. So these are the content for the rectus sheath. In this way, rectus sheath is formed. Let us move on to next topic, that is inguinal canal. Now only we have completed inguinal ligament. Inguinal ligament is a modification of what muscle? Inguinal ligament is a modification of external oblique aponeurosis. So here this is the inguinal ligament. That inguinal ligament which is extended from anterior superior iliac spine to pubic tubercle. Inguinal ligament. So here also inguinal ligament. just above the medial of inguinal ligament, there is a canal. That canal is known as inguinal canal. That inguinal canal which is extended from deep inguinal ring to superficial inguinal ring. This is the superficial inguinal ring. Now only we have discussed superficial inguinal ring, also a modification of external oblique aponeurosis. External oblique aponeurosis forming two modification. One of the modification is known as inguinal ligament. Another one modification is known as, what is this? Superficial inguinal ring. Then here deep ring. So this is deep inguinal ring. So it is a superficial inguinal ring is triangular in shape. Superficial inguinal ring, what in shape? Triangular. Deep inguinal ring is rounded in shape or circular in shape. It is a defect seen in fascia transversalis. It is a defect seen in what? Fascia transversalis. It is a defect seen in external oblique aponeurosis. So from deep ring to superficial inguinal ring, here one canal is extending. That canal is known as inguinal canal. This deep ring and superficial ring is separated from each other by one artery. One artery. That artery is known as inferior epigastric artery. Okay, so this is inferior epigastric artery. Inferior epigastric artery, lateral to that, what opening is seen? That is deep inguinal ring. It is a defect of fascia transversalis. Medial to this, superficial inguinal ring. It is a defect of first layer of abdomen, external oblique aponeurosis. It is a defect of fourth layer of abdomen, fascia transversalis. From deep ring to superficial ring, one canal. That canal is known as inguinal canal. That canal is known as inguinal canal. Now we have to know the boundary. So already we have discussed here by using. So see here, triangular shaped opening, that is superficial inguinal ring. Circular shaped opening, that is a deep inguinal ring. From here to here, one canal is extending, that is inguinal canal. Here deep ring which lies lateral to inferior epigastric artery. Inferior epigastric artery is a branch of external iliac artery. Is a branch of external iliac artery. So superficial inguinal ring, where it is located, just above and lateral to the pubic tubercle, which is pubic tubercle, just above to pubic tubercle. What is superficial inguinal ring? Just above to the mid-inguinal point. Here see, mid-inguinal point, deep inguinal ring is located. Deep inguinal ring is located. Here, now we are going to discuss about their boundary. Boundary, here see, these are the sagittal section of abdomen. Here see, skin, superficial fascia, external oblique muscle. This is external oblique muscle, external oblique aponeurosis. Already we have discussed. External oblique aponeurosis condensed itself and form inguinal ligament. See, this is inguinal ligament. Inguinal ligament is a modification of external oblique muscle. This is external oblique muscle which is folded itself and form inguinal ligament. Which is folded itself and form inguinal ligament. So here inguinal ligament, here external oblique muscle. Both are continuous with each other. So already we know inguinal ligament is a part of external oblique muscle. So external oblique aponeurosis, here thickened and form inguinal ligament. Please remember this. Then deep to this external oblique, this muscle is internal oblique. Deep to that, what is this muscle? Transverse abdominis. Deep to that, what is this? Fascia transversalis. Deep to this, fascia transversalis. Now here, if we mark inguinal canal, this is the inguinal canal. This is the inguinal canal. So if this is the inguinal canal, this is the anterior side, this is the posterior side. Now we can write the boundary ourselves very easily. What is the anterior boundary? External oblique aponeurosis forming anterior boundary. What is the floor? Floor is formed by inguinal ligament. Floor is formed by inguinal ligament. Anterior boundary is formed by external oblique aponeurosis. External oblique aponeurosis. Posterior, this is posterior. Posterior boundary is formed by fascia transversalis. Fascia transversalis. Roof is formed by two muscle, internal oblique muscle as well as transverse abdominis. So it is very easy. So this is the inguinal canal. This is the inguinal canal sagittal section. Very easily we can say anteriorly external oblique muscle. Roof is formed by internal oblique transverse abdominis. Floor is formed by inguinal ligament. Inguinal ligament. Then here posteriorly fascia transversalis. Some additional structure can come because, for example, here inguinal ligament which is supported by one more ligament, lacunar ligament. So floor is formed by two ligament, inguinal ligament, another one is lacunar ligament. Then anterior boundary is formed by external oblique aponeurosis which is assisted by internal oblique muscle. Then roof is formed by these two only, internal oblique transverse abdominis. Then here posteriorly, this is fascia transversalis which is assisted by these two muscle collectively forming one tendon. The tendon is known as conjoint tendon. So that conjoint tendon also forming, see here these two, this brown color which is extending down, that is conjoint tendon. That is conjoint tendon. So again, finally, anterior boundary is formed by external oblique muscle as well as internal oblique muscle. The floor is formed by two things. One is inguinal ligament, another one is lacunar ligament. Roof is formed by internal oblique muscle, transverse abdominis muscle. Posterior boundary is formed by fascia transversalis, also conjoint tendon. Conjoint tendon is a combination of internal oblique muscle, also transverse abdominis. This conjoint tendon also known as falx inguinalis, FALX inguinalis, falx inguinalis. Just to remember conjoint tendon, that is enough.
It is a combination of two things. What is the combination of internal oblique muscle, transverse abdominis muscle collectively forming conjoint tendon? Conjoint tendon going to form which boundary? Posterior boundary. Then let us move on to the content. Through this canal, there are two contents are, in case of male, there is one content, that content is known as spermatic cord is descending down. In case of male, what is descending down? Spermatic cord. In case of female, round ligament of uterus. Round ligament of uterus. So what are the content? In case of male, spermatic cord. In case of female, round ligament of uterus is descending down. Also, here one more nerve is coming down, that is ilioinguinal nerve. So what are the content in male? Spermatic cord, ilioinguinal nerve. What are the content in female? Round ligament of uterus as well as ilioinguinal nerve. Okay. So here this is spermatic cord, which is descending down, which is suspending the testis, So spermatic cord, what are the structure present? What are the coverings of the spermatic cord? What are the content of the spermatic cord? We have to learn. So full content from deep ring to superficial ring. The full content is one is spermatic cord, male. Female, round ligament of uterus. Then from this region, ilioinguinal nerve will enter. So ilioinguinal nerve is considered as a partial content. This spermatic cord, round ligament of uterus considered as a full content. Okay, entire content, partial content. Ilioinguinal nerve is a partial content. Please remember. Okay, so here spermatic cord, if you put section here, we can see three covering. See, this is the spermatic cord. We are taking section. It is covered by three fascia: external spermatic fascia, cremastic fascia, internal spermatic fascia. There are three covering: external spermatic fascia, cremastic fascia. Another one is internal spermatic fascia. External, cremastic, internal. Then inside we can see vas difference or ductus difference. Vas difference or ductus difference. Okay. Then very close to that, to providing vas difference or ductus difference. Okay. So to providing artery, here artery to ductus difference. Then one more thing, testicular artery is there. Pambiniform plexus of vessels are there. One more very important thing. Please remember. Spermatic cord contain genital branch of genitofemoral nerve. Genitofemoral nerve, which is divided into two branch. Genitofemoral. So femoral branch, genital branch. Femoral branch of genitofemoral nerve is a content of femoral sheath. Already we have discussed femoral sheath. In front of femoral artery, one nerve lies within the femoral sheath. That nerve is known as femoral branch of genitofemoral nerve. So femoral branch of genitofemoral nerve is a content of femoral sheath. Here, genital branch of genitofemoral nerve is a content of which one? Spermatic cord. Spermatic cord contain which nerve? Genital branch of genitofemoral nerve. Please remember. Here, question will come. So this spermatic cord. Okay, so spermatic cord in male, what are the content? Spermatic cord plus ilioinguinal nerve. See, ilioinguinal nerve which lies outside. Ilioinguinal nerve not a content. Ilioinguinal nerve is a partial content. Spermatic cord is a full content. Spermatic cord section. These are the things are seen inside genitofemoral nerve seen, but outside ilioinguinal nerve seen. Always this area will give confusion. Spermatic cord contain genital branch of genitofemoral nerve. Outside the spermatic cord, partial content ilioinguinal nerve. Ilioinguinal nerve is not a content of spermatic cord. Spermatic cord only contain genitofemoral nerve. Please remember, genitofemoral nerve. Okay, so this genital branch of genitofemoral nerve going to supply cremaster muscle by giving CRC cremastic nerve. Okay, so genital branch of genitofemoral nerve going to supply cremaster muscle. Okay, so these are the things we have to remember. So in male, spermatic cord contain on nerve. What is that nerve? Genital branch of genitofemoral nerve. Femoral sheath contain on nerve. What is that? Femoral branch of genitofemoral nerve. Okay, then ilioinguinal nerve is a entire content or partial content? Partial content. Why it is partial content? It is only passing through superficial ring, not traversing through deep ring, because it is piercing the wall and come. Okay, so so it is a partial content. So ilioinguinal nerve is not a content of spermatic cord. So these are the things we have to remember. Then the external spermatic fascia, cremastic fascia, internal spermatic fascia, not only forming spermatic cord, the spermatic cord suspending the testis. So here spermatic cord which is suspending the testis, at the time all the three layer, I mean external spermatic fascia, cremastic fascia, internal spermatic fascia, also going to form the scrotal layer. So scrotum also covered by external spermatic fascia. Okay, another one is cremastic fascia, external fascia, cremastic fascia, internal spermatic fascia. All are forming scrotal covering as well as spermatic cord covering. So here testis we able to see. So testis, separately, which is covered by three layer, immediately covered by tunica. Here see, tunica vaginalis, outermost covering. Then tunica albuginea. Then tunica vasculosa. So testis from outside to inner side, these are the covering: external spermatic fascia, cremastic fascia, internal spermatic fascia, tunica vaginalis, deep to tunica vaginalis, tunica albuginea, deep to that one more layer, tunica vasculosa. So these are the coverings for the testis. These are the coverings for the testis. So in case tunica vaginalis, any fluid collection, that is known as hydrocele. That is known as hydrocele. So here testis blood supply, we can enter into testis blood supply. So here testis, here totally it is not only supplied by testicular artery. So testicular artery, we already know it is a direct branch of abdominal. Gonadal vessels are branch of aorta. Gonadal branch of is a branch of directly branch of aorta. Okay, so it is supplied by 3 artery. It is not only supplied by testicular artery, it is also supplied by artery to vas deferens. Here there is an MCQ: differential artery, artery to vas deferens, differential artery. Okay, artery to vas deferens is a branch of superior vesical artery. Here whether it is a branch of superior vesical artery or inferior vesical artery, always confusion will come. But artery to vas deferens is a branch of superior vesical artery. Please remember, artery to vas deferens is a branch of superior vesical artery. Testicular artery is direct branch of aorta. Then it is also supplied by one more artery, that is cremastic artery, inferior epigastric artery, cremastic artery, cremastic artery. Totally 3 arteries supplying the testis. Then venous drainage, it is drained by paminiform plexus of veins. Okay, then testicular vein is formed. Here very important thing, this is right testis, this is left testis. Right testis drained into IVC. Please remember, right testis drained into IVC. Right testis drained into IVC, but left testis drained into renal vein. Left testis drained into renal vein. Okay, so in renal vein, in acute angle it is opened, so left side varicocele is common. Here it is drained into some broader vein. Okay, so broader vein, but here some acute angle is maintained. So here it is drained into renal vein, it is drained into IVC, left side varicocele is common. Left side varicocele is common. Then one more thing, here blood testis barrier is formed by what? Here inside seminiferous tubule. So the unit of testis is seminiferous tubule. If we take the section of seminiferous tubule, inside many supporting cells are there. Okay, nutrition providing cells. That cells are known as Sertoli cell. So here one Sertoli cell forming on a tight junction with adjacent Sertoli cell. So Sertoli cell to Sertoli cell junction or adjacent or something cell junction forming blood testis barrier. Blood testis barrier is formed by Sertoli cell to Sertoli cell adjacent. Sertoli cell to Sertoli cell adjacent. Okay, so abdominal wall over external genital organs. Okay, male external genital organ. Another one is inguinal canal over. Well, let us move on to internal structure, that is stomach. Here stomach from above down, which is divided into fundus, body. Another one is pyloric region. Pyloric region. Here inside, if we open the stomach, inside we are able to see many folds. These folds are known as rugae. What are the names for these folds? These folds are known as rugae. Okay, so here we can see this is fundus, this is lesser curvature, here greater curvature, greater curvature. This lesser curvature providing attachment to one ligament. That ligament is known as lesser omentum. That ligament is known as lesser omentum, which is extending from liver to stomach, which is extending from liver to stomach. Lesser omentum is extending. Then here greater curvature we are able to see. Greater curvature, greater omentum is attached. Greater curvature is attached. Now here we are going to put, so this is greater omentum attached to greater curvature, lesser omentum which is attached to lesser curvature. Okay, now we are going to put incision through this greater omentum and we are going to lift the stomach. So at that time we can see what are the structure present posterior to stomach. Stomach bed structure we are going to learn. So here stomach, that is separated from greater omentum and lifted. Here we able to see few structure. Okay, but it is not clear. Here pancreas we able to see. Can you able to see pancreas? Yes. This is suprarenal gland. Here spleen we able to see. Here kidney we able to see. What is this? Kidney. So here few structures we able to see. What are the structure we able to see? Here this is suprarenal gland. Suprarenal gland we able to see. Here left kidney we able to see. Left kidney. Here pancreas we able to see. Pancreas we able to see. Here spleen we able to see. Spleen we able to see. Transverse colon we able to see. This area is transverse mesocolon we able to see. Transverse mesocolon we able to see. So these are the structures are present posterior to stomach. So these are the structure going to form stomach bed. So a little bit fat, if we clear this, we can see more clearly. Okay, so here the following structures we able to see. What are the structures we can see? Here see posterior stomach that is cut and removed. So here we can see left kidney, one of the stomach bed structure, left suprarenal, one of the stomach bed structure, pancreas, stomach bed structure, splenic vessel, stomach bed structure, spleen, stomach bed structure, transverse colon. Okay, this anterior aspect of pancreas, transverse mesocolon. Okay, so this thing, splenic flexor of colon, everything forming stomach bed, everything forming stomach bed. Again I'm repeating, stomach bed is formed by what is this? Here splenic left is formed by here left kidney, left suprarenal, pancreas, splenic vessels. Another one is here spleen, here transverse mesocolon, transverse colon, all are forming stomach bed, all are forming stomach bed. Here itself we can understand relations of kidney also. Here see, kidney is there, kidney is there. What are the relations of kidney? It is crossed by splenic artery, it is crossed by pancreas, it is crossed by colon. Then here after removing stomach only we able to see, so this area will be related to stomach. Then it is capped by what is this? Suprarenal gland. Then it is related to spleen also. So very easily we can explain. So kidney, in front of that, what are the structures seen? In front of that pancreas seen, in front of that here above, here suprarenal, here stomach, gastric area, below pancreas, below colon, then spleen. The same picture we can derive easily. Okay, so next, so here see the same left kidney, the uppermost area suprarenal, then this area is pancreas, this area is gastric, this area is spleen, here colon, jejunum, here colic area, jejunal area. Very simple. Okay, so stomach bed and kidney relation simultaneously you remember, okay. So these are the structures forming I mean stomach bed structure we finished, anterior relations of left kidney also we finished. Then please move to the right kidney anterior, simultaneously right kidney also here itself we can finish. So for this, here after removing all the thing, here left kidney, liver and all removed. Okay, so here left kidney we able to see, left suprarenal gland we able to see here because after removing liver we able to see, so this area will be hepatic area because liver largest organ. Okay, after removing that we able to see this mean this area is covered by what? That is liver. So this area is related to hepatic area. This is suprarenal gland. Then close to hilum, this is second part of duodenum is crossing, then colon is crossing, this small area related to jejunum. So we can make it simple. So this is hepatic area, below to that colic area, hilum is covered by what? Duodenum, capped by suprarenal gland, then colic area, jejunal area. So what are the organs forming anterior relations of kidney? Stomach bed structure, anterior relations of right kidney, left kidney, all are, we can answer very easily. Okay, then here come to the celiac trunk and its branches. Celiac, arterial blood supply to the stomach. So here it is supplied by celiac trunk because stomach is foregut, so it is supplied by celiac trunk. So here what is this? Celiac trunk. Celiac trunk giving 3 branches directly. This is left gastric artery. This artery is left gastric artery. Another one artery is splenic artery. Another one artery is common hepatic artery. Another one artery is common hepatic. So here then this common hepatic artery, which is divided into gastroduodenal artery, proper hepatic artery, gastroduodenal proper hepatic. This gastroduodenal artery coming down divided into superior pancreaticoduodenal artery, right gastroepiploic. This is right gastroepiploic artery, gastroepiploic artery. Splenic artery giving left gastroepiploic artery. Also here this proper hepatic artery giving right gastric artery. This is right gastric artery. This is left gastric artery. Splenic artery giving many short gastric artery, many short gastric artery. So this is the final picture. Okay, so here celiac trunk branches we are going to discuss. Celiac trunk collectively giving 3 main branches. One is left gastric artery is the main branch. This is the principal supply to the stomach. Then it is giving splenic artery. It is giving splenic artery. Then it is giving common hepatic artery. Common hepatic artery divided into gastroduodenal artery, proper hepatic artery. Gastroduodenal artery coming down divided into superior pancreaticoduodenal artery as well as right gastroepiploic artery. Right gastroepiploic artery. If we trace splenic artery, it is tortuous in course, which is giving left gastroepiploic artery as well as short gastric artery. See here splenic artery, here it is giving left gastroepiploic artery running along the greater curvature. It is also giving short gastric artery. Then if you're giving this is left gastric artery, then this is common hepatic divided into proper hepatic artery. Also it is giving one more thing, gastroduodenal artery, gastroduodenal divided into superior pancreaticoduodenal, right gastroepiphylic, left gastroepiphylic, anastomosing with each other. Then proper hepatic artery giving one more branch, that is right gastric artery, left gastric artery, both are anastomosing with each other. Out of all the thing, the principal supply is provided by left gastric artery. Okay, so this point we have to remember. So this is about arterial supply. If you the corresponding vein, for example, left gastric vein. So this is left gastric vein. This is right gastric vein. Okay, so both the left gastric vein as well as right gastric vein drained into portal vein directly. What are the vein directly drained into portal vein? Left gastric vein, right gastric vein, both are drained directly into portal vein. Then here, how portal vein is formed? So portal vein, which is formed by, see here, splenic vein is coming. This is splenic vein. Splenic vein, in its course, it is receiving inferior mesenteric vein, hindgut vein. So splenic vein receiving inferior mesenteric vein. After that, here it is coming. Here it is joined with superior mesenteric vein. So superior mesenteric vein, splenic vein, both are joined together behind the neck of pancreas. That landmark is very important. Behind the neck of pancreas, portal vein is formed. So here, splenic vein, this is inferior mesenteric vein. Splenic vein joined with superior mesenteric vein behind the neck of pancreas, portal vein is formed. What are the tributaries of portal vein? Portal vein totally receiving three direct tributaries. The direct tributaries are the point number 1, it is receiving left gastric vein. It is receiving right gastric vein. So left gastric vein, it is receiving right gastric vein. It is receiving another one vein is superior pancreaticoduodenal vein. So it is totally receiving three veins. So what are the direct tributary? One is left gastric, another one is right gastric, another one is superior pancreaticoduodenal vein. So splenic vein is coming here, inferior mesenteric vein, superior mesenteric, both are joined together and form portal vein. Portal vein receiving three tributary. We have finished that. Okay, so here this is a greater omentum, this is a lesser omentum. Here this free border of lesser omentum is very important. So lesser omentum is attached to lesser curvature of stomach. Okay, so this is free border. Here it is attached completely. But here it is free. Okay, if we insist this free border, is any structure seen inside? Yes, if we insist this free border, totally three structure we able to see inside. One is bile duct, another one is hepatic artery, another one is portal vein. So totally three structure. So in the free border of lesser omentum, this is border is free because it is stretching from liver to duodenum, but it is free. If we insist this area inside, bile duct seen, hepatic artery seen, portal vein seen. So here we can pass our finger behind this free border. This free border contain three structure. We can pass our finger this through this, because behind the stomach and lesser omentum, behind to stomach, we able to see one space. That space is known as lesser sac. Everywhere this space is known as greater sac. For example, this area is greater sac. Okay, it is present all over abdomen, but for example, imagine this area is greater sac. But behind the lesser omentum as well as stomach, this area is known as lesser sac. So this is a lesser sac, this is greater sac. So greater sac and lesser sac communicate through one foramen. That foramen is known as foramen of Winslow, W-I-N-S-L-O-W, Winslow or epiphylic foramen. Epiphylic foramen, where it is present? Behind this free border of lesser omentum, it is present. So this epiphylic foramen, what are the boundary we can tell? So if this is epiphylic foramen, above what is seen? Liver is seen. Below what is seen? Duodenum is seen. What lies in front? This free border. This free border contain how many structure? 3. So if free border present anterior mean, those 3 structures also will form anterior boundary to epiphylic foramen. Logical. So this free border forming anterior boundary mean this contain bile duct, this contain hepatic artery, this contain portal vein. All the 3 structure will form anterior relation to epiphylic foramen. Okay, so this is epiphylic foramen. So bile duct forming anterior boundary, hepatic artery forming anterior boundary, portal vein forming anterior boundary. Is any other classical picture? Yes, this is the epiphylic foramen. Above liver, below duodenum, anteriorly free border, which contain bile duct, hepatic artery, portal vein, anterior boundary. Then posteriorly, what it lies? Posteriorly, IVC, T12 vertebra. Please remember. So epiphylic foramen anteriorly on major vein is present. That vein is portal vein. Yes. Posteriorly on major vein is present. That vein is known as IVC. Yes. We can pass probe in between portal vein and IVC. That space at the level of T12 is known as epiphylic foramen. Yes, that is known as epiphylic foramen, which is also known as foramen of Winslow. This is the only communication from lesser sac to greater sac. We have to remember that. Okay. Then next important, liver. Okay. So liver. What are the points are important? So here liver, this is the anterior aspect, falciform ligament is attached. So this ligament is known as falciform ligament. By using this falciform ligament, liver is divided into major right side, smaller left lobe, major right lobe, larger right lobe, smaller left lobe. This is falciform ligament. Falciform ligament above divided into coronary ligament. Coronary ligament continues as triangular ligament. Okay, then it is stretched to diaphragm. So if we turn the liver, we can get the picture like this. If we turn the liver, here we can see the IVC. We can see the IVC. Okay, here porta hepatis. Here porta hepatis. Below the IVC, we can see gallbladder. Gallbladder, IVC we able to see. Okay, so then here this is the porta hepatis. Below the porta hepatis, one lobe. This area is known as quadrate lobe. Above to that one lobe, this lobe is known as caudate lobe. So this is caudate lobe, very close to IVC. Quadrate lobe, very close to gallbladder. Then here there are two ligament. So both are very important. This is known as ligamentum teres. Ligamentum teres. This is known as ligamentum venosum. This is known as ligamentum venosum. So this is ligamentum teres. This is ligamentum venosum. Ligamentum teres is a remnant of left umbilical vein. Ligamentum teres is a remnant of left umbilical vein. Ligamentum venosum is a remnant of ductus venosus. So these 2 points we have to remember. Okay, there is no time. What is it? How it is formed? To explain all the things, there is no time. So here, what is this? Ligamentum teres is a remnant of left umbilical vein. Ligamentum venosum is a remnant of ductus venosus. Okay, this is caudate lobe. This is quadrate lobe. This is porta hepatis. This is bare area of liver. Bare area of liver, not covered by this peritoneal covering. So here, this porta hepatis, anterior to posterior, how structures are arranged. So DAV. So the mnemonic is DAV. So anterior most structure is this bile duct. Anterior most structure is bile duct. Then A for artery, hepatic artery, then vein. DAV, anterior to posterior. Okay. So next here, we already discussed falciform ligament. By using falciform ligament, liver, which is divided into smaller left lobe. This is the attachment level of falciform ligament. Falciform ligament. So which is divided into smaller left lobe, larger right lobe. But physiologically, functionally, there is a line. That line is known as Cantley line. Okay, Rex Cantley line. So that is which is extending from this IVC to gallbladder. IVC. So choledochal vena cava. Choledochal vena cava line. Choledochal vena cava line. So physiologically, this line is used. So this side is right, this side is left. Like that, they will divide. Okay. Here, usually here that Quinault classification. Liver, which is divided into how many segment? 8 segment. How? By using hepatic vein as well as portal vein. Hepatic vein and portal vein, Quinault divide the liver into 8 segment. Okay. How? This falciform ligament, very easy. Falciform ligament, which is corresponding to one vein. That vein is known as left hepatic vein. So this is a left hepatic vein, which is corresponds to falciform ligament. Then this line, which is extending from vena cava to gallbladder, which is corresponds to middle hepatic vein. Middle hepatic vein. Middle hepatic vein. Here one more hepatic vein is seen, that is right hepatic vein. See, there are 3 hepatic veins. By using this liver, which is divided into 4 sector. So 1, 2, 3, 4 area. Okay. Now portal vein, which enter through porta hepatis, that portal vein is divided into right and left. For example, portal vein, how it is enter, it is divided into right as well as left. Right as well as left. Right as well as left. Okay. First, initially, these are hepatic vein. 3 in number: hepatic vein, middle hepatic vein. This is left hepatic vein. This is right hepatic vein. Right hepatic vein. Now, this one is known as portal vein. This one is known as portal vein. Now, initially here 1, 2, 3, 4 areas we got. Now it is transversely divided into 8 segments. This is segment number 1, 2, 3. All are numbered from anti-clockwise direction. All are numbered from clockwise direction. 1, 2, 3, 4, 5, 6, 7, 8. 7, 8. Yes, any doubt? Aarti Priyadarshini? Excuse me, one of you reply. Can you hear?
Sir, sorry.
Someone raised a hand. Any doubt? Can I continue?
No, sir.
Can I continue? Okay, so here this is a portal vein. By using this, liver totally divided into 8 segment. For example, so here this is the line. This is the line. Now everything easily. So this is the line. So physiologically, liver divided into 2 things. So segment number 5, 6, 7, 8 present in right side. Segment 1, 2, 3, 4 present in left side. So for example, any questions like liver, this is the level of falciform ligament. So falciform, left of the falciform ligament is removed mean. What are the segment will be removed? 2 and 3 will be. So left of the falciform, this is the falciform ligament level. Left of the falciform ligament, 2 and 3 will be removed. Here actually it is not correct. This entirely 4. This segment 1 is considered as a caudate lobe. This segment 1, for example, 1 I told you know that segment 1 is belong to caudate lobe. Segment 1, which is segment 1, caudate lobe. Caudate lobe, that is some peculiarity. For example, all the other thing 2, 3, 4, 5, 6, everything is drained by this hepatic vein. See here 2, 3, 4 drained by hepatic vein. All the direct things are drained by hepatic vein, that is drained into IVC. That is drained into IVC. But here, what is this? Here, one of the syndrome is known as Budd-Chiari syndrome. Budd-Chiari syndrome, what is taking place? This hepatic vein, that is thrombosis. So hepatic vein undergoes thrombosis. It is undergoes thrombosed. So it will affect all the other segment, but except one, because this caudate lobe, that is also known as posterior lobe. Posterior lobe, segment 1, caudate lobe, all are synonyms. So segment lobe directly drained into IVC. Directly drained into IVC. Okay. So in case Budd-Chiari syndrome, I mean this thrombosis, this caudate lobe won't be affected. It undergoes enormous enlargement. It compensates the liver function. So Budd-Chiari syndrome, which segment is not affected? Segment 1, because it is directly drained into IVC, not through hepatic vein. Because hepatic vein thrombosis is known as Budd-Chiari syndrome. Okay, so that will lead to caudate lobe hypertrophy. Then liver blood supply is important. 80% portal vein. This percentage is important. 80% portal vein, 20% hepatic artery. 80% portal vein, 20% hepatic artery. That percentage is very, very important value, numerical. Then here, let us move on to gallbladder. Gallbladder, here it is divided into fundus of gallbladder. Okay, here body of gallbladder. Then here neck of gallbladder. It is continuous with the cystic duct. Inside the cystic duct, there is a valve that is known as Heisner's valves. Okay, inside Heisner's valves are seen inside. Then cystic duct joined with here hepatic duct, right hepatic duct, left hepatic duct. This is common hepatic duct. Hepatic duct, cystic duct joined together and form bile duct. Coming down, this bile duct joined with the pancreatic duct. So this is common hepatopancreatic ampullae, which opens into amble of Vater, major duodenal papillae. So this is about biliary system. This is about biliary system. See here, this is common bile duct is coming down. It is joined with the major pancreatic duct. Here it is opens into major duodenal papillae. Accessory pancreatic duct opens into minor duodenal papillae. This is major duodenal papillae. This is minor duodenal papillae. Okay. So here two things are very important. Sphincter of OD. Sphincter of OD. How many sphincters are there? Sphincter of OD totally contain 3 sphincter. Okay. For example, this is bile duct is coming down. Totally contain 4 sphincter. So here bile duct is coming. This bile duct is guarded by 2 sphincter. Okay. So here this is superior choledochal sphincter. This is inferior choledochal sphincter. Both are present in common bile duct. Superior choledochal, inferior choledochal, 1 and 2. Where it is present? Common bile duct. Then this is pancreatic duct, which contain pancreatic sphincter. Now this bile duct and pancreatic both are joined together and form one common ampullae, that is having ampullary sphincter. That is having ampullary sphincter. So superior choledochal, inferior choledochal, sphincter, pancreatic sphincter, ampullae, all are collectively known as sphincter of OD. All are collectively known as sphincter of OD. So the superior choledochal, inferior choledochal also known as Boyden sphincter. BOYDEN, Boyden sphincter. Okay. Then here something about Callet triangle. Here Callet triangle, hepatobiliary triangle, it is giving confusion. So we have to clarify that hepatobiliary triangle, Callet triangle, both are not same. Both are not same. So here this is gallbladder, this is cystic duct, this is common hepatic duct. So this is common hepatic duct, this is cystic duct. Here liver we able to see. Okay. So liver, common hepatic duct, cystic duct. Okay. So 3C. Okay. So here common hepatic duct, cystic duct, here under surface of liver. Okay. Caudate lobe of liver. So this is hepatobiliary triangle. Okay. Hepatobiliary triangle, which contain, see, this is proper hepatic artery divided into left hepatic artery, right hepatic artery. So right hepatic artery is a content of that hepatobiliary triangle. This right hepatic artery giving cystic artery. That is also a content. That is also a content. So hepatobiliary triangle. What are the content? Right hepatic artery, cystic artery. Here one lymph node is there. That lymph node is known as the Koncpt lymph node. There are three structure for hepatobiliary triangle. But here, see, this is triangle properly known as Koncpt triangle. So here, this is collectively known as hepatobiliary triangle. Hepatobiliary triangle. Within that, here, see, cystic artery, common hepatic duct, another one is cystic duct, 3C. Okay, cystic artery is not a content of Koncpt triangle. Cystic artery is a boundary for the Koncpt triangle. So cystic artery, another one is what? This cystic duct, another one is what? Common hepatic duct. These three forming one triangle. That is known as Koncpt triangle. Within the Koncpt triangle, which is the proper content, that is this Koncpt lymph node of Clark. So cystic lymph node of Lund, which is also known as Lund lymph node. Okay, so cystic artery is 3 C's for the Koncpt triangle. So the differentiation is very important. Sometime here before that, so when we open during cholecystectomy, we are going to ligate this cystic artery. So here right hepatic artery should undergo straight course like this. Then it is giving cystic artery. We are ligating cystic artery, but sometime right hepatic artery, which is undergoing some abnormal tortuous course like this, that is known as Moynihan-Schumm caterpillar turn. So in case accidentally we will ligate right hepatic artery instead of this cystic artery. See, it is undergoing some abnormal course. So that is known as Moynihan-Schumm or caterpillar turn. Okay. Then most common anomaly of gallbladder. Okay. Which is the commonest anomaly of pancreas? Pancreas commonest anomaly, is it annular pancreas? No. Pancreas, the commonest anomaly is pancreatic divisum. Pancreas commonest anomaly is pancreatic divisum. Like that, here in gallbladder, the commonest anomaly is Phrygian cap. These two, please remember. Pancreas commonest anomaly, one word, very, very important. Like that gallbladder, which is the commonest anomaly, Phrygian cap. Okay. So like that gallbladder, that bile duct which is coming down now, the bile duct which is receiving blood supply from above mainly or below mainly. That is very important. It is bile duct which is mainly supplied by, please remember, this is the gastroduodenal artery, which is giving one of the artery is known as retroduodenal artery. So bile duct, which is the primary support, primarily it is supplied by below, from below. Please remember, bile duct, it is not because it is supplied by this right hepatic artery as well as cystic artery also, it is supplied from above, but mainly it is receiving blood supply. So because these are the artery coming from above, these are the artery going from below only it is mainly supplied. Out of that, here mainly it is supplied by retroduodenal artery. It is mainly supplied by, at least this point please remember, retroduodenal artery is the main artery supplying that. Then let us move on to duodenum. So stomach, liver, extrahepatic biliary apparatus, everything we have completed. So duodenum which is divided into 4 parts. So this is first part of duodenum, second part of duodenum, another one is third part. This is fourth part of duodenum. It is a C-shaped cavity. This C-shaped cavity which is occupied by pancreas. Okay. So here inside, if you open the duodenum, inside many folds are seen. Okay. These are known as Herkring fold walls. Okay, Herkring walls. These are known as Herkring wall. Here major duodenal papillae we are able to see, minor duodenal papillae, major duodenal papillae, that is hepatopancreatic ampulla will open. This is accessory pancreatic duct opens into minor one. So here this Herkring wall that is absent in first 2 cm of duodenum. So this is smooth walled. Okay. So in case of radio opaque dye, barium swallow or something, this area will have, because see there is no fold inside, so this wall will be smooth. So this is the basic for the duodenal duodenal cap, first 2 cm smooth walled. But here that is the walls are puckered appearance. Okay, so these are the things we have to remember. Some important relation we have to know. Here see, out of that second part of duodenum, I want to highlight the most important one, the second part of duodenum, which runs in front of left hilum, left renal hilum. See, sorry, right hilum. So in front of right kidney. So this is right kidney, left kidney. In front of right kidney, especially hilum, renal vessel center. hilum in front of that, as well as ureter, this second part of duodenum. So second part of duodenum lies in front of right kidney. Please remember at least that point. Okay. So second part of duodenum, that is the vertical point which lies in front of right kidney. Like that, third part of duodenum, which lies in front of aorta. Another one is inferior vena cava, but that is not so important. Anterior relations of third part of duodenum is important. See here, second part which lies in front of kidney, third part anteriorly crossed by superior mesenteric vessels. Very, very important. So third part of duodenum anteriorly crossed by what? Totally superior mesenteric vessels, as well as root of mesentery. So totally three structure, please remember. This third part of duodenum anteriorly crossed by superior mesenteric vessels as well as root of mesentery. See here, very clearly seen. Second part of duodenum which lies in front of kidney. This is the third part of duodenum. This is posteriorly aorta seen, posteriorly vena cava seen, but anteriorly superior mesenteric vessels are seen. We can say the third part of duodenum which lies in between aorta and superior mesenteric vessel. Any classical picture? Yes, this is duodenum. Here this is aorta. Here aorta giving one of the ventral branch, that is known as superior mesenteric artery. So superior mesenteric artery and aorta, that angle is known as aortico-mesenteric angle. In that angle, third part of duodenum is present. So sometimes this aortico-mesenteric angle should be above 30 degree. Sometimes if it is lesser than 20 degree or 25 degree, sometime what will happen? Superior mesenteric artery can compress this third part of duodenum. So please remember here aorta, which is giving one ventral branch, superior mesenteric artery. This angle is aortico-mesenteric angle. This aortico-mesenteric angle contains two structure. See here, this is superior mesenteric artery, posteriorly aorta. So two structure are going. One structure is known as duodenum, another structure is known as left renal vein. So left renal vein also there, duodenum also there, both can be compressed. Duodenum compressed means that syndrome is known as Wilkie syndrome. Wilkie syndrome, W-I-L-E-K-E-S, Wilkie syndrome. Okay. Left renal vein compressed mean nutcracker syndrome. We will come to that later. Okay. Aortico-mesenteric angle, if it is reduced mean third part of duodenum can be compressed. That can lead to duodenal obstruction. Very, very important. Like that, the second part of duodenum is most common site for one of the site for in small intestine. This is the commonest site of acute diverticulum. Okay. So this point we have to remember. Then blood supply. Here, this is supplied by here already gastroduodenal artery. This gastroduodenal artery divided into, already we know, right gastroepiphytic artery, superior pancreatico-duodenal artery, inferior pancreatico-duodenal artery is a branch of superior mesenteric artery running in front of third part of duodenum. At the time it can compress this part of duodenum, that can lead to duodenal obstruction. So it is applied by mainly superior pancreatico-duodenal as well as inferior pancreatico-duodenal. Then here sometime this first 2 centimeter of duodenum, what is the blood supply? First 2 centimeter, I mean duodenal cap, because in this area if we dissect inside there is no lumen, inside there is no fold, Kirkring fold. So this area is supplied by what are the artery? See here, gastroduodenal artery descending down. Okay, so this area is supplied by gastroduodenal artery. Here right gastroepiphytic artery, right gastric artery. Okay, so above horizontally one artery is running, right gastric. Below horizontally one artery is running. Here vertically one artery is running. Then above to that here common hepatic artery. So it can be this first 2 centimeter of duodenum. So especially this area, what is the blood supply? Questions can come. First 2 centimeter is supplied by this transversely running right gastric, transversely running right gastroepiphytic, this common hepatic artery, vertically running gastroduodenal. One more artery here, it is supraduodenal artery. So bile duct is mainly supplied by what artery? That is retroduodenal artery. Then this first 2 centimeter is supplied by supraduodenal, which is also known as artery of Wilkie. So supraduodenal can supply first 2 centimeter of duodenum. Then like that, bile duct is mainly supplied by retroduodenal artery. So it is the main source for the bile duct. Please remember that. Then duodenal ulcer is the commonest one. Peptic ulcer, commonest site duodenum. So it can perforate the wall. Anterior wall, if it is anterior wall, posteriorly, if it is perforating mean, it can lead to hemorrhage because gastroduodenal artery is there. We have to remember that. Then pancreas. So here this is superior mesenteric vein, superior mesenteric vessel, which is accompanied by superior mesenteric artery. It is not only the superior mesenteric vessel. Now only we have discussed it is running in front of third part of duodenum. Okay, so it is also running in front of uncinate process. So in case of uncinate process, tumor or something, okay, it can compress or affect which vessel? Superior mesenteric vessel. Behind the neck of pancreas, what is formed? Portal vein is formed. So these are the two things we have to remember. Then here jejunum and ileum. Jejunum and ileum mainly that peritoneal windows. I mean here superior mesenteric artery, superior mesenteric. So here celiac trunk, we already discussed the level of origin is T12. Celiac trunk, the level of origin T12. Then superior mesenteric artery, level of origin is L1. Below, if you coming inferior mesenteric artery, these three considered as a ventral division. So celiac trunk, ventral division, superior mesenteric artery, ventral division, then inferior mesenteric artery also ventral division. So this the level is L1, inferior mesenteric artery L3, celiac trunk, the level is T12. So superior mesenteric artery, here it is giving inferior pancreaticoduodenal artery. Also it is supplying jejunal branch, ileal branch, jejunal branch, ileal branch. What is the difference between jejunum and ileum? See, this is superior mesenteric artery. Here it is giving many jejunal branch. This jejunal branch forming arterial arcade, arterial arcade. So this is for jejunum. Jejunum, arterial arcade. For example, count 1, 2. Arterial arcade is just 2 in number. But ileum, it is also supplied by superior mesenteric artery. Here arterial arcades are more. Okay, so here if we examine, when we open the peritoneum, here arterial arcade few in number. See, longer arterial arcade, but 1, 2, only 2 arterial arcade. So minimum arterial arcade seen mean what is this? Jejunum. But here see more arterial arcade more mean that is ileum. So this region is ileum, this region is jejunum. Then after arterial arcade, see here arterial arcade minimum number. So vasa recta, straight vessel will be longer. Here this arterial arcade more in number. So vasa recta is shorter. Vasa recta is short. Okay, vasa recta long, vasa recta short. In between vasa recta, the peritoneal windows are opaque. Here peritoneal windows are clear. Okay, so these are the three difference. Okay, here arterial arcades are very few in number. Vasa recta wrong. Sorry, vasa recta that is long. Then peritoneal windows are clear. Here peritoneal windows are opaque. Arterial arcades are more in number. Very smaller vasa recta. So this is about ileal and jejunal branches. Both are supplied by superior mesenteric artery. Both are supplied by superior mesenteric artery. Then this is the Kerckring fold. We told Kerckring fold, which is also known as walls of Kerckring. Okay, also known as valvulae conniventis. Valvulae conniventis, other name plica circularis. All are characteristic features of small intestine. So this is where it is maximum. Walls of Kerckring, whether it is in duodenum, jejunum, or ileum. In jejunum, middle part, it is maximum in number. These are permanent fold. These are permanent fold. Okay. If we take X-ray, it is giving some feathery appearance. Some feathery appearance. Okay. Then next. So here in the small intestine, we can see Kerckring valve. Like that, in large intestine, especially in rectum, we can see one more type of valve. That valves are known as Houston's valve. Okay. So valves of Kerckring, valves of Heister seen in cystic duct. Valves of Kerckring or valvulae conniventis seen in small intestine. Maximum in number in jejunum. Like that Houston valve seen in rectum. Okay, so now superior mesenteric artery branches we are discussing. Now only we have discussed it is giving jejunal branch, it is giving ileal branch, it is giving inferior pancreaticoduodenal branch. Okay, then it is also giving some other branches. See here superior. So
Sir, valve of Hastings is in
cystic duct, ma'am.
okay, sir.
Cystic duct. Okay.
Okay, sir.
Here in this picture we are going to remove the small intestine part. Okay, next picture. So superior mesenteric artery is coming. Superior mesenteric artery, it is going to supply the small intestine. So we are going to remove this picture. So we can see the large intestine. So superior mesenteric artery, this side it is giving jejunal as well as ileal branch. Then it is also supplying large intestine. So it is giving ileocolic artery. This artery is known as ileocolic artery. Okay. Then this artery is known as right colic artery. Right colic artery. This artery is known as here to this transverse colon, middle colic artery. So finally, conclusively, what are the branches of superior mesenteric artery? Superior mesenteric artery giving inferior pancreaticoduodenal. Inferior pancreaticoduodenal, it is giving jejunal branch, it is giving ileal branch, it is giving ileocolic artery, it is giving right colic artery, it is giving middle colic artery. So these are the branches of this thing, superior mesenteric artery. Then here some of the common thing. Duodenum is the commonest site of peptic ulcer. Duodenum is the commonest site of peptic ulcer. Then duodenum, which is the commonest diverticulum in GIT. Commonest diverticulum is Meckel diverticulum only, no doubt. But which is the commonest site of acute diverticulum? Acute diverticulum that is common in where pressure is more. That invariably the answer is sigmoid colon. So sigmoid colon, this thing acute diverticulum is common in sigmoid colon. That is followed by duodenal diverticulum. Duodenal diverticulum. So commonest diverticulum, that is congenital diverticulum. So the in question, There is not specifically asking acute diverticulum or congenital diverticulum, simply which is the commonest diverticulum, Meckel diverticulum. But if they specifically asking acute diverticulum commonest site, sigmoid colon is number 1. That is followed by duodenum. Duodenum also second part of duodenum. In second part of duodenum also medial wall of the duodenum. We have to remember all the thing. Then duodenum, it is the commonest site of Brenner gland. Duodenum is the commonest site of Brenner gland. Okay, Brenner gland seen in duodenum. Then it is compressed by superior mesenteric artery. That syndrome is known as Wilkie syndrome. Then jejunum, what characteristic feature we have to find? Maximum number of Kerckering fold, prominent Kerckering fold. Then ileum, pair patches seen, commonest site of TB. Okay, Kerckering folds are very few in number. So these are the points we have to remember. Let us move on to large intestine. So large intestine, here cecum, ascending colon, transverse colon, descending colon, sigmoid colon. Sigmoid colon is the commonest site of acute diverticulum. Just now we have finished. Then here this is appendix. Appendix. Here appendix, it is opens into cecum. Okay, so it is guarded by one valve. That valve is known as Gerlach valve. That valve is known as Gerlach's valve. Like that, here ileum, which opens into cecum. Here there is one more valve that is known as ileocecal valve, which is also known as Bowhin's valve, which is also known as Bowhin's valve, which is also known as Bowhin's valve. There are two valves, Gerlach valve seen here, Bowhin's valve seen here. Then here there are some of the characteristic features for the large intestine. Large intestine, outer longitudinal muscle not arranged, I mean as a thin layer. All the longitudinal muscles of large intestine condensed together and form, this is not Y, this is T, and form 3 longitudinal bundle that is known as tinea coli. What is tinea coli? How many tinea coli seen in large intestine? Large intestine, 3 tinea coli we able to see. 3 tinea coli. What is tinea coli? Longitudinal muscle, that is the outer coast, condensed and form 3 bundle, that is known as tinea coli. Then additionally, some fat-filled pouches we able to see on the wall, that is known as appendices epiphyllae. Then intestines, large intestine, it is arranged like this only. So this is known as hostration or sacculation. These are the 3 characteristic features. Fat-filled pouches, appendices epiphyllae, tinea coli, longitudinal muscle form 3 bundle, that is known as tinea coli. All are characteristic feature of this one. Then here, where and all this tinea coli is absent. This tinea coli which is absent in rectum, it is absent. Tinea coli absent in rectum, tinea coli absent in appendix. So these are the 2 places tinea coli is absent. Tinea coli absent in rectum, tinea coli absent in appendix. Okay, so we have to remember that. Then here we are in position to discuss about something about Griffith point. Something about Griffith point. Already we have discussed. Here see, this artery is superior mesenteric artery. This artery is superior mesenteric artery. The superior mesenteric artery, here it is giving ileocolic artery. Here it is giving ileocolic artery. Like that, here it is giving right colic artery to this ascending colon. Then here it is giving middle colic artery. So this is middle colic artery to the transverse colon, right colic artery to the ascending colon, ileocolic artery to the appendix, as well as cecum, ileocolic artery. So this is ileocolic artery, this thing, right colic artery, middle colic artery. All the branches divided into something ascending branch, descending branch. See here, ileocolic artery divided into ascending. Here it is anastomosing with the descending branch of right colic. This right colic divided into one branch, which is anastomosing with the middle colic artery. Here, like that, continuous anastomosis is taking place. Here, anastomosis of ileocolic artery, I mean all the 3 artery, ileocolic, right colic, middle colic, anastomosing with each other. Here, like that, if we coming this, inferior mesenteric artery. Inferior mesenteric artery finally going to, this is the question, inferior mesenteric artery going to continuous as superior rectal artery. Going to continuous as superior rectal artery. Superior rectal artery is a continuation of inferior mesenteric artery, which is also giving sigmoidal artery, left colic artery to the descending colon. Here it is also divided into ascending branch, descending branch. So this ascending branch, descending branch, all are anastomosing with each other and form one continuous anastomotic chain. One continuous anastomotic chain. That continuous anastomotic chain is known as artery of Drummond. Okay. So for example, this is ascending colon, this is transverse colon, this is descending colon, sigmoid colon, here rectum. Here superior mesenteric artery is coming. The superior mesenteric artery, here this thing, superior mesenteric artery, ileocolic artery, right colic artery, middle colic artery. This is superior mesenteric artery trunk. This right colic artery divided into ascending, descending. Ileoc artery divided into ascending, descending. This middle colic divided into right, left. So like that, everything is divided anastomosing. So here anastomosis, here anastomosis. So this continuous anastomotic chain is known as drum and anastomosis. This is known as drum and anastomosis. Like that, left colic artery finally going to continue as a superior rectal artery. Finally, superior rectal artery. It is giving left colic artery. It is giving sigmoidal branches. It is divided into ascending branch, anastomosing with each other. Okay. So here, this is the end of superior mesenteric artery territory. See, middle colic artery here. This is the starting of inferior mesenteric artery territory. So this is the meeting point of superior mesenteric artery as well as inferior mesenteric artery. So vascularity wise, this is the least vascular area. This point is known as Griffith point. So this Griffith point, where it is located in this splenic flexor of colon. So here, this area Griffith point is located. See here, Griffith point is located. So to reinforce the blood supply to this area, here, what is this artery? This is middle colic artery. Here, what is this artery? Left colic artery. But left colic artery is a branch of this inferior mesenteric artery. This is inferior mesenteric artery. This is superior mesenteric artery. This middle colic artery and this left colic artery both are anastomosing with each other to reinforce the blood supply. Okay. So this arc, that anastomosing, is known as arc of Riolan. Arc of Riolan. Arc of Riolan. So anastomosis in between this middle colic artery, left colic artery is known as arc of Riolan. Okay. Griffith point located on this splenic flexor of colon. So least vascularity. So these are the 2 points we have to remember. Then appendix. Let us move on to appendix. In appendix, which is the commonest position of appendix. So on the appendix, there is no tinea coli, no appendices epiphyllae. Okay. Rectum also, there is no tinea coli, appendices epiphyllae. Commonest position of appendix is behind the cecum. Behind the cecum. So retrocecal position is the commonest position. Retrocecal position is the commonest position. Okay. Commonest position of appendix is retrocecal, which is supplied by superior mesenteric artery, appendicular artery. Then which is followed by second commonest position is pelvic position. Second commonest position is pelvic position. First commonest position is retrocecal position. Okay. Then something about rectum. Rectum, peritoneal coverings are very important. Rectum, here, this is the middle part. This is middle 1/3. Middle 1/3. This is the upper 1/3. Here, lower 1/3. Here, peritoneum wise, lower 1/3 not at all covered by peritoneum. Rectum, lower 1/3 divide of peritoneum. Middle 1/3, if we checking, middle 1/3 only anterior part. Here, see, this anterior part is covered by peritoneum. Middle part, anterior part is covered by, only anteriorly covered by peritoneum. Okay. So here lower aspect bladder is there, male picture, rectum. So rectum lower part divide of peritoneum, middle part anteriorly covered by peritoneum, upper part if we looking mean anteriorly covered by peritoneum, by the side covered by peritoneum, only posterior aspect divide. Okay. So upper 1/3 of rectum, 3 sides covered. Middle part only anteriorly covered, lower part not at all covered. So this is about peritoneal coverings of rectum. Rectum, that is a misnomer, because rectum, the meaning is straight tube, but see, rectum, it is a curved one. Here in male it is a in men it is a in humans it is a misnomer. See here, it is first initially it is following the sacral curvature. So this is the sacral curve, then perineal curve, here anal canal. So in between rectum and anal canal, some curvature is maintained, that is known as anorectal angle. Anorectal angle. What is the normal anorectal angle? What is the maintaining thing? So here puborectal is from pubic bone to rectum, one muscle which is encircling. Okay. What is that? Puborectalis muscle which is maintaining this anorectal angle. Angle between rectum and anal canal. What is the normal angle? 80 to 110 degree. 80 to 110 degree. Okay. Then inside rectum, if you open, side curvature is also there. See here, side also curvature. It is not a straight tube. Inside we are able to see the Houston's wall. Houston's wall. Okay. So this is the most dilated part of the large intestine. Rectum is the most dilated part of the large intestine. This is divide of tinea coli, appendices epiphyllae, as well as sacculation. So all the things are absent here. Houston's wall. Then what is the primary support for the rectum? Primary support for the rectum is superior rectal artery. See, superior rectal artery. So what is superior rectal artery? Superior rectal artery is a continuity of inferior mesenteric artery. Inferior mesenteric artery. Is only superior rectal artery supplying? No. Middle rectal artery also supplying, inferior rectal artery also supplying. So superior rectal artery, inferior. So here, this is the level of, here, it is the beginning of, here, rectum will end here. below to that anal canal. See, the superior rectal artery, not only here superior rectal artery descending down, the superior rectal artery not only supplying the rectum, it is also main supply to anal canal, upper part of anal canal. So it is very, very important. Superior rectal artery is very important. Superior rectal artery not only supplying the rectum, it is also supplying the anal canal, upper part of the anal canal. But middle colic artery, that is only supplying rectum. Middle colic artery not supplying the anal canal. This is inferior rectal artery. Inferior rectal artery supplying rectum as well as anal canal. So rectum is supplied by superior, middle, and inferior rectal artery. Anal canal is supplied by only superior, inferior, not middle. Okay. Then one more thing, middle colic artery is traversing through. Here, see, this is the rectum, this is the pelvic wall. So rectum and pelvic wall, which is connected by lateral ligament, lateral rectal ligament, lateral ligament. This lateral ligament. So rectum, which is connected to pelvic wall, both side by some lateral ligament, which is transmitting one ligament, that one artery, that is middle rectal artery. So middle rectal artery is a content of lateral rectal ligament, lateral rectal ligament. Rectum primary support, superior rectal artery, which is a branch or a continuity of, it is a continuity of inferior mesenteric artery, inferior mesenteric artery. Then anal canal. So below the rectum, anal canal, which is divided into upper, middle, and lower part. Upper part, many anal columns are there. Upper part, many anal columns are there. Then middle part is pecten here. Here, this anal column, lower aspect, there is a line. That line is very important, pectinate line. Pectinate line acts as a watershed line of anal canal. Which is watershed line of anal canal? Here there are two lines, white line of Hilton, another one is pectinate line. Here just a color difference. Here, because this area is lined by mucous membrane, this area lined by skin. So in between there is a color difference. So that is white line of Hilton. That is not so important. Okay, this line is least important. But pectinate line is very, very important, because pectinate line, above the pectinate line, I mean, blood supply is different. Below the pectinate line, blood supply is different. For example, above the pectinate line, superior rectal artery. Below the pectinate line, inferior rectal artery. Above the pectinate line, venous drainage is done by inferior mesenteric vein. For example, I mean superior rectal vein, it is a continuity of inferior mesenteric vein. So inferior mesenteric vein, if we trace, that will reaching splenic vein. Splenic vein drained into portal vein. So this area is drained by portal system. This area is drained by portal system, supplied by superior rectal. Here supplied by inferior rectal artery. Okay, but here the second thing, it is drained into portal system. It is drained into some inferior vena cava. So this acts as a watershed line. Which is the watershed line of anal canal? Pectinate line is a watershed line of anal canal. One of you, please put your system in mute, please, all of you. It is creating some disturbance. Okay, so here, this is inferior rectal artery, which is supplying below the pectinate line. Here above the pectinate line, superior rectal artery. See here, superior rectal vein. This is the anal column. Anal column contain here tributaries of superior rectal vein. Tributaries of superior rectal vein. Okay. If the superior rectal vein in anal column dilated, mean that is known as pile. Pile. The primary pile, secondary pile. So here, for example, the clock position. So this is some sagittal section. So it is parallelly arranged, but actually rectum, that is rounded. So clockwise we can tell. So if this vein enlarged in 3 o'clock, 7 o'clock, 11 o'clock, so that is known as primary pile. Primary pile. So enlargement of superior rectal vein, that is inferior. Superior rectal vein, if it is dilated, mean that is internal pile. Internal pile again divided into primary pile, secondary pile. Primary pile. So anal column in 3 o'clock, anal column in 7 o'clock, anal column in 11 o'clock. So everywhere here, for example, if we draw the diagram, so here, what is this? Full rectum. Here anal columns are there. Anal column contain vein. Anal column contain the superior rectal vein. So out of that, this 3 o'clock vein, 7 o'clock vein, 11 o'clock vein. So 3, 7, 11. These are the vein dilated, mean that is primary pile. All the other vein dilated, mean that is secondary pile. So these are the things we have to remember. Then on both side of rectum anal canal, to allow the expansion, one fat-filled pouch is there. That is known as ischiorectal fossa. That fossa is known as ischiorectal fossa. Ischiorectal fossa, the boundaries are here above. What is this? Levator ani. Levator ani. Medially, here, this is anal sphincter, external anal sphincter. Laterally, obturator internus muscle. Here, one thing, the subdivision, there are so many things are there, but one thing, very important content is this ischiorectal fossa of both sides communicating with each other. Infection of this side can passing through opposite side. That one point we have to remember. The important contents are inferior rectal vessels and nerve. inferior rectal vessels and nerve is a content, inferior rectal vessels and nerve. Then here pin structures are there in the lateral wall. That is important. So inferior rectal, nerve and vessel, because superior rectal which is coming from above. Okay, inferior rectal traverse through ischiorectal fossa. Then posterior scrotal vessels and nerve. Posterior scrotal or posterior labial. Both in female posterior labial. In case of male, posterior scrotal vessels. Okay, in case of female, posterior labial vessels. Okay, posterior scrotal, that is a content of ischiorectal fossa. Inferior rectal vessels, that is a content of ischiorectal fossa. Lateral wall contain pin structure, pudendal canal. Lateral wall contain what? Lateral wall of ischiorectal fossa contain what? Pudendal canal. Okay, so here there is a fascia. That fascia is known as anal fascia. Anal fascia. Here obturator fascia. Here obturator fascia. Okay, here there is one more fascia, lunate fascia. So these are the subdivision, but contents are very, very important. Contents are very important. So inferior rectal nerve and vessels, lateral wall contain pudendal nerve, internal pudendal artery nerve to obturator internal spin structure seen, pudendal canal that is seen on lateral wall, posterior scrotal or posterior labial vessels, that is also a content of ischiorectal fossa. Then let us enter into retroperitoneum. So retroperitoneum, here we have to know some important retroperitoneal structure. Retroperitoneum, here this is the peritoneal cavity. Here this is the peritoneal cavity. Behind the peritoneum, we are able to see few organs. Those are retroperitoneal organ. What are the structure we are able to see? So kidneys are retroperitoneal organ. So if it is kidney, main kidney is capped by suprarenal gland. From the kidney, ureter is coming. All the three are, these are the three considered as a primary retroperitoneal. In case if we cross anywhere primary retroperitoneal, these are the three considered as a primary retroperitoneal. All the other, for example, ascending colon, descending colon, duodenum, pancreas, all are considered as a secondary retroperitoneal, because here, see, here ascending colon very close to peritoneal. One side it is covered with peritoneum. Duodenum one side covered with peritoneum. Pancreas very close to peritoneal cavity. Duodenum one side covered with peritoneum. So very close to peritoneal cavity, secondary retroperitoneal. Kidney, ureter, suprarenal gland, primary retroperitoneal organ. Then posterior abdominal wall. For to understand the kidney posterior relations are very important, not anterior relation, because kidney is approached through posteriorly. So posterior abdominal wall we have to know. Some muscles we have to know. Posterior abdominal wall, here uppermost muscle. This muscle is known as diaphragm. This muscle, the uppermost muscle, this is diaphragm. This is vertebral column. Parallel to vertebral column, this is psoas major muscle. Please remember this psoas major muscle. Then lateral to that quadratus lumborum, still lateral to that transversus abdominis. Totally 4 things only we able to see. So upper part diaphragm, this is vertebral column, psoas major muscle, quadratus lumborum muscle, psoas major, quadratus lumborum. Another one is transverse abdominis muscle. So these are the muscles seen on posterior abdominal wall. Okay. So here there is a question. Thoracolumbar fascia. Thoracolumbar fascia. What are the structure enclosed by thoracolumbar fascia? Okay. So here see thoracolumbar fascia, which is attached to this lumbar vertebra region. Okay. So here it is having 3 lamina. See, this is anterior lamina, middle lamina. Another one is posterior lamina. So thoracolumbar fascia contains 3 lamina. Yes. Then here this thoracolumbar fascia enclosing, like clavipectoral fascia enclosing 2 muscles. What are the 2 muscles? Subclavius, pectoralis minor. Like that, here also it is enclosing 2 muscles. The muscles are here in this region, and in between anterior and middle, 1 muscle is there. In between middle and posterior, 1 more muscle is there. 2 muscles enclosed by thoracolumbar fascia. What are the muscle enclosed by thoracolumbar fascia? Quadratus lumborum is enclosed. Then erector spinae is enclosed, but psoas major muscle not enclosed. Psoas major muscle is enclosed by psoas fascia. Psoas major muscle is enclosed by psoas fascia, not by thoracolumbar fascia. So thoracolumbar fascia enclosing 2 muscle, clavipectoral fascia enclosing 2 muscle. We have to remember that. Then here let us move on to the kidney. Okay, so kidney, because of presence of liver, this is right kidney, left kidney. Right kidney is a little bit lower than the left kidney. Okay, so right kidney that is lower than the left kidney. So right kidney lower than the left, so it is related to only last rib, because little bit below it is related to only T12 rib. But this is a little bit higher level, so it is related to T12 as well as T11. Logical, because upper level, so it is related to 11th rib also. It is lower level, so only related to 12th rib. Logical. So now posterior relation. So now only we have seen posterior wall, which contain upper part diaphragm. Be able to see this is central vertebra. So middle psoas major, then So sorry, middle here we are able to see psoas major, then quadratus lumborum, then transverse abdominis. We are going to apply the same here. We are going to apply the kidney here. Okay, so it is very easy. So if we apply the kidney exactly, if you apply the kidney here, if you apply mean, what are the structure will present posteriorly? Posteriorly diaphragm will come, posteriorly psoas major will come, posteriorly quadratus lumborum will come, posteriorly transverse abdominis will come. Now we already know posteriorly what are the ribs there. So collectively if we draw one diagram, so these are the thing. So here this is left side, this is the right side, the same picture we are going to recalling. So posterior relation, left kidney, what are the rib? Because a little bit upper level, because of presence of upper level, it is related to 11th rib as well as 12th rib. But here right side only it is related to 12th rib. Then upper part related to diaphragm. Then medial to lateral, already we have crossed the 3 muscle, psoas major muscle, quadratus lumborum muscle. Another one is transverse abdominis. Very simple. Okay. Then 2 other nerve we have to remember. Posterior to kidney, posterior to ureter. Posterior to kidney, iliohypogastric nerve, ilioinguinal nerve. But posterior to ureter, genitofemoral nerve. Okay, so here ureter will descend down no. At the time posterior to ureter, genitofemoral. Posterior to kidney, ilioinguinal nerve, ilioinguinal, iliohypogastric. So in case of approach of kidney, what are the nerve? Approach of kidney, what are the nerve can be damaged like that. Then subcostal nerve also present posterior to that. So again we are repeating, 2 ribs are there behind the left. Okay, here almost everything is same. Only one difference is left kidney related to 11th rib, but a right kidney related only to 12th rib. All otherwise posterior relation for both same. The upper part diaphragm, here lower part from medial to lateral, the same posterior abdominal wall relation. Okay, the same posterior, psoas major, quadratus lumborum, another one is transverse abdominis. Then 3 nerve, subcostal nerve, iliohypogastric, ilioinguinal. So in case of posterior approach, what are the nerve can be damaged? They may give genitofemoral. Genitofemoral, it is present posterior to ureter, not posterior to this thing, kidney. Okay, so that point we have to remember. Then coverings of kidney, here kidney immediately covered by one capsule, that is renal capsule, then perinephric fat, then renal fascia, then outside one more layer, that is known as paranephric fat. So totally 4 layer. Okay, first renal capsule, that is the true capsule, condensation of kidney connective tissue. Okay, because kidney it contain connective tissue, no, that one connective tissue of kidney condensed and form one capsule, immediate covering, we can't separate that. So that is known as renal capsule. Then outside one more fatter, that is perinephric fat. Then still one more layer, that is gerotous fascia, renal fascia or gerotous fascia. Then paranephric fat, outermost side one more fatty layer, that is known as paranephric fat. So these are the coverings of kidney. Okay, so here if we draw one diagram, here kidney is present like this. Okay, above the kidney suprarenal gland, that renal fascia which is enclosing kidney, side view we are looking, this is anterior side, posterior side. So this is renal fascia we are drawing. Okay, so for example here kidney is there, kidney this is renal fascia, this is anterior layer, posterior layer. This anterior and posterior layer join together with the upper pole of kidney, again re-split and enclosing this suprarenal gland. So suprarenal gland also covered by renal fascia only. Then after enclosing suprarenal gland, both the fused part, that is extended to diaphragm, that is stretched to diaphragm. So this is the picture. So this is renal fascia, above fused, re-split enclosing suprarenal. This is suprarenal, this is kidney, re-split and enclosed suprarenal. But below both are not fused with each other. So here only fat is there. So only in case of prolonged starvation, this fat loss can be there. So descent of kidney is possible. Like that, one more thing, malignancy, here fused with each other. So malignancy can't spread up, but malignancy, that fluid can drag down. So these are the things we have to remember. Then anterior relations of kidney, already during stomach itself we have discussed. Okay, so stomach bed structure, okay, at that time we have discussed. Then here some inner aspect, here interior it contain many pyramids, then in between area, so this is one pyramid, this is below there is one more pyramidal region. In between pyramid we able to see renal column, in between columns of Bertin we able to see. So this area renal column, so this is renal pyramids we able to see. Then here aortico-mesenteric angle, so here it is supplied by renal artery, L1 L2 disc level it is originating. Okay, it is supplying this, then drained into renal vein, So here aortic renal vein also. So already we have discussed something about nutcracker syndrome. So this is aorta, here superior mesenteric artery, in that angle left renal vein also there. So here we are able to see the left renal vein. So aortic mesenteric angle, if it is reduced, mean what will happen? That will lead to compression of this left renal vein. See here, compression of left renal vein is taking place. Compression that will lead to nutcracker syndrome. Here very important thing, here this left renal vein not only draining the kidney, left renal vein also receiving two other vein. One vein is known as left testicular vein or left ovarian vein. Here suprarenal gland is there, that suprarenal also drained into renal vein only. Okay, so here suprarenal directly drained into IVC, here suprarenal drained into renal vein, here testis drained into IVC. So right side everything drained into IVC separately, but left side everything drained into renal vein. So this point we have to remember. Let us move on to suprarenal gland. Suprarenal gland also covered by renal fascia. Just now we have finished. Okay, then here this inner medulla. So this adrenal gland, which is divided into medulla and cortex. Medulla is developed from neural crust cell. Medulla is developed from neural crust cell, but outer cortex is mesodermal in origin. Outer cortex is mesodermal in origin. See, just now here one thing is very important, the blood supply is very important. Here see the suprarenal gland, which is supplied by totally 3 set of artery. Suprarenal gland is supplied by 3. So suprarenal gland, which is supplied by totally 3 set of artery. Here see superior suprarenal artery, middle suprarenal artery, inferior suprarenal artery. Middle suprarenal artery only a direct branch of aorta. Superior suprarenal artery is a branch of, this is inferior phrenic artery. This is inferior phrenic artery giving superior suprarenal artery. Middle suprarenal is a branch of aorta. Inferior suprarenal artery is a branch of renal artery. So this is renal artery, it is giving inferior suprarenal artery. Okay, inferior suprarenal, middle, another one is superior, 3 artery. Okay, then let us move on to venous drainage. Venous drainage, this is suprarenal gland, right suprarenal vein drained into IVC, but left vein drained into this renal vein. Renal vein not only receiving suprarenal vein, also receiving left gonadal vein. Okay, right side everything drained into IVC, left side everything drained into vena cava. Sorry, renal vein. So this point we have to remember. Then ureter, 3-level constrictions we are able to see. Pelviureteric junction, upper level, at one point it is crossing the iliac artery, then where it is enter into urinary bladder. So these are the level we are able to see the constrictions. Okay, these are the level we can see the constriction. Then here ureter, during descending down, it is supplied by many artery. It is supplied by many artery. So here uppermost part it is supplied by renal artery. Then here at one point it is crossed by gonadal artery. So gonadal artery also supplying, then aorta directly supplying, then internal iliac artery branches. So it is supplied by multiple branches, so we can't say single arterial supply. So it is descending down. So during that course it is receiving blood vessel by the side. Okay, renal artery, gonadal artery directly by aorta, also internal iliac artery, all are supplying this. Okay, then very important thing, ovarian fossa. Okay, please remember ovary located in one place, that is known as ovarian fossa. Ovarian fossa, for the ovarian fossa, ureter forming posterior relation. Please remember, for the ovarian fossa or ovary, which is forming posterior relation, ureter forming posterior relation. So overall ovarian fossa, ureter forming posterior relation. That is very, very important. Okay, so here see, here ovary is there, here this is uterus, here fallopian tube we can see, here ovary is there, behind the ovary ureter is running, behind the ovary ureter is running. So for the ovary that is located in one area, that is known as ovarian fossa. For the ovarian fossa, ureter forming posterior boundary. Then here this is the uterine artery. Here see, this is the uterine artery. For the uterine artery also ureter running posteriorly. For the ovary it run posteriorly, ureter anteriorly crossed by the uterine artery. Then let us move on to urinary bladder. Urinary bladder, here everywhere, if you put the section, everywhere rugae seen, everywhere. So like stomach, here also it is loosely arranged rugae seen, except one area. That area here there is no submucosa. So mucosa tightly adherent to the underlying muscle layer. So this layer there is no rugae. Rugae means loose arrangement. Okay, many folds are seen, but one area we can't see that rugae, that is known as trigone of urinary bladder. At the lateral angle of trigone, ureter is opening. In between one ridge, that is interureteric ridge or something Mercier bar, something known as Mercier bar. Then here this trigone not only ends here, trigone enter into prostatic urethra and form one elevation that is known as urethral crust. So this is trigone muscle. The importance is trigone muscle, it is glistening structure because no rogue is seen, it is clear. Okay, so it is a glistening structure. At the lateral angle, ureter open. So here interureteric ridge, here urethra. So this is ureterourethric ridge, ureterourethric ridge. This trigonal muscle not only ends here, also enter into prostatic urethra. These are the points we have to remember. Then male reproductive system. Here already testis blood supply venous drainage over. So right testis drained into IVC. Okay, venous drainage. Left testis that is drained into renal vein. Then here some of the important functions of seminal vesicle. Here is semen. Is it stored in seminal vesicle? No, semen that is not stored in seminal vesicle. No storage of semen. Okay, it is mainly accounts for 70% of the volume of ejaculated semen. Mainly it is fluid, it is secreting some fluid. Okay, so that is mainly increasing the volume. So that point we have to remember, no storage is taking place. Then in prostate, two things we have to remember. Prostate, so this is the here trigone, this enter into prostatic urethra. This is prostate where hypertrophy is common. What is uvula vesicae we have to remember. Which lobe is hypertrophy, where cancer is common we have to know. So if we put the section, totally 5 lobes we able to see. So prostate, which is traversed by prostatic urethra. So this is prostatic urethra. In front of prostatic urethra, anterior lobe. Here median lobe, here posterior lobe, two side lateral lobe. So lobe wise, if we tell, posterior lobe is the commonest site of cancer. Lobe wise, posterior lobe is the commonest site of cancer. Median lobe is commonest site of hypertrophy. Lobe wise, median lobe is commonest site of hypertrophy. Posterior lobe is the commonest site of cancer. Then one more definition, transitional zone. Around the here prostatic urethra is coming. The area around the prostatic urethra is known as transitional zone. Okay, this posterior, which is also known as here, this is the peripheral most part. So this is the peripheral zone. So zone wise, peripheral zone is common for cancer because posterior aspect, peripheral zone, that is common for cancer. Okay, transitional zone, that is common for hypertrophy. Zone wise, transitional zone common for hypertrophy. Lobe wise, median lobe common for hypertrophy. Then posterior lobe common for cancer, zone wise peripheral zone common for cancer. So these two things we have to remember. Then sometime median lobe, this is producing some elevation. That elevation, see here it can cause this obstruction of urination. Obstruction, it can cause obstruction. What is here? Prostate, one of the lobe can undergoes enlargement and protrude one elevation into the bladder like this. That is known as uvula vesicae. Uvula vesicae. Okay, so there is a bulging caused by prostate. So which lobe of prostate can cause this elevation? This elevation is known as uvula vesicae. So this is caused by median lobe of the prostate. Median lobe of the prostate. So median lobe common for hypertrophy, it is causing uvula vesicae. Okay, so posterior lobe common for cancer. So these are the points we have to remember. Then already we have discussed this. Posteriorly, that trigone of the urinary bladder, which is also extending into prostatic urethra. See here, interior of prostatic urethra. So this is the prostatic urethra, this is the prostate. So that trigone muscle enter into prostatic urethra and cause an elevation. So this elevation is known as here, what is this? Seminal colliculus. So there is a this complete elevation is known as urethral crust. This complete elevation is known as urethral crust. Okay, out of that, the middle part is highly enlarged. So that is known as verumontanum. That is known as verumontanum or seminal colliculus. At the middle here, prostatic atricle, one of the remnant open, ejaculatory duct also open. So this is urethral crust. It is caused by this thing. Urethral crust is caused by trigonal muscle, which is seen on posterior wall of the prostatic urethra. Then at the central part is highly dilated. That is known as verumontanum or seminal colliculus. Here, prostatic atricle open, ejaculatory duct are open. Then by the side, prostatic gland open, that is known as prostatic sinuses. This point we have to remember. Then prostate is mainly supplied by inferior. So please remember, vas deferens is mainly supplied by superior vesical artery. Prostate is mainly supplied by inferior vesical artery. Prostate is supplied by middle inferior vesical artery, which is also associated by middle rectal artery, internal pudendal artery. So let us move on to next region, that is pelvis region. That is pelvis region. Here, one thing, extravasation of urine. So pelvic diaphragm, like this questions will come. So here, this is anterior abdominal layer. Anterior abdominal layer which contains carpus fascia. Carpus fascia, if we trace it down, here it is continuous with penile fascia. Penile fascia. This penile fascia continues with here dartas muscle. Dartas muscle continues with collis fascia. So this region is collis fascia. Here collis fascia is there. Here carpus fascia is there. So this is the fascia of abdomen. This is the fascia of pelvis. Both are continuous with each other through dartas muscle as well as penile fascia. Now here this region perineal membrane is there. This region perineal membrane is there. So in between area is known as superficial perineal pouch. For example, one more easy diagram. Here if we take section, here see, here the outermost skin is there, some superficial fascia. Here this fascia is known as collis fascia. This fascia is known as collis fascia. So what is this? Collis fascia. Then this is perineal membrane. This is perineal membrane. So perineal membrane and collis fascia, in between this region is known as superficial perineal pouch. So what is superficial perineal pouch? In this diagram, if this is collis fascia, this is perineal membrane. So in between area is known as what? Superficial perineal pouch. So here this area is known as superficial perineal pouch because this is collis fascia. This is perineal membrane. So this is superficial perineal pouch. This area is known as deep perineal pouch. Above to this superficial perineal pouch, deep perineal pouch, this area is known as pelvic diaphragm. This area is known as pelvic diaphragm. Very simple. So here the same urinary bladder we able to see. Below the urinary bladder, prostate we able to see. Prostatic urethra is coming down. Okay. So here this urinary bladder supported by pelvic diaphragm. Pelvic diaphragm. Below the pelvic diaphragm, this area is known as deep perineal pouch. This area is known as superficial perineal pouch. Here what to know? Here we have to know about what are the structure present in deep pouch, what are the structure present in superficial perineal pouch, what are the structure forming pelvic diaphragm. So three things we are going to learn. So in pelvis, totally 4 areas are important. What are the structures forming pelvic diaphragm? What is deep perineal pouch? What is superficial perineal pouch? What are the structure attached to perineal body? So these are the four things only we are going to concentrate. One by one we are going to come. First, pelvic diaphragm. So pelvic diaphragm. So here see complete view of pelvic diaphragm. This is the sagittal section. Pelvic diaphragm appear like this. But here pelvic diaphragm, it is a complete enclosure. So this is the pelvic diaphragm. So here this is here posterior side, here anterior side. Okay. So here first this is pubic bone. Here ilium, ischium bone. From the pubic bone, here one of the muscle which is extending behind and inserted into this coccyx. So that muscle is known as pubococcygeus. What is the muscle? Pubococcygeus. One of the muscle is known as pubococcygeus. Then from the ilium, one muscle extending here. That muscle is known as iliococcygeus. Then from ischium, one of the muscle is extending. That muscle is known as ischiococcygeus. So it is, make it simple. Here there are three muscle. Here see, from the pubic bone, pubococcygeus. From the ilium, iliococcygeus. From the ischium, ischiococcygeus. So three parts of the hip bone to the coccyx, some muscles are extending. Pubococcygeus, iliococcygeus, ischiococcygeus. Out of that, this pubococcygeus and iliococcygeus collectively known as levator ani. What is levator ani? Pubococcygeus, iliococcygeus collectively known as levator ani. Ischiococcygeus not a component of levator ani. Then ischiococcygeus is also known as coccygeus. So now we know what is levator ani. Pubococcygeus, iliococcygeus known as levator ani. Ischiococcygeus not a levator ani, it is coccygeus. Then what is pelvic diaphragm? This levator ani. Levator ani is a component of two. One is pubococcygeus, another one is iliococcygeus. Then plus this coccygeus, I mean ischiococcygeus. Everything collectively known as pelvic diaphragm. So pelvic diaphragm, note pubococcygeus, iliococcygeus, also ischiococcygeus. All the three things collectively known as pelvic diaphragm. But levator ani mean pubococcygeus, iliococcygeus. Now it is very simple. Here urethra is there. Here vagina is there. Here rectum is there. So pubococcygeus extending like this. At the time, few fiber encircling urethra, few fiber encircling vagina, few fiber encircling. So this is a medial most one, pubococcygeus encircling this thing, rectum. So this fiber pubourethralis. So pubourethralis is a modification of pubococcygeus. Pubovaginalis is a modification of pubococcygeus. Puborectalis is a modification of pubococcygeus. Make it simple. So this is about pelvic diaphragm. Then here, if we coming means superficial perineal pouch. Here, what are the things are seen? Here, this muscle. Here, see, we able to see here bulb of the penis. We able to see. So this is bulb of the penis. Bulb of the penis, which is surrounded by one muscle, that is bulbospongiosis. Bulbospongiosis. So superficial perineal pouch. Already we know this is Colles fascia. This is perineal membrane. So in between area is known as superficial perineal pouch. So this is known as ischiocavernosus. Ischiocavernosus. So bulbospongiosis, ischiocavernosus, all are content of what? Superficial perineal pouch. Also here the superficial perineal pouch in female, it contain one of the gland. That gland is known as Bartholin gland. So Bartholin gland is a content of which pouch? Superficial perineal pouch. So make it simple. So superficial perineal pouch mainly contain three structure: bulbospongiosis. They mainly contain bulbospongiosis, ischiocavernosus, also this gland, that is Bartholin gland, also this gland, Bartholin gland. So here one urethra is seen. Urethra is seen. If urethra rupture mean, what will happen? See here already we have drawn. This is perineal membrane. This is perineal membrane. Here Colles fascia. In between area, this area is known as superficial perineal pouch. Here urethra is going. This urethra is rupture. Urine is coming out. That urine first initially collected in where? That urine initially collected in superficial perineal pouch. Then enter into where? Scrotum. Enter into where? Scrotum. Then from here enter into where? Penis. Enter into where? Penis. Then enter into where? Anterior abdominal wall, because continuity is there. Anteriorly it is wide open. So here initially easily it can enter into, so here leak. So enter into superficial perineal pouch, enter into scrotum, enter into penis, enter into anterior abdominal wall. But can it enter into thigh? Okay, see here in case of rupture it can enter into superficial perineal pouch, okay, or anterior urethral, because this part anterior urethral, deep perineal pouch and above posterior urethral. Anterior urethral injury extravasation seen in superficial perineal pouch, scrotum, penis, anterior abdominal wall. Can it enter into ischiorectal fossa? No. Can enter into space of Retzius, the space around the bladder? No, because it is above. No. Ischiorectal fossa? Never. So only these four places can enter. Can it enter into thigh region? No, because here fascia of abdomen coming down, it is fused tightly with fascia lata. Fascia of thigh and fascia of abdomen tightly fused with each other. That line is known as Holden's line. So it never cross Holden's line. Okay, it can go up. So four places only extravasation of urine seen. Superficial perineal pouch content we have discussed. Please remember Bartholin gland. Deep perineal pouch. If you going deep perineal pouch, just now we have completed. This is perineal membrane above to the deep perineal pouch. This region. So this is bulbar urethra. This region is known as membranous urethra. So membranous urethra is a content of deep pouch. Bulbar urethra is a content of superficial pouch. Then on both side of that, if this is membranous urethra, here sphincter urethra is seen. Here deep transverse perineum. So what are the content? Deep transverse perineum. Here what is this? External. Sorry. Here external urethral sphincter. External urethral sphincter. Here deep transverse perineum. Deep transverse perineum, external urethral sphincter. These two muscles collectively known as urogenital diaphragm. These two muscles are collectively known as what? Urogenital diaphragm. So already we have discussed about pelvic diaphragm. Already pelvic diaphragm. Here there are two things. Urogenital diaphragm. Here this region urogenital diaphragm. Urogenital diaphragm. What is this? Deep transverse perineum plus external urethral sphincter, collectively known as urogenital diaphragm. Then levator ani muscle mean pubococcygeus plus iliococcygeus, collectively known as. So these two things we have to remember. Then membranous urethra present here. Here one more gland seen in male. That gland is known as Cowper gland. That gland is known as Cowper gland. See, Cowper gland. Okay, bulbourethral gland. So here question will come. Bulbourethral gland is a content of deep perineal pouch. Bartholin gland is a content of superficial perineal pouch. Okay, what is urogenital diaphragm? Deep perineal, deep transverse perineum plus external urethral sphincter, collectively known as urogenital diaphragm. Is it synonymous with levator ani? No, levator ani is pubococcygeus plus iliococcygeus. That is levator ani. What is pelvic diaphragm? Levator ani, combination of pubococcygeus, iliococcygeus plus ischiococcygeus. Ischiococcygeus. This is pelvic diaphragm. So with this we we can enter into the perineal body. So perineal body, please remember perineal body, it is located here. What is the location of perineal body? This is the location of perineal body. Here, what are the muscles are? So if perineal body present mean two transverse muscle, one muscle superficial transverse perineum. So this muscle is superficial transverse perineum. Then another one muscle is deep transverse perineum. Two muscle, paired muscle, deep transverse perineum. This is deep transverse perineum. That one is superficial transverse perineum. Posteriorly, here rectum is seen. So external anal sphincter, longitudinal muscle of rectum can attach. Anteriorly, here bulb of the penis. So bulbospongiosis muscle can be attached. So perineal body, what are the muscle? Superficial transverse perineum, bulbospongiosis, deep transverse perineum, external anal sphincter, longitudinal muscle of rectum, also levator ani. Because why levator ani? Here urethra is there, vagina is there, rectum is there. Here perineal body is there. Here pubococcygeus it is going. So pubourethralis, pubovaginal, puborectalis. So perineal body also receiving levator ani. All are pubococcygeus is a combination of what? Levator ani. Superficial transverse perineum, deep transverse perineum, bulbospongiosis. Here the very important one which is not. So here see, this is the location. This is the location of perineal body. Perineal body. Which muscle is away from perineal body? If we note, this muscle is away from perineal body. What is that muscle? Ischiocavernosus. Ischiocavernosus. Ischiocavernosus never attached to perineal body. So in that way we can remember. Then urethra. Here most dilated part prostatic urethra. Least dilated part membranous urethra. These 2 points we have to remember. Then one more thing, prostatic urethra lining epithelium is the same urinary bladder lining epithelium, transitional epithelium. Please remember, what is the lining epithelium of prostatic urethra? Prostatic urethra is lined by the same urothelium or transitional epithelium. Other part are lined by stratified columnar epithelium, ciliated pseudo-stratified columnar epithelium. Okay, so least dilated part membranous urethra, most dilated part prostatic urethra. So these are the part we have to remember. So let us move on to the thoracic region. Thoracic region, what are the points we have to remember? Sternal angle event. So sternal angle, what level it lies? T4, T5 vertebral level it lies. Okay, T4, T5 vertebral level it lies. So here the sternal angle, at the sternal angle, which rib is attached? At the sternal angle, second rib is attached. Sternal angle, second rib is attached. Then what are the other event are taking place? So here only arch of aorta begin, arch of aorta end. Okay, so here something mnemonic is rat plant. Okay, second rib is attached, arch of aorta beginning and ending, trachea that is also bifurcating here only. Then pulmonary trunk also. So trachea bifurcation, pulmonary trunk bifurcation taking place here only. Then one more important thing here, azygous vein drains into IVC. Azygous vein drains into IVC. Okay. So some important things we have to remember. So at the sternal angle, second rib is attached. That is important. Another one is azygous vein drained into SVC. These two things, then trachea bifurcation, pulmonary trunk bifurcation. So these are the event taking place at sternal angle. Then thoracic inlet, which is covered by one membrane. That membrane is known as Simpson's fascia. Simpson's fascia or suprapleural membrane, which is a remnant of scalenus minimus muscle. So which is a remnant of what muscle? It is a remnant of scalenus minimus muscle. It is a remnant of scalenus minimus muscle. So this Simpson's fascia, which is extending from transverse process of C7 vertebra to first rib, which is extending. So which is separating subclavian vessels from this lung. Okay, apex of lung, which is separating these two structure, apex of lung from subclavian vessels. Okay, 5 minutes break. Can you hear me?
Yes, sir.
Yes, please join soon. Okay, 5 minutes. Okay, can we continue? Okay, so the Simpson species is a remnant of the scalenus minimus muscle. So that point we have to remember. Then some of the diaphragm. So here thoracic outlet. So thoracic outlet which is formed by diaphragm which has three major opening. So here this is aortic opening, here esophageal opening, another one is inferior vena cava opening. So what are the structure, main structure passing through this? Important here, aortic opening, the level is T12 vertebral level. Esophageal opening, the level is T10. Vena cava opening, the level is T8. Vena cava opening, it will transmit two important structure. One is inferior vena cava, another one is vena cava opening transmit. Another one is right phrenic nerve, not left phrenic nerve. Only one phrenic nerve, that is right phrenic nerve. Esophageal opening, it will transmit esophagus. It will transmit esophagus. Also, it will transmit vagus nerve, but both vagus nerve, right and left. Esophagus, I mean aortic opening T12 level. So it will transmit three structure: aorta, here esophagus vein, thoracic duct. Totally three structure. Okay. So here aorta, thoracic duct, esophagus vein. So these are the three structure passing through aortic opening. Esophagus, vagus nerve passing through esophageal opening, vena cava opening transmit right phrenic nerve. So these are the points we have to remember. Here, one of the this thing, sometime I mean one of the hernia, I mean defect in diaphragm. So diaphragm, it is a partition in between thorax and abdomen. So sometime there is a defect. One of the commonest defect is known as foramen of Bok-Telek. Okay, Bok-Telek hernia. So diaphragm failed to completely separate thorax from abdomen, so abdominal content can enter into thorax. Okay, so that is known as, here I told the answer only, I am not explaining explanation. Okay, so here sometime it is developed from many sources. One of the source is known as pleuroperitoneal membrane. That pleuroperitoneal membrane sometime failed to develop, mean diaphragm defect is there. So Bok-Telek hernia. So here only one question: Bok-Telek diaphragmatic hernia is because of pleuroperitoneal membrane failed to develop. Pleuroperitoneal. There are other sources also. So it is developed from, diaphragm is partially developed from septum, transversum, dorsal mesentery of esophagus, somites. Okay, but all the thing usually completely formed. So sometime defect seen in diaphragm, that is because of failure in development of pleuroperitoneal membrane. So that hernia is known as Bok-Telek hernia. We have to remember that. Then thoracic wall we can go. So thoracic wall, from outside to inner side, external intercostal muscle, internal intercostal muscle, innermost intercostal muscle. There are three muscles are there. Out of that, this internal intercostal and innermost intercostal, in between neurovascular planes are there. Neurovascular plane, in between second and third layer. So this is first layer, second layer, third layer. In between second and third, internal intercostal, innermost intercostal, neurovascular plane is seen. Neurovascular plane which contain intercostal vein, artery and nerve. Intercostal vein, artery, nerve. From above downward, van structure, above downward. So here, this is the costal groove. So costal groove contain van structure. From above downward, vein, artery, another one is nerve. Okay, so this point we have to remember. Then here something about typical intercostal nerve, atypical intercostal nerve. Typical intercostal nerves are, I mean space, intercostal nerve number 3, 4, 5, 6. These are the nerves are typical intercostal nerve. So what are the intercostal nerves? That is totally 11 in number. The 12th one is known as subcostal nerve. So thoracic spinal nerves only going to form the intercostal nerve. So here just to remember, what are the nerves are typical, what are the nerves are atypical. Typical are 3, 4, 5, 6. Other than that, because these only confined. Okay, how to define differentiate typical, atypical. Typical mean that should supply only thoracic cage. If it supply anywhere other than thorax, that is known as atypical. 3, 4, 5, 6 confined to thorax. First one, why first one is not typical one? First one going to contribute to the formation of brachial plexus. Brachial plexus going to supply the upper limb. Then second one going to supply the medial aspect, I mean cutaneous supply to the skin. So that is also atypical. Below the 6th, 7, 8, 9, 10, everything it is going to supply the abdomen. So that is atypical. 3, 4, 5, 6 typical. Then here intercostal spaces, anterior intercostal artery, posterior intercostal artery. Very simply, you remember anterior intercostal artery is a branch of internal thoracic artery. Okay, so the detailed thing not so important. So anterior intercostal, each intercostal space contain anterior intercostal artery, posterior intercostal artery. Anterior intercostal artery is a branch of internal thoracic artery. Internal thoracic artery is a branch of here subclavian artery. Already I told subclavian artery, which is divided into 3 parts by scalenus anterior. Here first part, which is giving internal thoracic artery. This internal thoracic artery giving anterior intercostal artery. Please remember. Then posterior intercostal artery is a branch of directly from aorta. Then here azygos vein. Here one main difference we have to know in azygos vein. Azygos vein, how it is formed? Azygos vein, which is formed by the last intercostal, intercostal vein, that is T12, thoracic vein, subcostal vein, which is joined with ascending lumbar vein, one more vein, lumbar azygos vein. These are the 3 veins joined together and form azygos vein. This azygos vein, when it is ascending up, it is receiving, for example, this is T11, this is T10. Like that, it is receiving all the posterior intercostal vein, So this is the right side. Left side, all the intercostal vein that is drained into here, hemiazygos vein, accessory. So this is hemiazygos vein, accessory hemiazygos vein. Okay, so here intercostal veins are drained. Okay, so like that, it is mainly draining intercostal veins only. See, mainly draining intercostal veins only. So here some difference only we have to know. See, azygos vein, what are the tributary? If they ask you, one is right subcostal vein, another one is lumbar azygos vein or ascending lumbar vein. Here accessory hemiazygos vein, another one is this is hemiazygos vein. All are tributaries of azygos vein. Here main difference, here please note this. Here right side, second intercostal, posterior intercostal, third posterior intercostal, fourth posterior intercostal, all are joined together and form superior intercostal vein. All are joined together and form superior intercostal. Superior intercostal, 1 is not included, 2, 3. Here also 2, 3, 4 join together and form superior intercostal. So this is right superior intercostal. This is left superior intercostal. Note this, right superior intercostal drained into azygos vein, but left superior intercostal drained into brachiocephalic. This is the main difference. This point we have to note. Okay, so right superior intercostal vein, so which is not a tributary, in that they will give right superior intercostal, left superior intercostal. Right superior intercostal drained into yes azygos vein, but left superior intercostal vein drained into left brachiocephalic vein. See, left brachiocephalic vein. So this is very, very important difference. We have to note it. Okay, then this is first vein that is drained into both side brachiocephalic only, but in the superior intercostal vein difference is there. Then something about tracheal bifurcation. So here trachea, where trachea is bifurcating, the actual correct level, disc between T4 T5, sternal angle level, disc between T4 T5. If T4 T5 is not in choice, upper border of T5, so disc between T4 T5. So there only it is divided into right and left. If it is not there, upper border of T4. Okay. Okay, then in cadaver, lower border of T4. In newborn, still higher level T3. But constant answer, please look T4, T5. If it is not there, upper border of T5. Then here, this is trachea, which is divided into right and left. Right more or mostly in line with here. See, this is mostly in line with trachea. So here, right side, mostly aspiration is common, accidental aspiration. Okay. Coin swallowing, everything that is common, foreign body aspiration, everything common in right side. Okay, then mediastinum. So in mediastinum, usually one thing we have to note, mediastinum, which is divided into superior mediastinum. See here, this is superior mediastinum, then here inferior mediastinum. This inferior mediastinum again divided into the smaller area is known as anterior mediastinum. Then this area is anterior mediastinum. This is posterior mediastinum. This is middle mediastinum. Here superior mediastinum content they will ask, superior mediastinum content. In superior mediastinum, here see, here this is the sternal angle level, above to that superior mediastinum, easily we can say superior mediastinum contain arch of aorta and its branches. So in this picture, we can see here superior mediastinum, what are the content? Arch of aorta we can tell. Arch of aorta which is giving brachiocephalic, subclavian, common carotid. Okay. Here, what is the main difference mean? Here, this is left recurrent laryngeal nerve is a content of superior mediastinum. So superior mediastinum contain left recurrent laryngeal nerve. Left recurrent laryngeal nerve. Here see, this is arch of aorta. Here it is giving branches of arch of aorta. This is winds around by one nerve that is known as left recurrent laryngeal nerve is a content. But right recurrent laryngeal nerve is not a content. There only they will catch. Okay. Here because this brachiocephalic trunk which is divided into common carotid, left subclavian. Here right this subclavian, right subclavian is winds around by this right recurrent laryngeal nerve. So right recurrent laryngeal nerve is surrounding subclavian, left only surrounding arch of aorta. Here arch of aorta only a content. See here this is left recurrent laryngeal nerve. This is right recurrent laryngeal nerve. This is left, that is right. So left is a content of superior mediastinum, but right is not a content of the superior mediastinum. Okay. Then middle mediastinum content, if you see, heart is there. So heart, ascending aorta is there, superior vena cava is there, pulmonary trunk, it is divided into two branches. Okay. Then please remember phrenic nerve they will give. Phrenic nerve, yes, phrenic nerve, it is adherent to the heart. Okay. See here phrenic nerve is descending down. This phrenic nerve is tightly adherent to the pericardium. Okay. So phrenic nerve is a content. Then bifurcation of this thing also. So trachea coming down, trachea bifurcation also taking place in bifurcation of trachea also taking place where this middle mediastinum only. So just in front of bifurcation, one cardiac plexus is there, that is deep cardiac plexus. So that is also a content of middle mediastinum. So here we are highlighting some important differences. Superior mediastinum almost to answer the MCQ, please remember left recurrent laryngeal nerve is a content of superior mediastinum, but not right. Please remember. Middle mediastinum, please remember phrenic nerve is a content, bifurcation of trachea is a content, deep cardiac plexus is a content. Always other things we can answer ourselves. See, heart with pericardium answer, ascending aorta we can answer, pulmonary trunk division answer, lower half of SVC we can answer, pulmonary vein we can answer, everything we can answer. These three blue colored structures only we have to remember. Bifurcation of trachea in front of the deep cardiac plexus, phrenic nerve which is running very close to the pericardium. So that is also a content. Then let us move on to the posterior mediastinum content. Posterior mediastinum, that is easy. Here descending aorta is there, thoracic duct is there. Now only we have seen esophagus vein is there, esophagus is there. All are posterior mediastinum. So superior mediastinum, please remember left recurrent laryngeal nerve is a content of superior mediastinum, but not right. Deep cardiac plexus is a content of deep middle mediastinum. So nerves only mainly we have to remember. Then let us move on to pleura. Pleura, which is divided into parietal pleura, another one is visceral pleura. Intimate covering is formed by visceral pleura, outer covering is formed by parietal pleura. So here surface marking of pleura is very important. Surface marking of pleura is very important. So here surface marking of pleura, the lower limit mainly. So here the pleura in the very close to sternum, here 6th costal cartilage. Then we have to add 2 cartilage in mid clavicular line 8th. So here 6th, here 8th, in mid axillary line 10th. Posteriorly, okay, so mid scapular line, so that is 12th. So 6, 8, 10, 12. So that is the level. Okay, here see here. So right lung and left lung, the lower limit of the pleura is 6th rib where 6th in parallel to sternum. Then mid clavicular 8th, mid axillary 10th, paravertebral 12th. Okay, so this is about pleura surface marking. So what is the level of surface marking of pleura in mid clavicular line? Mid clavicular line 8th, mid axillary line 10th. So like that we have to answer. For the lung main, we have to reduce 2. We have to reduce in midsternal 2 only. So for the lung lower border, midsternal 6 only, the same. But mid clavicular we have to -2. So 6th rib, lung 6th rib. For example, here this is mid axillary line. This is mid axillary line. Mid axillary line, what is the pleura lower limit? 10th rib. What is the lung lower limit? 8th rib. So like that. So mid clavicular line mean, what is the pleura lower limit? 8th rib. What is the lung lower limit? 6th rib. Like that. Here paravertebral, what is the pleura lower limit? 12th rib. Here, what is the this one? Lung lower limit -2, 10th rib. So in mid axillary line, if we consider until the 8th rib, lung is there. So below the 8th space only, we have to I mean, in case of any aspiration or thoracocentesis, we have to do below the pleural taping or something mean we have to do below the 8th space only we have to perform pleural taping. So that point we have to remember. Then here lungs that is divided into many bronchopulmonary segment. Bronchopulmonary segment, see here lung is divided into many bronchopulmonary segment. So which bronchi is aerating? So this is one bronchopulmonary segment, this is one bronchopulmonary segment. So this is aerated by different thing, this is aerated by, I mean, providing air, different thing. So tertiary bronchi, this is supplied by one tertiary bronchi, this is supplied by one tertiary bronchi. So area of lung which is aerated by tertiary bronchi is known as bronchopulmonary segment. That is very, very important. So bronchopulmonary segments are aerated by tertiary bronchi. So see here primary bronchi, lobar bronchi, tertiary bronchi aerating the lung. So tertiary bronchi. So here all are pyramidal in shape. Surgically we can remove each segment. So here this is one of the largest respiratory unit supplied by tertiary bronchi, surgically resectable, pyramidal in shape. Okay, so here no pulmonary veins inside. What is no pulmonary veins inside? This is very, very important. Here this is one bronchopulmonary segment, this is other bronchopulmonary segment in between pulmonary septum. So pulmonary septum separating this bronchopulmonary segment from this adjacent bronchopulmonary segment. Within the bronchopulmonary segment, what are the things we are able to see? One bronchiole we are able to see, bronchial artery we are able to see, pulmonary artery we are able to see, pulmonary arteriole, bronchial artery, bronchi we are able to see. But where is pulmonary vein? Pulmonary vein not seen within the bronchi. In between bronchopulmonary segment we are able to see. See, pulmonary venule or pulmonary vein is intersegmental in nature, not intrasegmental. Pulmonary vein lies in between or it is passing through pulmonary septum. It is intersegmental in nature. These three intrasegmental in nature. So that is no pulmonary vein inside the what? Inside the bronchopulmonary segment. Okay, in between bronchopulmonary segments only pulmonary veins are there. That point we have to remember. Then these are some of the named bronchopulmonary. So bronchopulmonary segment right side, which is the most appropriate answer. Right side 10 in number. Left side how many in number? Left side please go with 9. Okay, left side 9 for bronchopulmonary segment. The right side 10, left side 9. These are aerated by some tertiary bronchi. Then some of the important thing here this thing here, this is the right side, because right side only aspiration common, because that is more in line with trachea. Now only we have seen. So here this right superior basal, here this is posterior basal. These two one of the commonest aspiration site. Okay, if one of the bedridden patient, one patient in supine position, okay, then another one position in erect or standing position, they are aspirating. So first supine position, bedridden patient is aspirating mean that will reach right superior basal. So every aspiration common in right side. So which one is commonly involved? So in case one person, he is bedridden patient, he is aspirating mean that will reach which one? Superior basal. If person erect standing position, it will reach most dependent right posterior basal. So please remember right posterior basal, right superior basal. So in erect posture, erect standing posture, right posterior basal. Right superior basal in which position? In bedridden patient, it is most common site of aspiration. Then where TB is more common? So right upper lobe posterior segment TB is common. Okay, so posterior segment. So here this upper one which has posterior anterior. So this is posterior, this is anterior. Okay, that posterior upper lobe posterior common for TB, upper lobe anterior that is common for cancer. So these are the points we have to remember. Then finally here this some of the hilar structure, that order we have to know that order. I mean, simply you remember here right side and left side. Here this is root of lung. So from above downward, here see pulmonary artery, bronchi, pulmonary vein. So this is pulmonary vein, this is bronchi. So left side also pulmonary artery, bronchi, pulmonary vein. So what is this? Pulmonary vein, bronchi, pulmonary artery. So from above downward, artery, bronchi, pulmonary vein. But right side before enter into lung, this bronchi divided into one more branch which lies here. So this is the order. Right side, this is artery, above to artery, arterial bronchi. This is pulmonary artery. This is below the pulmonary trunk, hypoarterial bronchi. Hypoarterial bronchi. This is pulmonary vein. So this is the order seen in right side root of lung. But left side after enter into bronchi, after enter into lung only divide. So this order is maintaining. Pulmonary vein, bronchi. Another one is the uppermost content is always pulmonary artery. So we can remember that in this way. Then one more thing, is it lung? I mean, it is also supplied by bronchial artery. Bronchial artery, right bronchial artery, left bronchial artery. So right lung is supplied by right bronchial artery, left lung is supplied by left bronchial artery. Left bronchial artery is a branch of aorta. Right bronchial artery is usually arising from right third posterior intercostal artery. Right bronchial artery, right side. So right side, it is originating from right third posterior intercostal artery. Third posterior intercostal artery. Okay. Left side directly a branch of aorta. Left side usually 2 in number. Right side usually single in number. So these are the points we have to remember. Then one important thing, right lung and left lung, main difference in case if it is right lung, above the right lung there is one arch. That arch is known as Asayas arch. Right side, okay, root of lung is surrounded by Asayas arch. Okay, see here, this is Asayas vein, arch of Asayas vein for the right side. But left side, we can see arch of aorta. Arch of aorta. Then one more thing, please remember here, always in front of, if this is root of lung, in front of root, one nerve is descending, behind the root, one. So this is common for right as well as left. In front of root, phrenic nerve is there. In front of root, phrenic nerve is there. Behind the root, vagus nerve is there. Vagus nerve. There are two root. Then right lung arched, that root of lung is arched by Asayas vein. Left side, arch of aorta. Then pericardium, which is enclosing the heart. Okay, pericardium, which is enclosing the heart, which is not only enclosing the heart, it is also enclosing here two arteries together. Okay, so here aorta and pulmonary trunk both are enclosed by pericardium. Like that, all the veins also here, superior vena cava is there, inferior vena cava is there, pulmonary vein, everything is enclosed by. For example, here aorta, pulmonary trunk, both are enclosed by one pericardium. Pericardium. So here superior vena cava, inferior vena cava, pulmonary vein, everything enclosed by pericardium. So this is known as this pericardium enclosing artery. So this is arterial tube. This pericardium enclosing vein. So venous tube. So in between arterial tube and venous tube, arterial tube enclosing aorta, pulmonary trunk, venous tube enclosing superior vena cava, pulmonary vein, inferior vena cava. So in between we can pass our finger. So there is a space. That space is known as, in between arterial tube and venous tube, there is a space. That is known as transverse sinus. That is known as transverse sinus. So during surgery, major cardiac surgery, ligation of major blood vessel, okay, that is done by using this space. So that point we have to remember, transverse. Then one more sinus. Here see, there are many veins. I mean, left atrium that is receiving pulmonary vein, left atrium that is receiving pulmonary vein. So here, so for pulmonary vein where it is open, left atrium into the left atrium upper. So here in between pulmonary vein there is a space that is known as oblique sinus. So where oblique sinus is present behind the left atrium. Where transverse sinus is present, in between aorta, pulmonary trunk, in between vena cava. Okay, so here transverse sinus is present. Transverse sinus main use, that is ligation of major blood vessel. Oblique sinus, it is allowing expansion of left atrium. Okay, so these are the points we have to remember. Then heart, here some borders of heart are very important. Here see, here we can see the right atrium, right ventricle, left ventricle. Okay, so here this is superior vena cava opens into right atrium, inferior vena cava opens into right atrium. This is considered as right border of heart. This is considered as right border of heart. So what are the structures forming right border of heart from above downward? Superior vena cava, right atrium, inferior vena cava. In X-ray also, here they may mark. So here this is pericardium, this is cardiac shadow. So here above downward, right border is formed by superior vena cava, right atrium as well as inferior vena cava. Let us move on to left border. Left border is formed by left ventricle. Here left ventricle we are able to see. Here left auricle or left atrium, then pulmonary trunk, then arch of aorta. So this is entirely left border. So from above downward, arch of aorta, pulmonary trunk, left auricle, left ventricle. So here if we see, here arch of aorta, pulmonary trunk, left auricle, another one is left ventricle. So this is left border of heart, this is right border of heart. Okay, then here apex of heart is formed by apex of heart, that is full and full, that is formed by, this is left ventricle, right ventricle, this is anterior interventricular groove. So left ventricle only going to form the apex of heart. So apex of heart only formed by which one? Apex of heart only formed by left ventricle. Okay, then next one, here base of heart. So base of heart is formed by apex of heart only formed by left ventricle. So base of heart only formed by, so here two atriums. So here this is left atrium, this is right atrium. Right atrium receiving superior vena cava, inferior vena cava. So right atrium and left atrium collectively forming base of heart, collectively forming base of heart. So this is right atrium, this is left atrium, both are forming base of heart, both are forming base of heart. Okay, so base of heart maximum contribution is left atrium only, 2/3 by left atrium, 1/3 by right atrium. So base of heart, 2 atrium, left ventricle forming which one? Apex of heart. Then here interior, the very important one, here right atrium interior, right atrium interior. Here we can see one important thing, that is known as here fossa ovalis. So this is fossa ovalis. Inside we are able to see the fossa ovalis. This area is known as triangle of Koch. This is crista terminalis. This is crista terminalis. So here this fossa ovalis is a remnant of septum primum. We will discuss in embryology, but it is a remnant of septum primum. So here I superior vena cava opening seen, inferior vena cava opening seen, fossa ovalis seen. So anterior part is rough, this part is smooth. We have to remember that. Then interior of left ventricle, we can see the papillary muscles. Interior of left ventricle, we can see the papillary muscle. Then more than that, coronary circulation is important. Coronary circulation is important. So coronary arteries are originating from aortic sinuses. Aortic sinuses. Aortic sinuses. Here see the proximal most part of aorta. There is a dilatation. Okay. If we put the cross section in this level, we can get these three sinuses. These three. Okay. So here we can get the sinuses like this. So there are three dilatation. So this is known as anterior aortic sinus. These two posterior, we have to differentiate both. So this is left side, left posterior aortic sinus. This is right posterior aortic sinus. So left posterior aortic sinus, this is right posterior aortic sinus. This is anterior aortic sinus. Anterior aortic sinus giving origin to coronary artery. Left posterior aortic sinus giving origin to one more thing, that is left coronary artery. So left coronary artery originating from left posterior aortic sinus. Left coronary artery originating from left posterior aortic sinus. Right coronary artery originating from anterior aortic sinus. Okay, so this is not giving origin to any coronary artery. So this is known as non-coronary sinus. This is known as non-coronary sinus. So this point we have to remember. Here, cardiac dominance. How we have to decide the cardiac dominance? See, this right coronary artery, if we trace mean, right coronary artery, if we trace mean, this is right coronary artery. First initially running in the anterior aspect of atrioventricular groove, then it is going posterior aspect of atrioventricular groove. Here it is giving posterior interventricular artery. So if right coronary artery giving posterior interventricular artery mean, that is right cardiac dominance. So according to the posterior interventricular artery only, we have to decide the cardiac dominance. So here it is given by which artery? Right coronary artery. So right cardiac dominance. Left cardiac dominance also there. Here look this picture. Here this is right coronary artery. Here right coronary artery initially in anterior aspect, then posterior aspect, but here it is giving not posterior interventricular artery, but this is left coronary artery. It is divided into left anterior descending, left circumflex artery. This left circumflex artery giving posterior interventricular artery. So according to the origin of posterior interventricular artery, we have to decide the cardiac dominance. So here this patient, this case, posterior interventricular artery originating from right coronary artery. So this is right cardiac dominance. Here this is left cardiac dominance. This is left cardiac dominance. So according to the posterior interventricular artery, we have to decide the cardiac dominance. We have to decide the cardiac dominance. Okay, these are the other named thing. Here interventricular artery branches. Interventricular, here some of the named branch. This right coronary artery usually giving one of the first branch, that is known as right conus artery. That is known as right conus artery. This right conus artery sometime take directly originating from this aortic sinuses. Okay, if aortic sinuses giving origin mean, that is coronary artery. So this right coronary artery giving right conus artery. but that right conus artery sometimes can direct origin from aortic sinus. So it is known as what? If it is originating from aortic sinus, that is known as third coronary artery. So which is known as third coronary artery, right conus artery. Then here this is left anterior descending or anterior interventricular artery. This anterior interventricular artery giving one named branch, that is known as diagonal artery. That is known as diagonal artery. Then interventricular septum. So here interventricular septum mainly supplied by two interventricular artery. Okay, see here this is interventricular septum. Anteriorly anterior interventricular septum, posteriorly posterior interventricular septum. So here interventricular septum, both side interventricular artery seen. Okay, posterior interventricular artery, anterior interventricular artery. So interventricular artery mainly supplied by these two interventricular artery only. Okay, so here mostly supplied by interventricular septum, mostly supplied by anterior interventricular artery. Okay, so anterior 2/3 by anterior interventricular artery, posterior 1/3 by posterior interventricular artery. Then blood supply to the conductive system. The conductive system, please remember here this is SA node, AV node. Okay, then bundle of His. This is right bundle, this is left bundle, right bundle, left bundle. So here the proximal part, SA node, AV node. Okay, until bundle of His. Please remember in simple way, proximal part is supplied by right coronary artery, distal part is supplied by left coronary artery. Distal part is supplied by, bundle of His, everything is supplied by left coronary artery. So this is supplied by left coronary artery, this is supplied by right coronary artery. Don't confuse. SA node mainly supplied by right coronary artery, AV node supplied by right coronary artery, bundle of His supplied by right coronary artery. To this thing, right bundle branch, left bundle branch supplied by left coronary artery. So proximal part right, distal part left. Okay. Okay, so here coronary sinus, venous drainage is done by coronary sinus. So this coronary sinus, which is receiving many veins, many named vein. So to the answer the MCQ, okay. So here it is receiving, what are the vein? One is great cardiac vein, another one is middle cardiac vein. Okay, from the left atrium, some oblique vein of Marshall. So here it is receiving only one point you remember, it is not receiving anterior cardiac vein. Coronary sinus, it is not receiving anterior cardiac vein. All the other vein, whatever vein given, that is drained into coronary sinus, because it is receiving great cardiac vein, oblique vein of Marshall. There are so many things, but anterior cardiac vein is not a tributary of coronary sinus. It is directly opening. In this picture also we can see. So anterior cardiac vein directly opens into right atrium. Okay, it is not opens into coronary sinus. We have to remember that. Then some of the esophageal this thing, constriction as well as blood supply. Esophagus, above it is continuous with pharynx. Okay, so here esophagus, when it is coming down, esophagus at some places it presents some constriction at the beginning. Okay, here it is continuous with this thing, no, pharynx, no. So pharyngoesophageal at the C6 vertebral level, C6 vertebral level, one constriction is there. Then esophagus is coming down. Okay, at one point it is related to arch of aorta. There one constriction is there, arch of aorta. Beginning level one constriction, first constriction, arch of aorta, second constriction. Here left principal bronchus crossing that, their third constriction. At one point it is enter into diaphragm, fourth constriction. Totally 4 constrictions are there. Okay, so here these levels are very important. So site of constriction at the beginning, pharyngoesophageal junction at the beginning. Okay, so here see beginning, pharyngoesophageal junction. Okay, then second aortic arch, third left principal where it is crossed by left principal bronchus, then esophageal hiatus in diaphragm. So at the beginning, what is the vertebral level? C6 vertebral level. How many centimeter from the upper incisor teeth? 15 centimeter. Then aortic arch, what is the vertebral level? T4. Left principal bronchus, what is the level? T6. Esophageal hiatus, what is the level? T10. How many centimeter? 15 centimeter, 23 centimeter, 28 centimeter, 40 centimeter. So these are the 4 level causing site of constriction of esophagus, vertebral level, distance from upper central incisor. This is very important. Okay, then esophagus mainly supplied by cervical esophagus. Please remember, cervical esophagus is mainly supplied by inferior thyroid artery. Inferior thyroid artery. So inferior thyroid artery is a branch of thyrocervical trunk which is going to supply esophagus. Cervical esophagus is mainly supplied by from above inferior thyroid artery, from below left gastric artery. 2 things we have to remember. Okay, from below left gastric artery, from above inferior thyroid artery. Inferior thyroid artery. Venous drainage also done into inferior thyroid vein. So that also we have to remember. Okay. Then thoracic duct. So thoracic duct already we have discussed. It is one of the content of the it is one of the content of the. So here this is aortic opening level. Aortic opening, there are three structure. Aorta is passing, esophagus vein is passing, thoracic duct is passing. Thoracic duct beginning with cisterna chyli. Okay. Then after that it is ascending up at the T5 vertebra level. It is crossing from little bit. It is crossing from right to left side. Then finally it is drained into left junction of the left internal jugular vein and subclavian vein. So thoracic duct, it is mainly draining all over the body, except right side upper limb, right side chest, right lung, right side head and neck, except right head, because these are the area: right upper limb, right chest, right lung, right side head and neck is drained by right lymphatic trunk. Right lymphatic trunk. So almost all the other areas are drained by thoracic duct only. So thoracic duct, but what vertebral level it is crossing from right to left side. That is one important. At what vertebral level it is draining into this junction of internal jugular vein, subclavian vein. So this is also important. Okay, we can move into the next area, head and neck. Okay, 2 minutes break. Sorry. Okay, so we will start head and neck. First we will start from neck region. So neck, after removing the skin, we can see the platysma. What is the now supply to platysma? Platysma is supplied by facial nerve. Then if we remove the platysma, deep cervical fascia, we are able to see the deep. We can see the deep cervical fascia. Okay, so deep cervical fascia also, if we remove, we can see the triangles of neck. Okay, triangles of neck. So see here, this is sternomastoid muscle. The area in front of sternomastoid is known as anterior triangle. Anterior triangle. Behind the sternomastoid is known as posterior triangle. Okay, so this is posterior triangle. So here posterior triangle, first we are going to complete. Posterior triangle, that is anteriorly limited by sternomastoid muscle, posteriorly trapezius, base is created by or formed by clavicle. Okay, so this is the posterior triangle, which is divided into two parts by one muscle, that is omohyoid, inferior belly of omohyoid. So anteriorly sternomastoid, posteriorly trapezius, base is caused by clavicle, which is divided into two. Okay, so by one muscle, that is inferior belly of omohyoid. Okay, so this entire thing is posterior triangle, but which is subdivided into this upper part above the omohyoid. This is occipital triangle. Below the omohyoid, supraclavicular or subclavian triangle. So occipital triangle, supraclavicular triangle, collectively known as posterior triangle. So in this posterior triangle, two things we have to remember. Posterior triangle roof is pierced by external jugular vein. Posterior triangle roof is pierced by external jugular vein. In the roof of posterior triangles, here see, this is sternomastoid, this is trapezius, this is roof. Roof contain one vein, external jugular vein, also four important nerve. So on the posterior aspect of sternomastoid, one nerve point is there, four nerve diverging. Okay, so here some of the nerve, out of that, here transverse cervical nerve, great auricular nerve, lesser occipital nerve, supraclavicular nerve. Okay, please remember, roof of the posterior triangle is pierced by external jugular vein, four nerves are there. There is a nerve point. We have to remember that. Okay, then great auricular nerve. What is the importance of great auricular nerve? Entire face sensory supply is done by trigeminal nerve only, except this angle of mandible. Sensory supply is provided by great auricular nerve. Great auricular nerve present in the roof of the posterior triangle, which is providing sensory supply to the angle of mandible. So that point we have to remember. Then posterior triangle, what is the important content? Posterior triangle, the important content, that is spinal accessory nerve. There are so many lymph nodes present in spinal accessory nerve. So here some pus formation is common in case of infection. So in case if we drain that pus, when we put incision, spinal accessory nerve accidentally can be damaged. If it is damaged, mean which nerve can be paralyzed? Here, this is spinal accessory nerve, which is the full nerve supply for the sternomastoid as well as trapezius. So here, first it is crossing sternomastoid. At the time, it is providing supply to the sternomastoid, then enter into posterior triangle. Now we are incising the posterior triangle. At the time, accidentally, if we damage mean, the distal to the trapezius muscle will be gone. So in case of posterior triangle injury of spinal accessory nerve, which muscle will be paralyzed? Trapezius. Is sternomastoid paralyzed or not? Sternomastoid will be escape. Okay, so if trapezius gone, mean shrugging is not possible. Already we have discussed. Shrugging of shoulder is not possible. Okay, then partial winking of scapula also. Overhead abduction become difficult. So trapezius actions we get discussed. So spinal accessory nerve is one of the important content. So spinal accessory nerve is one of the important content. Then this is posterior triangle. Uppermost part contain occipital artery, then subclavian triangle. Just so because posterior triangle is a combination of two. This is occipital triangle, this is subclavian triangle. Subclavian triangle contains subclavian vessel. So what are the three main content of the posterior triangle? One is spinal accessory nerve, subclavian vessels, another one is occipital artery. So this is about it. So here, in case of any injury of spinal accessory nerve in posterior triangle, sternomastoid will be escape. Only trapezius will be gone. Shrugging is not possible. Overhead abduction is not possible. Winking of scapula will be seen. Okay. So here, little bit about root of leg. So posterior triangle over. Root of neck. Root of neck mean deep dissection of this area. For that we are going to, because by using that scalenus anterior relation, we are going to deeply dissect this area. So at that time, if we deeply dissect here, this muscle is known as scalenus anterior muscle. This muscle is known as scalenus anterior muscle. This muscle is known as scalenus medius muscle. Okay, both are inserted into first strip. This is first strip. After removing all the other muscle, scalenus anterior medius. Okay, in between there is a triangle. The triangle is known as scalene triangle. What is scalene triangle? The space in between scalenus anterior and medius is known as scalene triangle. Scalene triangle transmit subclavian artery. Subclavian artery brachial plexus. So what are the content of scalene triangle? Subclavian artery and brachial plexus. Then scalene triangle, is it transmitting this one subclavian vein? No. See here, scalenus anterior muscle in front of that subclavian vein, behind to that subclavian artery. So subclavian vein and artery separated by scalenus anterior. Any other picture? See here, this is scalenus anterior muscle, which is separating subclavian artery in front, subclavian subclavian vein front, subclavian artery behind. So this triangle is scalene triangle. So in case of thoracic outlet obstruction, for example, cervical rib or something, this space will be compressed. Okay, so brachial plexus will be compressed. So numbing sensation, tingling sensation, numbness in upper limb seen. Okay, then here artery compression, so claudication and all possible. Okay, so here this is thoracic outlet syndrome common in scalene triangle. Okay, so in that case subclavian vein will be escape. Subclavian vein will be escape. Okay, then scalenus anterior, some important relation, very important. So scalenus anterior, we are going to magnify this. Some of the important relation we are going to discuss. This scalenus anterior to that one vein is running. That vein is known as phrenic nerve. That vein is here. See, scalenus anterior medius. See, behind the scalenus anterior, what artery is there? Subclavian artery. Brachial plexus is there. In front of scalenus anterior, subclavian vein is there. Okay. Then here one nerve is descending down. That nerve is known as phrenic nerve. Phrenic nerve lies in front of scalenus anterior. Very, very important. Phrenic nerve lies in front of scalenus anterior. Then scalenus anterior, it is also anterior to that common carotid artery, internal jugular vein, vagus nerve. So carotid sheath and its content, that is also there. Then this is thyrocervical trunk. Thyrocervical trunk divided into transverse cervical artery, which is divided into suprascapular artery, transverse cervical artery. Another one is inferior thyroid artery. All are lies in front of scalenus anterior. So this is the complete list. Scalenus anterior relations are subclavian vein anteriorly, carotid sheath content, phrenic nerve, branches of thyrocervical. Posteriorly, subclavian artery, trunks of brachial plexus. Okay. Then what are the structures covered by carotid sheath? So carotid sheath contain here common carotid artery, internal carotid artery, external carotid artery is not a content. Then internal jugular vein, in between carotid artery and internal jugular vein, vagus nerve is there. So this is the carotid sheath and its content. Carotid artery, internal jugular vein, vagus nerve. Posterior to carotid sheath, sympathetic trunk, anteriorly ansa cervicalis. So these are the structure. Let us move on to next triangle. So carotid triangle over, root of neck over, anterior triangle, carotid triangle we are going to discuss. Within the carotid triangle, what are the structure we are able to see? Within the carotid triangle, carotid sheath and its content. So carotid sheath and content, internal jugular vein, internal carotid artery, common carotid artery, in between vagus nerve is there. So the same thing. Additionally, two other nerves are there. One is spinal accessory nerve. Spinal accessory nerve, and it is one of the content of posterior triangle, but before that, it is a content of carotid triangle. It is a content of carotid triangle, then only it enter. So how many cranial nerve seen in carotid triangle? 3 cranial nerve seen in carotid triangle. Please remember, 3 cranial nerve seen in carotid triangle. What are the 3 cranial nerve seen? The first cranial nerve, that is known as spinal accessory. Vagus is vertically descending down. Spinal accessory nerve, also hypoglossal nerve seen. Also hypoglossal nerve. So totally 3 nerve seen. Yes. What are the 3 nerve? Hypoglossal nerve seen, vagus nerve vertically descending down, spinal accessory nerve seen. Okay. Also, what are the other things seen? Here, internal jugular vein seen, internal carotid artery seen, common carotid artery bifurcation, internal carotid artery, external carotid artery branches seen. What are the branches seen? First 5 branches of external carotid artery seen. What are the first 5 branches? Which is the first branch of external carotid artery? Superior thyroid artery is the first branch of external carotid artery. Superior thyroid artery is the first branch of external carotid artery. Then lingual artery, facial artery seen. Okay, ascending pharyngeal artery seen. Another one is occipital artery seen. So these are the structures seen in where? These are the structures seen in carotid triangle. Then digastric triangle, if you moving, digastric triangle, what are the boundary? Carotid triangle, what are the boundary? Carotid triangle, this is the sternomastoid muscle, superior belly of omohyoid muscle, posterior belly of digastric muscle, This is anterior belly of digastric. This is lower border of mandible. So this is digastric triangle. This is carotid triangle. Carotid triangle contain 3 cranial nerve, spinal accessory nerve, hypoglossal nerve, vagus nerve. Please remember. Then digastric triangle. The floor, digastric triangle, here see, posterior belly of digastric, anterior belly of digastric. Floor contain 2 muscle, mylohyoid muscle. From mandible to hyoid bone, mylohyoid muscle. Also from hyoid bone to tongue, hyoglossus muscle, mylohyoid as well as hyoglossus. There are two muscles forming floor of digastric triangle. One is extending from mandible to hyoid, another one is extending from hyoid to tongue. So these are the two muscle. Okay, in between these two muscle, this is mylohyoid, this is hyoglossus. In between these two, the here submandibular salivary gland is present. Submandibular salivary gland is present. Partially lies outside, partially sandwiched in between these two. Partially sandwiched in between these two. Here, some of the nerve supply also here itself we can discuss. Here, what is the nerve supply to the trapezius? Spinal accessory nerve. What is the nerve supply to the sternomastoid? Spinal accessory nerve. Digastric, posterior belly of digastric, what is the nerve supply? Facial nerve. Anterior belly of digastric, what is the nerve supply? Facial nerve. Sorry, so anterior belly of digastric is supplied by mandibular nerve. Then here, this is superior belly of homohyoid, inferior belly of homohyoid. All other this strap muscle or infrahyoid muscles are supplied by, what is that? Yeah, it is supplied by ansa cervicalis. So these are supplied by ansa cervicalis. This is supplied by spinal accessory nerve, facial nerve. Here, mandibular nerve. Then here, mylohyoid, which is supplied by what? Mylohyoid is supplied by again mandibular nerve. Then hyoglossus, which is supplied by, this is a can you see the PowerPoint?
Yes, sir.
Yes, sir.
Okay, so this mylohyoid, which is also supplied by mandibular nerve, hyoglossus, which is supplied by hypoglossal nerve. So here, what are the other content? So in between these two, here this is the superficial part of the submandibular gland. This is the deep part of the submandibular gland. We are able to see. Now, next picture. This hyoglossus relations are very important. Hyoglossus. So this muscle, some of the structure lies outside, some of the structure deep to that. For that, to visualize the hyoglossus muscle, we are going to remove this mylohyoid. We are going to remove this gland also, outer part of the gland. So at that time, we will get the picture like this. So clearly we can see the hyoglossus. So here hyoglossus superficial to that. Please remember, this is very important. This one is known as superficial to that. Hypoglossal nerve is present. Hypoglossal nerve, which is reaching tongue and providing motor supply. Hypoglossal nerve, superficial to hyoglossus. Lingual nerve, superficial to hyoglossus. Lingual nerve, superficial to hyoglossus. Lingual nerve, which is suspending submandibular ganglion, so which is also lies outside. Then here, deep part of the gland, submandibular gland. See, these are the four structures lies outside. Okay, what are the four structure? Hypoglossal nerve, lingual nerve. So easily we can remember, lingual nerve reaching tongue and providing sensory supply. Hypoglossal nerve reaching tongue and providing motor supply. Okay, then lingual nerve suspending on ganglion, submandibular gland. Middle part is gland and its ganglion. Upper part and lower part, tongue nerve. What are the tongue nerve? One is lingual nerve, another one is known as hypoglossal nerve. Deep to the hyoglossus, one nerve is going. That nerve is known as glossopharyngeal nerve. Deep to the hyoglossus, superficial to that tongue nerve. Superficial, deep to that pharyngeal nerve, that is glossopharyngeal nerve. Also deep to that lingual artery is going. So lingual nerve superficial, lingual artery deep, please remember. Then nerve supply of the neck muscle, just now we have discussed. Okay, but here we have to note that ansa cervicalis, we want to clarify one thing, that is strap muscle, infrahyoid muscle. Infrahyoid muscle, there are, what are the muscles are? One muscle which is extending from here sternum to thyroid cartilage, sternum to thyroid. So this is sternum here to thyroid cartilage, sternothyroid. Okay, then one more muscle, sternum to hyoid, sternohyoid. Then omohyoid, superior belly, inferior belly, all are present below to the hyoid bone. So everything is known as strap muscle. In strap muscle, one more thing, for example, easily we can draw this. This is hyoid bone, this is thyroid cartilage, here sternum. So if sternum to hyoid, sorry, thyroid cartilage, any muscle is extending, mean that is sternothyroid. If sternum to hyoid, any muscle extending mean, that is sternohyoid. Sternohyoid. Then superior belly of omohyoid, inferior belly of, this is superior belly of omohyoid. This is inferior belly of omohyoid. This is superior belly, inferior belly. This is sternothyroid, sternohyoid. Then from thyroid to hyoid, any muscle extending mean, what is that? Thyrohyoid. What is that? Thyrohyoid. Here, the now supply wise, superior belly of omohyoid, inferior, here, superior belly of omohyoid, inferior belly of omohyoid, sternohyoid, sternothyroid. Everything is supplied by ansa cervicalis. Everything is supplied by ansa cervicalis, except one strap muscle is not supplied by ansa cervicalis, that is thyrohyoid. Then what is the now supplied to the thyrohyoid? That is supplied by C1. Which strap muscle is not supplied by ansa cervicalis? That is C1. Please remember, thyrohyoid is supplied by C1. Thyrohyoid is supplied by C1. How? Here, hypoglossal nerve, which is running through anterior triangle, we know at the time it is also carrying C1 fiber, which is also carrying C1 fiber. So here C1 fiber, which is running through hypoglossal nerve, here few fiber leaving the hypoglossal nerve descending down. This is known as descendants hypoglossi. This is known as what? Descendants hypoglossi. Like that, C to C3 join together and form descendant cervicalis. So this is a descendant cervicalis. This is a descendant hypoglossi. Both are joined together and form ansa cervicalis. This ansa cervicalis is combination of this C1 fiber, C2, C3 fiber, which is going to innervate all the strap muscle, but except C thyrohyoid. Thyrohyoid is not supplied by this part. It is directly supplied by some of the C1 fiber running through hypoglossal nerve. So thyrohyoid, there are two muscles in neck directly supplied by C1. One is geniohyoid, another one is thyrohyoid. Please remember, neck, two muscles are directly supplied by or solely supplied by C1 fiber. One is geniohyoid, another one is thyrohyoid. Out of that, geniohyoid is a suprahyoid muscle, thyrohyoid is a infrahyoid muscle or strap muscle. So the question is, which strap muscle is supplied by C1? Not geniohyoid. Thyrohyoid is the answer. What are the muscles are supplied by C1? Geniohyoid, thyrohyoid. That is the answer. So care should taken. Then let us move on to suboccipital triangle. Already we have completed this thing. Suboccipital triangle, usually what are the content? In that case, if they give occipital artery, that is attractive one. Is occipital artery is a content of suboccipital triangle? No. Occipital artery is a content of posterior triangle. Occipital artery is a content of posterior triangle. Already we have seen that. Posterior triangle contain three main content. One is subclavian artery and vessels. Another one is spinal accessory nerve. Another one is occipital artery. All are content of posterior triangle. Suboccipital artery contain vertebral artery. Third part, here it is wrongly typed, vertebral artery. So third part of vertebral artery. Okay. Another one is suboccipital triangle contains suboccipital nerve. Okay. So please remember. So suboccipital triangle contains. So occipital artery is a content of posterior triangle, not suboccipital triangle. Then deep cervical fascia. Here it is enclosing two muscle. Deep cervical fascia, if you see, it is enclosing here anterior to posterior sternomastoid as well as trapezius muscle. Then this investing layer, which is also enclosing two gland. One is parotid, another one is submandibular salivary gland. Okay. Then here something about thyroid gland. So here mainly three glands in head and neck region. One is parotid gland, another one is submandibular gland. Both are enclosed by investing layer of deep cervical fascia. So deep cervical fascia, which is divided into many layer. Okay. So in detailed manner we are not going to discuss. So here investing layer, which is enclosing parotid gland, submandibular gland, both are here enclosed by what layer? Investing layer. In front of trachea, thyroid is there, which is enclosed by pretracheal layer. See here, these are the thyroid cartilages. Okay. Laryngeal and tracheal cartilages in front of that thyroid gland, which is enclosed by what? Pretracheal layer. So thyroid is enclosed by pretracheal. This parotid as well as submandibular is enclosed by investing layer. See, one more thing here. This is thyroid, which is completely enclosed by pretracheal layer. So in case of thyroid swelling, upward extension of thyroid is prevented by this pretracheal layer only. So thyroid, if it is enlarged, mean upper side it won't enlarge. Okay, that is because of this is a tightly enclosed by pretracheal layer. One more thing, the same pretracheal layer also forming one more ligament. That ligament is known as ligament of Berry. So this pretracheal layer forming a ligament of Berry, that ligament of Berry attached to cricoid cartilage. That ligament of Berry attached to cricoid cartilage. Because of that, it is enclosed by, see here, if we trace it upward, this pretracheal layer, it is reaching hyoid bone. Through the cricoid cartilage, through the ligament of Berry, it is also attached to cricoid cartilage. So only thyroid also moving with the deglutition. Thyroid, is it moving with the deglutition? Yes. Why? It is through the pretracheal layer, it is attached to hyoid bone. Through the ligament of Berry, it is attached to cricoid cartilage. Those structures moving with the deglutition. So thyroid also moving with the deglutition. Parotid enclosed by investing layer. Submandibular enclosed by investing layer. Thyroid is enclosed by pretracheal layer. Ligament of Berry is a modification of what? That is also pretracheal layer. That is also a pretracheal layer. Okay. Then one more thing. So here axillary sheath we know. So axillary sheath enclosing how many structure? Axillary sheath which is going to enclose subclavian axillary artery. Axillary artery is enclosed by this one, axillary sheath. Okay, axillary artery enclosed by axillary sheath. This axillary sheath is a modification of prevertebral layer. So please remember 3 important point. Investing layer, there are deep cervical fascia divided into investing layer, pretracheal layer, prevertebral layer. Prevertebral layer going to form axillary sheath. Parotid submandibular enclosed by investing. Thyroid, that is enclosed by pretracheal. So these are the 3 important points we have to remember. Thyroid. Okay, so thyroid is developed from thyroglossal duct. Thyroglossal duct. Okay, so thyroglossal duct from the tongue region, which is descending down and reaching the neck, then it is bifurcate and forming the thyroid. Sometime if it is failed to descend mean, that will leads to ectopic thyroid, which is the commonest site of ectopic thyroid. Lingual thyroid is the commonest site. Okay, lingual thyroid is the commonest site. Okay, then here it is enclosed by pretracheal layer. Because of that thyroid, that is, I mean, it won't grow upper side. So that point we have to remember. Then thyroid blood supply, superior thyroid artery, inferior thyroid artery. Superior thyroid artery is a branch of, first branch of external carotid artery. Then inferior thyroid, already we have discussed, inferior thyroid artery is a branch of thyrocervical trunk. It is a branch of the thyrocervical trunk. This inferior thyroid artery also supplying esophagus also. Then little bit about venous drainage, thyroid gland venous drainage. Thyroid gland, it is drained by 4 set of vein. One is superior thyroid vein, another one is middle thyroid vein, one more vein that is known as inferior thyroid vein. Okay, so see, please come to this picture. Superior thyroid vein, it is drained into internal jugular vein. Middle also drained into internal jugular vein. Then inferior thyroid vein, this is not drained into internal jugular vein, it is drained into brachiocephalic vein. Then this is Kocher's vein, 4th thyroid vein, it is drained into internal jugular vein. So here answer is, what are the thyroid vein drained into internal jugular vein? Okay, all are drained into internal jugular vein except which one? Inferior. Okay, what about superior, middle, another one is 4th, all are drained into internal jugular vein. Okay, so these are the things we have to remember. Then emergency tracheostomy, we are cutting this in front of trachea, we are putting incision. So in the midline structure will be damaged. Okay, what are the structure can be damaged, like that question. Then this one more thing, thyroid arterial supply, it is supplied by superior thyroid artery, inferior thyroid artery. Okay, superior thyroid artery constantly a branch of external carotid. Another one is first part of subclavian artery, thyrocervical trunk, which is giving inferior thyroid artery, which is also can be supplied by arteria thyroidea. See here, can you able to see arteria thyroidea? Yes, it can be. Arteria thyroidea, it can be a variable origin. It can be originating from brachiocephalic trunk, it can be originating from arch of aorta. So constantly it is originating from here only. We can't tell like that. So arteria thyroidea. So now it is lies in midline. So this is also can providing blood supply. So now we are putting emergency tracheostomy. We are cutting here. Midline structure can be damaged. What are the structure present in midline? Here arteria thyroidea present in midline. Can it be damaged or not? Yes, it can be damaged. Inferior thyroid vein present in midline. It can be damaged. Left brachiocephalic vein crossing the midline. It can be damaged. So what are the structure can be? So what is the answer? Here in emergency tracheostomy, the following structure can be damaged except isthmus of thyroid. Yes, it is crossing midline, can be damaged. Yeah, arteria thyroidea in midline, inferior thyroid vein in midline, but inferior thyroid artery, it is approaching from lateral side. It is not in midline. If you put in incision here, it won't be damaged. So these are this thing we have to remember. Then oral cavity. Oral cavity, tongue. So here tongue, the first one important thing, which is the safety muscle of tongue. The safety muscle of tongue is known as genioglossus. Which is the safety muscle of tongue? Genioglossus. Genioglossus is the safety muscle of tongue. Then nerve supply. All the muscles of tongue is supplied by hypoglossal nerve. Hypoglossal nerve, motor supply, except only one muscle, that is palatoglossus. That is palatoglossus, which is supplied by which nerve? Cranial accessory nerve. Cranial accessory nerve. So please remember, genioglossus is the safety muscle of tongue, because falling back of tongue. So in case if we become unconscious, mean tongue will fall back and produce respiratory obstruction, that is done by or prevented by genioglossus. So that is known as safety muscle of tongue. So nerve supply of tongue, motor supply, all the muscles of tongue is supplied by hypoglossal except palatoglossus, which is supplied by cranial accessory nerve. Cranial accessory nerve. Then let us move on to the sensory supply. Anterior two-third of tongue. So for example, here if we draw, this is anterior two-third of tongue. Here normal general sensation, taste sensation. Taste sensation is carried by chorda tympani. Taste sensation is carried by chorda tympani. Normal general sensation is carried by lingual nerve. Lingual nerve. Okay. So here there is a sulcus terminalis. Sulcus terminalis, which is dividing anterior two-third, posterior one-third. From the posterior one-third, both sensation, I mean taste as well as general sensation, both are carried by ninth cranial nerve, glossopharyngeal nerve. So glossopharyngeal nerve, from the posterior one-third, both sensation carried by glossopharyngeal nerve. Glossopharyngeal nerve. Posterior most part, here in front of, this is epiglottis. Posterior most part, all the sensation carried by vagus nerve or internal laryngeal nerve. So here it is carried by internal laryngeal nerve or vagus nerve. So please remember, anterior two-third, lingual nerve, general sensation, chorda tympani, taste sensation, posterior most part, everything is carried by glossopharyngeal nerve. Everything is carried by glossopharyngeal nerve, vagus nerve, posterior most part. But here one catch, here circumvallate papillae, which lies in anterior two-third only. But for the circumvallate papillae, all the sensations are carried by glossopharyngeal nerve. Glossopharyngeal nerve. In spite, it is lies in anterior two-third, but this won't work for this one. Circumvallate papillae. Okay, circumvallate papillae, everything is carried by glossopharyngeal nerve. Then here one more important point, palatine tonsil. Palatine tonsil. Here palatine tonsil also some taste buds are there. From the palatine tonsil, taste sensation is carried by what? General sensation is carried by what? Both are carried by the same glossopharyngeal nerve. Glossopharyngeal nerve. So here conclusively, glossopharyngeal nerve carrying taste sensation from circumvallate papillae, palatine tonsil, posterior one-third of tongue. From the posterior one-third of tongue, from the circumvallate papillae, from the posterior one-third of tongue, from the circumvallate papillae, also palatine tonsil, all the sensation carried by glossopharyngeal nerves. Then soft palate also taste buds are there. From here taste sensation is carried by facial nerve. From here general sensation is carried by glossopharyngeal nerve. Glossopharyngeal nerve. So these are the important points we have to remember. Then in case of hypoglossal nerve injury, here tongue will move to the affected side. Affected side. We have to remember that, because the reason is here this is the midline. Here one side genioglossus, other side genioglossus, they are trying to pushing each other. This side paralysis mean this side muscle become dominant, so tongue that is deviated to affected side. This side palsy mean palsy side it will be deviated. So this person right side palsy or left side palsy, here left side is deviated, so left side palsy. Left side is deviated, left side palsy. So these are the things we have to remember. Then palatine tonsil, the main palatine tonsil, 2 points we have to remember. Palatine bed is formed by what muscle? Palatine bed. Palate that is located on one muscle. That muscle is superior constrictor. That muscle is superior constrictor. So superior constrictor muscle forming the palatine bed. Then one more thing here, tonsil, blood supply. The tonsil, the blood supply is mainly provided by facial artery. Tonsil mainly blood supply is provided by facial artery. Facial artery giving here tonsillar artery directly, ascending palatine artery also, ascending palatine, descending palatine artery is a branch of maxillary artery. So please remember, facial artery is the main supply. Let us move on to pharynx. Pharynx, some of the important thing here, pharynx is divided into nasopharynx, oropharynx, laryngopharynx, 3 parts it is divided, 3 parts it is divided. Nasopharynx, the character here, this area is nasopharynx. Okay, nasopharynx is Eustachian tube opening scene. That is the main characteristic feature. Okay, immediately behind to that, there is a fossa that is known as fossa of Rosenmuller. So nasopharynx contain this Eustachian tube opening scene, then fossa of Rosenmuller scene. Fossa of Rosenmuller is the commonest site of cancer in nasopharynx. So cancer nasopharynx, where it is commonly seen, fossa of Rosenmuller it is seen. Fossa of Rosenmuller it is seen. So this is Eustachian tube opening. Then if we coming below, this area is known as oropharynx. Oropharynx contain palatine tonsil. Then if we coming here, the lowermost part, that is hypopharynx, the important characteristic features of hypopharynx. So hypopharynx which contain pyriform fossa, which contain pyriform fossa. So pyriform fossa is a component of the lowermost part of larynx. Okay, so here the partly which lies behind the larynx, so this is nasopharynx. Partly behind the oral cavity, so this is oropharynx. Partly behind the larynx, so this is known as laryngopharynx. So laryngopharynx component hypopharyngeal, so hypopharynx mean laryngopharynx. So what are the component? One is pyriform fossa, then this is the cricoid cartilage. So the area behind the cricoid cartilage, this region is known as post-cricoid region. So post-cricoid region, pyriform fossa, both are component of laryngopharynx. Both are component of laryngopharynx. Oropharynx contain palatine tonsil. Like that, here the uppermost part, this contain Eustachian tube opening, adenoid as well as fossa of Rosenmuller. So these are the characteristic features. Then muscles. If we discuss, 3 constrictor muscles are there. Okay, superior constrictor muscle, middle constrictor muscle, inferior constrictor muscle. This inferior constrictor muscle originating from 2 component. Okay, see here it is partially, it is originating from thyroid. It is partially originating from, so this is superior constrictor muscle, this is middle constrictor muscle. Here inferior constrictor, it is having 2 component. It is originating from thyroid, so this is known as thyropharyngeus. This is originating from cricoid, cricopharyngeus. So both are collectively known as inferior constrictor. So 3 constrictor: superior constrictor, middle constrictor, inferior constrictor. So here now supply wise, all the muscles of pharynx is supplied by cranial accessory nerve. Cranial accessory nerve or vago accessory complex. Vago accessory complex. Also, all the things are supplied by vago accessory complex except 2 nerve. Except 2 nerve. One muscle number 1, stylopharyngeus. Muscle number 1, stylopharyngeus. Muscle number 2, cricopharyngeus. 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 Pharyngeus. Okay. So stylopharyngeus is supplied by 9th nerve, glossopharyngeal nerve. Stylopharyngeus is supplied by which nerve? 9th nerve. Then cricopharyngeus is supplied by which nerve? Recurrent laryngeal nerve. So again, repeating here, superior constrictor muscle, middle constrictor muscle, this inferior constrictor upper component, thyropharyngeus, all are supplied by vago accessory complex. All are supplied by vago accessory complex. Then salpingopharyngeus, palatopharyngeus, everything, I mean longitudinal muscle, everything is supplied by vago accessory complex except 2, stylopharyngeus muscle, which is supplied by 9th nerve. Stylopharyngeus is supplied by which nerve? 9th nerve. Like that, cricopharyngeus muscle, the lowermost part of inferior constrictor, which is supplied by recurrent laryngeal nerve, which is supplied by recurrent laryngeal nerve. See here, palatine tonsil, that is beautifully located on the superior constrictor muscle. So palatine bed is formed by superior constrictor muscle. Okay, so here some of the structure, I mean here, this is superior constrictor muscle, this is the base of skull. So in between there is a space. So superior constrictor muscle, base of skull, in between there is a space. The space transmitting auditory tube along with levator palli-palati, then something, I mean pharyngeal branch of the ascending palatine artery, something. So auditory tube, levator palli-palati. So it is seen in the space is known as sinus of Margagni. Okay, so base of skull, superior constrictor, in between the space is known as sinus of Margagni, which will transmit auditory tube. Another one is levator palli-palati. Then here superior constrictor muscle, middle constrictor muscle, in between there is a gap. Here glossopharyngeal nerve will go. Here glossopharyngeal, the space in between superior and middle, glossopharyngeal nerve, and it is going to supply stylopharyngeus. So both are, so between superior and middle constrictor, stylopharyngeus, glossopharyngeus. So for sinus of Margagni, auditory tube, levator palli-palati. So like this chart is important. So between middle and inferior constrictor, so some internal laryngeal nerve. Okay, so here upper 2 spaces are very important. So sinus of Margagni transmit auditory tube, levator palli-palati. In between superior and middle constrictor, stylopharyngeus, glossopharyngeal nerve. So that point is important. Here weak area of the pharynx, which is known as weak area. Here Here some space is there. Here in between middle and inferior constrictor some space is there, but here wider spaces is there. But now supply wise, the superior constrictor, middle constrictor supplied by same nerve. So if firing of nerve take place mean these superior and inferior middle constrictor that constrict simultaneously won't create any problem. But inferior constrictor, if you looking, inferior constrictor is combination of two. One is thyropharyngeus, another one is cricopharyngeus. Both are different nerve supply. So neuromuscular incoordination common in this area. So in case which is considered as a weakest area, the space in between thyropharyngeus and cricopharyngeus because different nerve supply, this is considered as weakest area. This is considered as what? Weakest area. So in case of any diverticulum developed mean there only diverticulum developed. Okay. So the weak area, what is the name for A? Is there any name for this weak area? This is thyropharyngeus, this is cricopharyngeus, both are inferior. Both are collectively inferior constrictor. So the weak area in between. So this is thyropharyngeus. This is cricopharyngeus. Which is supplied by thyropharyngeus is supplied by vago accessory complex. Cricopharyngeus is supplied by recurrent laryngeal nerve. In between there is a weak area that is known as Killian dehiscence. So in case any diverticulum developed in that area mean the diverticulum is known as Jenker's diverticulum. Then let us move on to the larynx. So here larynx, these are the cartilages. Epiglottis is an example for elastic cartilage. Then from the anterior side we can see thyroid cartilage, cricoid cartilage. Thyroid and cricoid cartilage both are example for hyaline cartilage. It can ossify, but elastic cartilage never ossify. Okay. So here inner view. So this is thyroid cartilage. Here cricoid cartilage we able to see. So here what are the paired cartilages? What are the unpaired cartilages? So paired cartilages are totally 3. So what are the cartilages are paired? Here thyroid cartilage we able to see. Below to the thyroid cartilage, cricoid cartilage. Another one is epiglottis. These 3 single in number, so unpaired cartilage. Then smaller cartilage, arytenoid, corniculate, cuneiform. So these are what cartilages? Paired cartilages. So paired 6 in number plus 3. Totally 9 cartilages are there. Out of that, epiglottis is elastic. Thyroid and cricoid is hyaline in nature. Then over this cricoid cartilage, this base of arytenoid in contact. So that is also hyaline. Other parts are elastic. So conclusively, thyroid is hyaline. Cricoid is hyaline. Base of arytenoid is hyaline. Other than that, everything epiglottis, apex of arytenoid, corniculate, cuneiform, everything is elastic in nature. Then now we are going to put one sagittal section. If we take one sagittal section, inside we able to see 2 membrane. See here, this is sagittal section. So here epiglottis. So epiglottis, if we trace, it will reach inner aspect of thyroid. So this is thyroid cartilage. Inner aspect of thyroid, epiglottis. So this is anterior side, this is posterior side. Okay. So inner aspect we able to see 2 membranes. See here one membrane is quadrate membrane. Here one membrane, one more membrane, which is known as cricovocal membrane. There are 2 membrane. So this is quadrate membrane which is extending from epiglottis to what is this cartilage? Arytenoid cartilage. From inner aspect of thyroid to arytenoid, one more cartilage, cricovocal. Just remember inner aspect quadrate membrane, cricovocal membrane. So here quadrate membrane lower border is known as vestibular fold. Cricovocal membrane upper border is known as vocal fold. So cricovocal membrane upper border, free border is known as vocal fold. This lower border is known as vestibular fold. Now if you draw one diagram here, see inside there are 2 membrane. This is upper membrane, quadrate membrane, lower membrane. That membrane is known as cricovocal membrane. So this is cricovocal membrane. This is quadrate membrane. Quadrate membrane lower fold is thickened. That is vestibular fold. Cricovocal membrane upper fold thickened. This is vocal fold. This is lined by mucosa. But in between there is a defect. So through the defect, mucosa is going out. So it is present like this. So interior of larynx, if you are looking here, mucosa protrude. So this is known as sinus of larynx. So this is one vestibular fold. Okay, there is a gap. Okay, so here vocal fold, there is a gap. So this gap is known as rima glottidis. So now here mucosa lining the epithelium. What epithelium lining that? All over the larynx, respiratory epithelium, ciliated columnar epithelium. Okay, except vocal cord, that is vibrating. So protect epithelium, stratified squamous epithelium. Then anterior surface of epiglottis, because anterior surface of epiglottis, which is facing oral cavity should be lined by protective epithelium. So epiglottis also should be lined by protective epithelium, stratified squamous epithelium. Okay, so here now only we have discussed vocal cord, which is extending from here. This is vocal cord, which is extending from this thyroid to this arytenoid cartilage. Now see, muscles we can differentiate. One is tensor of vocal cord, another one is relaxor of vocal cord. For example, just imagine here arytenoid cartilage is there, arytenoid cartilage. Here thyroid cartilage is there. From here to there, what is extending? Vocal cord is extending. Now below cricoid cartilage is there. One muscle which is extending from cricoid to thyroid. So this is thyroid cartilage, this is arytenoid cartilage, this is cricoid cartilage. From cricoid to thyroid, any muscle extending mean that is cricothyroid. If this muscle contract mean thyroid will move forward. If thyroid moving forward mean this will be stretched. This will be stretched. So this cricothyroid muscle is known as tensor of vocal cord. So please remember which is known as tensor of vocal cord. Tensor of vocal cord is cricothyroid. Cricothyroid. Then all the muscles of larynx is supplied by recurrent laryngeal nerve. Now supply wise, all the things are supplied by which nerve? Recurrent laryngeal nerve, except only one cricothyroid, that is tensor of vocal cord. To raise the pitch of voice, tensor of vocal cord, which is supplied by external laryngeal nerve. External laryngeal nerve. Please remember. Okay. Then relaxor of vocal cord. The same thing. Here this is the level of arytenoid, this is the level of thyroid. Here vocal cord is extending. If any muscle, one muscle also extending mean what name we can give? This is thyroid, this is arytenoid. If this muscle extending mean, can I give thyroarytenoid? Yes, thyroarytenoid. If this muscle contract mean both cartilage. So here vocal cord extending from this is thyroid to arytenoid. One muscle also extending thyroarytenoid. Okay, so if that muscle contract mean both are coming close to each other. If both are coming close to each other, mean vocal cord will relax. So thyroarytenoid muscle is relaxor of vocal cord. Cricothyroid muscle is tensor of vocal cord. Tensor of vocal cord. So cricothyroid, tensor vocal cord, only muscle which is supplied by external laryngeal nerve. So here this is thyroid cartilage, here arytenoid cartilage. This muscle is known as thyroarytenoid muscle. Okay, thyroarytenoid muscle. So thyroarytenoid muscle, this is relaxor of vocal cord. Then inlet of all inlet. So here this is the inlet. This is the inlet. So here what is this? Cricoid cartilage. Okay, so here this is cricoid cartilage. This is epiglottis. If epiglottis falling back mean closing. If epiglottis moving forward mean if epiglottis here this thing here thyroid is there. Okay, so this is the inlet. If any muscle which is extending from arytenoid to epiglottis, it will pull the epiglottis back. Okay, if one muscle which is extending from arytenoid to if any muscle which is extending, this is arytenoid to thyroid. If any muscle extending mean it will pull the this thing epiglottis back. Okay, so arytenoid to epiglottis. So aryepiglotticus is closing of inlet. Then opposite to this, from thyroid to epiglottis, if any muscle extending mean it will pull the epiglottis forward, opening. So thyroepiglotticus is opening, aryepiglotticus is closing. Aryepiglotticus is closing. Okay, so this thing we have to remember. Then one more thing, which is the safety muscle of larynx. So for the respiration, vocal cord should deviate from each other, abduction. So that is done by posterior cricoarytenoid. So posterior cricoarytenoid is known as safety muscle of larynx. Safety muscle of larynx. So it is usually confusion will come. Easily we can remember. Posterior cricoarytenoid, lateral cricoarytenoid. Okay, lateral cricoarytenoid. So here please remember like this. Here lateral cricoarytenoid, L for love. L for love. Okay, so if any person fell, if they fall in love mean they will forget to sleep, they will forget everything. Okay, love. So in case of any fight or something mean that they can't do anything. So love will choke, like that you remember. Love will choke. Okay, so choke mean unable to respiration. So lateral cricoarytenoid, L for love. Love, is it facilitating or choking? Facilitating respiration or choking? So it is choking. So here Choking mean adductor focal cord. Adductor focal cord. So lateral cricoretinoid, adductor focal cord. Then opposite, one more thing, posterior cricoretinoid, safety muscle of lacquer cord. So safety muscle. So safety muscle is supplied by recurrent laryngeal nerve. Again, formula, all the muscles of larynx is supplied by recurrent laryngeal nerve. Only one exception, that is tensor focal cord or cricothyroid, which is supplied by external laryngeal nerve. So we have to remember this. Okay. Then finally, here some of the sinuses. Here we can see the frontal sinus. Here we can see the maxillary sinus, sphenoidal sinus, then ethmoidal sinus, which is divided into anterior group, middle group, posterior group. Like that it is divided. How, where and all sinuses are open. So this is inferior meatus. So here there are the concha, inferior concha, middle concha, superior concha. This inferior concha, which is receiving nasolacrimal duct. Here what is opening? Nasolacrimal duct. Nasolacrimal duct opens into inferior concha, middle concha, maxillary sinus open, frontal sinus open. Then here, superior concha, please remember only one thing, posterior ethmoidal sinus. Ethmoidal sinus 3 in number, posterior is opens into superior concha. Other two, that opens into middle, maxillary, frontal, anterior ethmoidal, middle ethmoidal opens into this area. So frontal. So here everything given. So again here nasolacrimal duct in inferior, maxillary, frontal, anterior and middle ethmoidal opens into middle. Then posterior, that is in superior. Then here, so the sphenoethmoidal recess, uppermost sphenoidal air sinus. So here all the things are maxillary sinus, that is first to develop. Then here artery of epistaxis, sphenopalatine artery is known as artery of epistaxis. So little's area. So in the anterior aspect of septum, nasal septum, there is a rich arterial anastomosis. Out of that, which is known as artery of epistaxis, sphenopalatine artery. Okay. So temporomandibular joint. So here this is mandible. This is mandible articulating with the temporal. Inside there is one articular disc. Okay, this articular disc is a remnant of lateral pterygoid muscle. That point we have to remember. It is a remnant of lateral pterygoid muscle. Okay. Then here the muscles of mastication, temporalis masseter. What are the muscles? Temporalis, another one is masseter, lateral pterygoid, medial pterygoid. So these are the muscle. All the muscles are supplied by mandibular nerve. So here only one muscle that is used for opening the mouth, that is known as lateral pterygoid. See, according to muscle fiber direction, we can tell the action. See, temporalis muscle fiber running downward and forward. If this is contracting, mean mandible will move up because muscle is coming down. So mandible will move up. If muscle fiber is coming forward, so it will also cause retraction of temporomandibular joint. So by using muscle fiber, don't mug up, by using muscle fiber direction, we can remember. So temporalis muscle, which is running, temporalis, which is running, first it is running down. So opposite action, elevation, which is running forward. So opposite action, retraction of mandible. Okay. Masseter, which is running down as well as backward. So if it is contracting, mean mandible will move up, also forward. Okay. So in this way, if we think here, finally, conclusively, what will come? Temporalis muscle. Almost all the muscle causing elevation. See, temporalis will cause elevation, masseter will cause elevation, lateral pterygoid will cause elevation. Sorry, medial pterygoid will cause elevation. Except lateral pterygoid, this is causing protraction. Protraction causing muscle is lateral pterygoid. Mouth opening causing muscle is lateral pterygoid. Only retractor of temporomandibular joint is temporalis muscle. So like that it will come. Then finally parotid duct. What are the structures seen within the parotid duct? Totally 3 structures seen in the parotid duct. One is facial nerve. The first one, this is facial nerve seen. Outermost structure is facial nerve. Then retromandibular vein. Then deep to that external carotid artery. So outside to inside, the order is facial nerve, retromandibular vein. Another one is external carotid artery. Then parotid duct, which is piercing. Here parotid duct is coming. This parotid duct, which is going to pierce buccinator muscle, which is going to pierce. See here, From the anterior aspect of parotid gland, parotid duct is coming, which is going to pierce buccinator and opens into upper second molar tooth. Upper second molar tooth. Then one more thing here, by the side of mandible, we can see the masseter muscle. We can see the masseter muscle. This muscle is masseter. From antero-inferior angle of masseter, facial artery seen. So antero-inferior angle. Which border of masseter we can feel facial artery? Facial artery feel antero-inferior angle of masseter. Okay. Then scalp, which is composed of 5 layer. Out of 5 layer, the 4th layer of scalp is known as dangerous area. 4th layer. Here see, 4th layer is, what is this? Skin, some connective tissue layer, aponeurosis, gallia aponeurotica, loose areolar tissue. So this loose areolar tissue, this layer very loosely arranged. So pus collection and all easily here it is collected. Then some of the emissary vein from scalp to inner aspect of sinuses, some of the veins are going. So along this emissary vein, this pus can drag down and enter into sinuses, can cause thrombosis. Okay, so this loose areolar tissue of 4th layer of scalp is known as dangerous layer of scalp. Dangerous layer of scalp. Okay, then here from the dangerous area face also. So which is dangerous area of scalp? Dangerous area of scalp is 4th layer. Why? Because from outside it can cause sinus thrombosis. Infection can spread. 4th layer. Okay. Then here dangerous areas. Here upper lip, this nose, root of nose, collectively known as dangerous layer of face also. Why this is known as dangerous area of face? Because from this area, I mean, infection can spread. For example, here nose and upper lip area. From here, this is cavernous sinus. Here, facial vein is coming. Facial vein is coming. So facial vein here, it is communicating with superior ophthalmic vein. For example, here this area only known as dangerous area. In case of any infection, it can ascend up through facial vein. It is reaching cavernous sinus through superior ophthalmic vein. Also, it is reaching through pterygoid plexus of vein. There are two routes here. Middle pterygoid, lateral pterygoid contain pterygoid plexus. So here facial vein in communication with pterygoid plexus, then through the emissary vein, it can reach the cavernous sinus. Or infection can ascend up through the superior ophthalmic vein, it can reach cavernous sinus. So finally, it will leads to cavernous sinus thrombosis. Two route of spread, superior, another one is pterygoid, superior ophthalmic vein, another one is pterygoid venous plexus. Then all the facial muscles are supplied by facial nerve. Then some of the maxillary artery, here first part giving two important named arteries. Sphenopalatine artery is a branch of 3rd part. That is very important. Sphenopalatine artery is a branch of 3rd part of maxillary artery. Like that, middle meningeal artery, accessory meningeal artery, both are branches of first part. Both are branches of first part. So it is giving many named branches. Out of that, here first branch giving accessory meningeal artery, another one is middle meningeal artery. Sphenopalatine artery is a branch of 3rd part of maxillary artery. Then maxillary nerve also seen in infratemporal fossa. Maxillary nerve going to continuous as infraorbital nerve. Going to continuous as infraorbital nerve. So infraorbital nerve is a continuation of maxillary nerve. Okay. So all the muscles of mastication which is applied by this thing. All the muscles of mastication is applied by mandibular nerve. Okay. So here some of the sinuses. Okay. So the following sinuses here: superior sagittal sinus, inferior sagittal sinus. There are two sinuses present antero-posteriorly. This inferior sagittal sinus, which is receiving vein of Galen, which is formed by two internal cerebral vein. Two internal cerebral vein join together vein of Galen. This vein of Galen and inferior sagittal sinus join together and form straight sinus. So now straight sinus and superior sagittal sinus joining at confluence of sinuses. This is known as confluence. Here it is divided into two transverse sinus. Here it is divided into transverse sinus, right and left transverse sinus. Here only one side we are going to trace transverse sinus. This transverse sinus going to continue as sigmoid sinus. Sigmoid sinus through the jugular foramen, it is going to continue out as internal jugular vein. Internal jugular vein. So here this is transverse sinus, this is sigmoid sinus, this is internal jugular vein. Here vein of Galen, here vein of Galen. This one is vein of Galen. This is superior sagittal sinus. This is inferior sagittal sinus. This is straight sinus. This is straight sinus. So inferior sagittal sinus joined with Galen, vein of Galen, okay, Galen, and inferior sagittal, straight sinus, superior sagittal. Here it is divided into two transverse sinus continuous with sigmoid sinus going out as internal jugular vein. The same thing. See here, inferior sagittal joined with Galen, straight sinus, superior sagittal, transverse sinus, sigmoid sinus. Another one is this. Now cavernous sinus. Here we are going to put cavernous sinus. So here if you draw cavernous sinus here, cavernous sinus which is connected with transverse sinus, also connected with internal jugular vein through two thing. Here can you able to see inferior petrosal sinus. Another one is known as superior petrosal sinus. What is superior petrosal sinus? Here this is cavernous sinus and transverse sinus connected by transverse. This is cavernous sinus to the transverse sinus. There is a connection, superior petrosal. Cavernous sinus. Another one is internal jugular vein. There is a connection, inferior petrosal sinus. Inferior petrosal sinus. See here it is in this way. It is working. So this is superior ophthalmic vein, inferior ophthalmic vein. So here from the orbit region, blood reaching cavernous sinus, from the cavernous sinus everything reaching internal jugular vein, and everything reaching internal jugular vein. So dangerous area phase, how infection is spreading to cavernous sinus, just now we have finished. Then what are the structure passing through cavernous sinus? What are structure passing through lateral wall of cavernous sinus? So through the cavernous sinus, two structures are passing. One is carotid artery, internal carotid artery. Another one is abducen nerve. Another one is sixth cranial nerve. Sixth cranial nerve, internal carotid artery. Both are passing through that lateral wall. It will transmit few structure. Lateral structure is cranial nerve 3, 4, and carry oculomotor nerve, trochlear nerve, ophthalmic nerve. Okay, now recent grace they have removed maxillary. They have removed maxillary. So abducent is passing through that. Abducent is passing through that. Okay. Then extraocular muscle, all the muscles that is supplied by SO4-LR6. I hope all of you know the formula SO4, except superior oblique is supplied by fourth nerve. LR6 is supplied by everything. All the others are supplied by oculomotor nerve. Then here some of the important middle ear relation. Middle ear, here this is the middle ear which contain malleus, incus, another one is stapes. Malleus and incus in between joint, sometimes it is important, this joint is saddle type of joint. The joint is saddle type of joint. So here this is stapes, this is incus. Okay, so in between joint is known as ball and socket type of joint. Okay, lateral wall contain tympanic membrane. Then if we open the lateral wall, so here tympanic membrane is removed. So this side anterior boundary, some important structure seen on walls only we are going to appreciate. Anterior wall. What are the things in auditory opening scene? Auditory opening scene in which wall of middle ear? Anterior wall of middle ear. Anterior wall also related to internal carotid artery. Okay. Then floor related to internal jugular vein. Floor. So this is a space. Tympanic membrane that is removed. Floor is related to internal jugular vein. Anterior wall which is related to auditory tube. Also it is related to this thing, internal carotid artery. Then posterior wall, if you looking mean, posterior wall is related to facial nerve. Medial wall also related to facial nerve. So facial nerve related to two wall. One is lateral wall, one is medial wall. Another one is posterior wall. Facial nerve scene. Medial wall, facial nerve scene. Then medial wall, one elevation scene that is caused by basal tone of cochlea, that is promontory, over which tympanic plexus is seen. So facial nerve seen on medial wall first, then posterior wall. Anteriorly internal carotid artery, floor is related to internal jugular vein, anteriorly auditory tube opening also seen. Let us enter into neuroanatomy. Can we continue now? Are you there? Can we continue? Yeah. Thank you. 1 minute break. Okay, so we can discuss about neuroanatomy. Neuroanatomy, spinal cord. Spinal cord, from where to where it is extending. Spinal cord which is extending from C1 vertebra to L1 vertebra. C1 vertebra. Foramen, it is not extending from foramen magnum. From C1 to L1 vertebra, it is extending. Okay. Then if spinal cord, if it is extending only to L1 level, it is extending up to L1 level. Okay. Then from this L1 level, it is a tapering end. It is known as conus medullaris. From the conus medullaris, there is a phylum terminale which is extending up to coccyx vertebra. Here there is a question. Phylum terminale is a modification of pia mater. Phylum terminale is a modification of what? Pia mater. So here spinal cord end at L1 level. From the L1 level, phylum terminale, it is a modification of pia mater which is extending up to where? Coccyx vertebra. Then here outside some of the meninges, arachnoid matter, dura matter, then subarachnoid space, everything extending up to S2 vertebra. So these are the three levels are important. Phylum terminal is a modification of pia mater. Okay, so from where to where it is extending? From conus medullaris to coccyx vertebra it is extending. Then other than that, arachnoid matter, dura matter, everything extending up to S2 vertebra. So deep to arachnoid, here subarachnoid space which is also extending up to S2. So spinal cord only extending up to L1, but there are meninges extending up to S2 vertebra. So subarachnoid space also extending up to S2 vertebra. So here spinal cord end at L1 level. So L3, L4 space is safest space for lumbar puncture. Safest for lumbar puncture. So one more thing. So phylum terminal is a modification of pia mater. Just now we came to know. So like that, on both side of spinal cord, ligamentum denticulatum is there. So this is denticulate ligament. So that is also a modification of pia mater. So I hope Brown-Sequard syndrome and all in physiology you discussed. So I am skipping this. So here blood supply, spinal cord which is extending from cervical vertebra to lumbar vertebra. So it is supplied by many segmental artery, but mostly it is also supplied by branches of the vertebral artery. Here see anterior spinal artery, then one posterior spinal artery, anterior spinal artery, posterior spinal artery. Okay, both are branches of vertebral artery. Then when it is descending down, it is supplied by cervical artery. Okay, posterior intercostal artery, lumbar artery. Okay, so it is supplied by many branches, but out of that the very important two are anterior spinal artery, posterior spinal artery, both are branches of vertebral artery. Both are branches of vertebral artery. Then one of the largest branch is known as artery of Adam-Kiewicz. Artery of Adam-Kiewicz. Okay, so that is considered. Here, see here, artery of Adam-Kiewicz. So it is one of the major branches of the this segmental artery. I mean, either thoracic artery or lumbar artery can give one larger trunk to the spinal cord, that is known as artery of Adam-Kiewicz. Then let us move on to the brainstem. Brainstem here, which is divided into here three part. This is midbrain, this is pons, this is medulla. Here this is ventral aspect, this is dorsal aspect, cerebellum we able to see. Here fourth ventricle. Okay, so here this is corpus callosum. Here fornix we able to see. So first brainstem we can discuss. This area is interpendular fossa. So here if we take the section out, here this part is pons. Above to that, this is midbrain. In midbrain, this is known as crus cerebri. This part is known as what? Crus cerebri. This part is known as crus cerebri. So here we can see the interpendular fossa. We can see the interpendular fossa. Here this is actually belong to, this part is known as crus cerebri. This is belong to midbrain only, crus cerebri. So here this is interpendular fossa. Interpendular fossa, medial to crus cerebri, one nerve is coming out, that is oculomotor nerve. This nerve is oculomotor nerve. This nerve is trochlear nerve. This nerve is trochlear nerve. Lateral to crus cerebri, trochlear nerve. Medial to crus cerebri, oculomotor nerve. This is interpendular fossa. So interpendular fossa content is oculomotor nerve. Interpendular fossa boundary and content we are going to discuss, but crus cerebri medial to that oculomotor nerve. So oculomotor nerve is a content of interpendular fossa. Trochlear nerve outside the interpendular fossa are lateral to crus cerebri. Then from the pons ventral aspect, the trigeminal nerve is coming. Here this is medulla. Medulla which contain, here this is the midline. On both side of midline, here on elevation, this elevation is known as pyramid. This elevation is known as, this is the midline, on both side pyramid. Then lateral to pyramid, there is one more elevation that is known as olive. So this elevation is known as olive. This elevation is known as pyramid. Okay, so here this is pyramid. This is pyramid. This is olive. This pyramid is caused by corticospinal tract. Olive, which is produced by inferior olivary nucleus. So is it caused by corticospinal tract? Yes. Is it caused by inferior olivary nucleus? Yes. This is olive. This is pyramid. In between pyramid and olive, one cranial nerve is emerging out. That cranial nerve is known as hypoglossal nerve. So 12th cranial nerve emerging out in between olive and pyramid. Hypoglossal nerve is emerging out. Then immediately lateral to this olive, there are other cranial nerves are emerging out. This is 9, 10, 11 cranial nerve. Okay, this is glossopharyngeal nerve, this is vagus, this is accessory nerve. So these are the three cranial nerve emerging out lateral to olive or posterior to olive. These three cranial nerve originating from one common source. So that is known as nucleus ambiguous. So nucleus ambiguous giving origin to three cranial nerve 9, 10, 11. Okay, so here in between pyramid and olive, the cranial nerve is known as 12th cranial nerve. These three cranial nerve, that is 9, 10, 11 cranial nerve. Then here this is 5th cranial nerve. Interpendular fossa contain 3rd cranial nerve. Outer side 4th cranial nerve or trochlear nerve. So here pontomedullary junction, here we can see the pontomedullary junction. At the pontomedullary junction from medial to lateral side, 6th cranial nerve, abduction nerve. 7th cranial nerve, facial nerve, vestibulocochlear nerve. So these are the cranial nerve and its location. Here all the cranial nerve emerging out from the ventral aspect only. But if we turn the brainstem dorsally, we can see one cranial nerve. So which is the only cranial nerve emerging out on the dorsum aspect of brainstem. From the dorsum of brainstem, only one cranial nerve emerging out, that is trochlear nerve. So trochlear nerve is considered as the longest cranial nerve because dorsally it is coming out, then all the way it is reaching the eyeball. So longest intracranial. Okay, so that is this one. Next to vagus, so this one, longest intracranial course, which is undergoing trochlear nerve, fourth cranial nerve, which is the only nerve emerging out dorsally. That is also this one. Then this is the thinnest cranial nerve. This is the thinnest cranial nerve. Okay. Then interpedunclar fossa. We are magnifying this area, interpedunclar fossa. The boundaries and all we are going to discuss. Interpedunclar fossa anteriorly bounded by optic chiasma. Anterolaterally, this is optic tract. Optic tract. Then this is crus cerebri. These are the content. Content are, one is oculomotor nerve. Okay, oculomotor nerve is a content. Then these two elevations are known as mammillary body is a content. Then these are infundibulum, tubercinarium, infundibulum. So it is related to that hypothalamo-pituitary axis. So infundibulum, another one is tubercinarium. Then mammillary body, here posterior perforating substance, here oculomotor nerve, here oculomotor nerve. So these are the structures present in interpedunclar fossa. Interpedunclar fossa contain one cranial nerve, oculomotor nerve. Here, please remember, these are the above mentioned structure, this optic chiasma, tubercinarium, infundibulum, mammillary body, posterior perforating substance. If we, by using knife, if we cut this area, directly our knife will enter into third ventricle. The meaning is, directly if we cutting this, our knife enter into third ventricle, mean these are the structure forming floor. What are the structures forming floor? Interpedunclar fossa and the structures forming floor of third ventricle. Answer is same. Okay, so here the floor of third ventricle is formed by optic chiasma, tubercinarium, infundibulum, mammillary body, posterior perforating substance. But oculomotor nerve, that is not present in midline. Okay, because two structure, so it is parallel to midline. Okay, so it is not forming floor. So interpedunclar fossa content we know, except oculomotor nerve, all the other interpedunclar fossa content forming floor of the third ventricle. Okay, so next this is trochlear nerve we know. This is superior colliculi, inferior colliculi. Okay, so the both are collectively known as corpora quadrigemina. Then this area is known as rhomboid fossa. Rhomboid fossa, rhomboid fossa which contain one elevation. Okay, so that elevation is known as rhomboid fossa, which contain one elevation. That elevation is known as median eminence. See, median eminence is an elevation. So median eminence contain one prominence, that is known as facial colliculus. In the median eminence, there is an elevation that is known as facial colliculus. Okay, facial colliculus. Deep to this, what nuclei is present? Facial colliculus not contain facial nuclei. Facial colliculi contain abducens nerve nuclei. So facial colliculi which contain abducens nerve nuclei. Okay, so here see, this is facial colliculus. Deep to facial colliculi, abducens nerve nuclei. Abducens nerve is coming out here, but abducens nerve nuclei is present, which is winds around by facial nerve. Facial nerve. Deep to this facial colliculi mean deep to this facial nerve present, but facial nuclei not there. What nuclei is seen? Abducens nuclei is seen. So deep to facial colliculus, what nuclei? Question is like that, abducens nuclei. What nerve is seen? Facial nerve is seen. That is facial colliculus. Okay. Then below to that, this triangle is known as hypoglossal triangle. Hypoglossal nuclei present. Here vagal triangle, dorsal nucleus of vagus is there. So in this fossa is rhomboid fossa, dorsal aspect. Here superior colliculi, inferior colliculi, in between superior colliculi, pineal gland is there. Here trochlear nerve is emerging out. Okay, these are the cerebellar peduncle. So here this is rhomboid fossa, median eminence, facial colliculus we able to see, hypoglossal triangle seen. Here vagal triangle seen, hypoglossal nuclei, vagal nuclei seen. Here abducens nuclei, facial colliculus contain abducens nuclei. Lateral area, vestibular area. Lateral area, vestibular area. So these are the structure seen here. Next, fourth ventricle. So rhomboid fossa, that is forming fourth ventricle. Then some of the brainstem syndrome. For example, here this is the cross section of the midbrain. Cross section of the midbrain at the superior colliculus level. Superior colliculus level. If we take section, we can see the red nucleus. We can see the red nucleus. See here, this is superior colliculi, nuclei of superior colliculus. Red nucleus seen at which part of the brainstem? Midbrain. At what level? Superior colliculus. So superior colliculus level, one nerve is emerging out, that is known as oculomotor nerve. Oculomotor nerve. This is crus cerebri, which is transmitting many fiber. Out of that, very important one is corticospinal tract. Then here, this is substantia nigra. This is substantia nigra. These are ascending tract. I mean, some of the lemniscus. So medial lemniscus, trigeminal lemniscus, spinal lemniscus. So lemniscus are continuity of spinal cord tract. So one by one we will discuss. So here some of the syndromes we are going to discuss. some Benedict syndrome. So what are the structures? Make it simple. So Benedict syndrome, what are the structures involved? So if we know that, we can answer that very easily. So what are the structures involved? Here, oculomotor nerve is involved. See, Benedict syndrome, this is the area involved. So 3 lemniscus involved. Spinal lemniscus is involved, medial lemniscus is involved, trigeminal lemniscus is involved. I hope you're aware of that. Medial lemniscus is a continuity of dorsal column. Medial lemniscus is a continuity of dorsal column. Spinal lemniscus is a continuity of corticospinal tract. Corticospinal tract. So it will carry what? Pain and temperature. Medial lemniscus carrying what? It is carrying some fine touch, pressure, vibration, stereognosis. Then trigeminal lemniscus carrying sensation from face. Lemniscus mean that is a crossed tract. Okay, lemniscus after crossing to opposite side only we will use lemniscus. So in case for example, if this is right side lemniscus injury, mean left side lesion will be seen because this is a crossed tract. Okay, so red nucleus, oculomotor nerve. So these are the structure only involved in Benedict syndrome. So make it simple. Medial lemniscus gone. So what will happen? Medial lemniscus gone mean lemniscus, so crossed. So contralateral loss of touch, pressure, vibration, stereognosis. Trilemniscus gone. Trigeminal lemniscus, contralateral loss of sensation from face. Spinal lemniscus, contralateral loss of pain and temperature because it is a continuous spinocerebellar tract. Then red nucleus, which is going to give rubrospinal tract, extrapyramidal tract, rubrospinal. So that is very, very important for fine movement. So for red nucleus gone mean tremor. Then oculomotor nerve gone. Oculomotor nerve, it will leads to this much of problem. We can give the explanation. Extraocular muscle, because Benedict syndrome, 3 lemniscus mainly involved, red nucleus involved, oculomotor nerve involved. So oculomotor nerve, which is going to supply all the muscle except, so oculomotor nerve gain almost all the muscle gone except 2, SO4 LR6. So superior oblique, okay, it won't be paralyzed. Lateral rectus won't be paralyzed. Now lateral rectus is present. So what will happen? Lateral rectus, it will pull the eyeball laterally. What is the action of superior oblique? Superior oblique pull the eyeball down. So down and out, very easy. So only superior oblique is there, it will pull the eye down. Lateral rectus is there, it will pull the eye laterally. So down and out eye is one of the characteristic feature. Also, this oculomotor nerve, which is going to supply levator, upper eyelid, levator palpebrae superioris, that is also supplied by oculomotor nerve. So that is gone mean ptosis, second characteristic feature. Then this oculomotor nerve also carrying some of the parasympathetic fiber from the Ediger vestibule nucleus, which is going to supply the sphincter pupillae, So here sphincter pupillae gone because oculomotor nerve gone mean those Ediger vestibule nuclei fiber also gone, sphincter pupillae. So it is very simple. Levator scapulae, last it now supply ptosis. Then second thing, all the other muscle paralyzed except superior oblique, lateral rectus, so down and out eye. Then another one is sphincter pupillae gone, so that will leads to dilated pupil, fixed pupil. Okay, so these are the characteristic feature. So if this area is involved mean Benedict syndrome. Just to remember the structure. Medial lemniscus is involved. Medial lemniscus is dorsal column. Spinal lemniscus involved, that is spinocerebellar tract. Corticospinal tract. Another one is trigeminal lemniscus. So sensation from face gone. Contralateral pain temperature is gone. Contralateral some fine touch, pressure, vibration, stereognosis gone. Red nucleus involvement because of that tremor. Then oculomotor nerve palsy, we gave the explanation. Now second thing, Weber syndrome. So Weber syndrome in this area is involved. What are the structures involved? Anterior. So Weber syndrome, oculomotor nerve is involved, corticospinal tract is involved. Another one is substantia nigra. Substantia nigra very, very important for dopamine secretion. So substantia nigra gone mean Parkinsonism. Corticospinal tract gone mean contralateral hemiplegia. Oculomotor nerve gone mean now only we have discussed down and out eye, toes is seen. Another one is this thing, dilated and fixed people. So these are the Weber syndrome. Then pons, if we moving here, pons, if we putting section, what are the nerves are emerging out? Abducens nerve, facial nerve mainly emerging out, then corticospinal tract also descending down. So by using this, because pons, it is mostly, it is here, there is no role for oculomotor nerve or trochlear nerve. Pons mainly abducens nerve, facial nerve, pontomedullary junction. So here abducens nuclei is seen, here facial colliculus. So abducens nerve is coming out, facial nerve is coming out, here corticospinal tract descending down vertically, because corticospinal tract from the brain through the brainstem only it is descending down. So these three involvement, facial nerve, abducens nerve, corticospinal tract. Is there any syndrome? Yes, Millet-Gubler syndrome. Millet-Gubler syndrome, abducens nerve is gone. What will happen? It is very easy. Abducens, SO4 LR6, lateral rectus gone. Lateral rectus gone mean medial rectus will become prominent. So medial squint. So here see, eyeball, see, eyeball. This is normal eyeball. This is medially deviated eyeball. Lateral rectus is gone. So this is one of the picture for what on Millet-Gubler syndrome. Then facial nerve is gone. Facial nerve gone mean facial palsy. Facial nerve, ipsilateral facial palsy. Then here corticospinal tract mean gone. So contralateral hemiplegia. So these are the structure. These are the things related to Millet-Gubler syndrome. Then now we know here medial midline close to that elevation is known as what? Pyramid, lateral to that olive. So pyramid contain corticospinal tract, olive contain inferior olivary nucleus, in between hypoglossal nerve is coming out. So if we take the section also very close to midline pyramid, then olive, in between pyramid and olive, hypoglossal nerve. So the same picture will come. So see, if you take section pyramid which contain corticospinal tract, laterally olive which contain inferior olivary nucleus, in between hypoglossal nerve is coming, lateral to olive 9, 10, 11 curve is coming. This is medial lemniscus. So if this area is involved in medial medullary syndrome, what are the structures are gone? Hypoglossal nerve is gone. Here medial lemniscus is gone. Here corticospinal tract. If corticospinal tract gone mean what will happen? Contralateral hemiplegia. Medial lemniscus gone mean contralateral 5 sensory laws. What are the 5 sensory laws? Fine touch, pressure, vibration, stereognosis. Then hypoglossal nerve gone mean that is ipsilateral hypoglossal palsy. That's it. Medial medullary syndrome. Lateral medullary syndrome, these are the areas are involved. What are the areas are involved? Here mainly this thing, glossopharyngeal nerve, vagus nerve is gone. So gag reflex will be lost. Then here some cerebellar tract is involved. So some ataxia or gait difficulty will be there. So these are the things are characteristic features of lateral medullary syndrome. Lateral medullary syndrome. Lateral medullary syndrome. Here only hypoglossal, this thing, sympathetic tract also coming. So that will leads to Horner syndrome also. Horner syndrome. Nucleus ambiguous, which is common for 9, 10, 11. That is very, very important. Let us move on to cerebellum. Cerebellum here it is located posterior to brainstem. So brainstem, cerebellum is located here. So here this is mainly divided into, here see, here cerebellum is divided into 3 lobes. One is anterior lobe, another one is posterior lobe, another one is flocculonodular lobe. Anterior lobe, posterior lobe, flocculonodular lobe. Okay. So flocculonodular lobe, that is most oldest one. Posterior lobe, newest one. Anterior lobe, that is the middle one. So here this flocculonodular lobe. So here see this, that is the oldest flocculonodular lobe. Okay. The main function of the function wise we are correlating. The main function of flocculonodular, the small thing flocculonodular is axial balance. The main function is axial balance. Then main function of anterior lobe, this is anterior lobe, that is controlling crude movement. Then this is mainly controlling fine movement. This is mainly controlling fine movement. So overall, if we summarizing mean, this is going to perform axial balance. This is going to control crude movement. This is going to control smooth, highly skilled movement. So like this we can differentiate. So here this flocculonodular lobe, mainly axial balance. So flocculonodular lobe, in case of any lesion, here see, this is flocculonodular lobe syndrome. So it is mainly controlling axial balance. Okay. So flocculonodular lobe lesion mean what will the patient, they will try to balance themselves. So for that they will walk with wide base gait. So if patient walk with wide base gait, which lobe is involved? Because they are trying to maintain their axial balance, wide base gait. So what is this? Flocculonodular lobe. Then here the second thing, anterior lobe, that is going to control this thing. Mainly it will present as gait ataxia. It will present as gait ataxia. Then one more thing, posterior lobe lesion. Here flocculonodular lobe, that is present as wide base gait. It is present as gait ataxia. This is mainly controlling skilled movement. So it will leads to intention tremor. So these are the 3 characteristic feature. Then the nuclei are dentate nuclei. So here see the nuclei, dentate nuclei, emboliform nuclei, dentate nuclei, fastigial nuclei, emboliform nuclei. This fastigial nuclei that belong to flocculonodular lobe. Dentate nuclei belong to posterior lobe. This is belong to anterior lobe. Then here this one here, the the main cells are Purkinje cells. Cerebellum mainly contain Purkinje cell. That is a flask-shaped cell. That is a flask-shaped cell arranged in a single row. Arranged in a single row. Then let us move on to cerebrum. Cerebrum, the very important one is superior lateral surface. The main blood supply is provided by superior lateral surface. The main blood supply is provided by middle cerebral artery. Okay, so brain, which is composed of three surfaces. Okay, lateral surface, medial surface, inferior surface. Lateral surface is mainly supplied by middle cerebral artery. Middle cerebral artery. Okay, so here only most of the important areas. So this is motor area, sensory area. So most of the areas are located here only. Okay, except medial side is mainly supplied by anterior cerebral artery. Anterior cerebral artery here, for example, here all the face, upper trunk, head and neck, trunk, upper limb, all the areas located here only. Okay, so this is sensory area, motor area. So everything is located here only. Here speech area also located here only. Okay, so everything is supplied by middle cerebral artery. Middle cerebral artery is the artery of superior lateral surface. Superior lateral surface. In case of middle cerebral artery occlusion, what will happen? Mainly deficit seen in upper half, not in lower limb or pelvis perineum. Okay, because pelvis perineum, that is controlled by medial surface. That is controlled by, see, if we take this corpus callosum, we are able to see. So corpus callosum here, medial surface only controlling that micturition, defecation, lower limb. Oh, okay, so but this is mainly supplied by anterior cerebral. Here take home point, here superior lateral surface mainly supplied by middle cerebral artery, medial surface mainly supplied by anterior cerebral artery. So anterior cerebral artery, in case of any occlusion, problem mainly seen in lower limb, defecation difficulty, micturition difficulty, that is controlled by paracentral lobule. That is controlled by paracentral lobule. What is the blood supply to the paracentral lobule? Blood supply to the paracentral lobule is anterior cerebral artery. Here Broca's area is seen. Broca's area blood supply, middle cerebral artery. Wernicke's area blood supply, middle cerebral artery. Auditory area blood supply, middle cerebral artery. Most of the motor area, sensory area, that is supplied by middle cerebral artery, except paracentral lobule, that is supplied by anterior cerebral artery. That is supplied by anterior cerebral artery. So here, see, this is middle cerebral artery. What are the areas are supplied? Most of the motor area. Anterior cerebral artery mainly supply paracentral lobule. Paracentral lobule. So that point. So middle cerebral artery, anterior cerebral artery, main difference. Anterior cerebral artery, in case if it is occluded, mean paracentral lobule is affected. If it is gone, mean only lower half of body, which include lower limb, pelvis, perineum problem, anterior cerebral artery, which is supplying medial surface. Middle cerebral artery mainly it is producing problem, motor speech area, sensory speech area, upper half of the body, head and neck, upper limb, trunk. So head and neck, upper limb, trunk, any problem, middle cerebral artery occlusion. Lower limb, pelvis perineum problem, anterior cerebral artery occlusion. Okay, so these are the points we have to remember. Then main arterial supply here, circle of Willis. Circle of Willis, it is formed by, here see, this is internal carotid artery. Internal carotid artery giving anterior cerebral artery. This is what? Middle cerebral artery. Middle cerebral artery. Here two vertebral artery that is joined together and form basilar artery. Basilar artery, which is divided into two posterior cerebral artery. So here posterior cerebral artery is a branch of basilar artery. Here anterior cerebral artery, middle cerebral artery, both are branches of internal carotid artery. Then here this is posterior communicating artery. So all the artery anastomosing with each other and form one circle, that is known as circle of Willis. That is known as circle of Willis. Here some important question: which is the commonest site of berry aneurysm? Which is the commonest site of berry aneurysm? Berry aneurysm, the commonest site is anterior communicating artery. Anterior. So book to book it will differ, but the most standard answer is anterior communicating artery is the site of berry aneurysm, commonest site of berry aneurysm. Like that, there are two other things. Here, which is known as artery of cerebral thrombosis, which is known as artery of cerebral thrombosis. Cerebral thrombosis is Charcot's artery. Cerebral thrombosis is Charcot's artery. Artery of cerebral hemorrhage is anterior choroidal artery. Okay, sorry, here it is wrong. Artery of cerebral thrombosis is anterior choroidal artery, very narrow lumen. Artery of cerebral thrombosis, that is anterior choroidal artery. Cerebral hemorrhage is Charcot's artery. So here it is wrongly typed. Sorry. So here interchange. So this point we have to remember. Next, white matter of cerebrum. White matter of cerebrum, we have to know internal capsule mainly. Internal capsule. So internal capsule here, I mean, if we dissect the brain, here we can see the caudate nucleus, lentiform nucleus, thalamus. Caudate nucleus and lentiform nucleus collectively basal ganglia. So in between caudate nucleus, so caudate nucleus, lentiform nucleus, this is thalamus. So in between there is a tract that is known as internal capsule. This internal capsule which is divided into 3 parts. See here, anterior, so caudate nucleus, lentiform, in between anterior limb. Then this is lentiform nucleus, thalamus, in between posterior limb. Then in between genu. Here the very important thing, the core point is genu is contain head and neck fiber. Genu contain corticonuclear fiber. Genu contain what fiber? Corticonuclear fiber. Posterior limb, it will contain corticospinal tract. Corticospinal tract below the neck, corticospinal tract passing through which limb? Posterior limb. So in case of posterior limb, any occlusion, which one? Posterior limb lesion, corticospinal tract. Genu lesion, what will happen? Genu lesion mainly head and neck region. Corticonuclear fiber. Corticonuclear fiber passing through genu. Corticonuclear fiber passing through genu. Corticospinal fiber passing through posterior limb. Okay. So sensory and motor fibers of trunk, that is passing through motor fibers of trunk and limbs and trunk passing through posterior limb. Head and neck, that is passing through genu. So genu in case of lesion, sensory and motor loss on head and neck. Posterior limb, that will leads to neck, trunk and limbs. So these are the points we have to remember. Then mainly posterior limb, blood supply, posterior limb, this is mainly supplied by, so all the part is supplied by middle cerebral artery. Okay, except here posterior limb mostly exclusively supplied by anterior choroidal artery. Anterior choroidal artery, sometimes question can come, anterior choroidal artery mainly affecting corticospinal tract, mainly affecting corticospinal tract. That point we have to know. Then basal ganglia, the components are, one is caudate nucleus, another one is lentiform nucleus. Both are collectively known as basal ganglia. Caudate nucleus and lentiform nucleus. Lentiform again divided into outer putamen, inner globus pallidus. Outer putamen, inner globus pallidus. What are the important function? Mainly it is planning and programming of movement. Planning and programming of movement, that is done by basal ganglia. Then starting and stopping of the movement. Okay, so range of speed, automatic stereotyped motor activity, everything is controlled by basal ganglia. So basal ganglia is the planner. Main planner is basal ganglia only. Main planner is basal ganglia only. Okay, so here some of the important outcome. Substantia nigra. Okay, in case of any lesion, because it is going to secrete the dopamine, so Parkinsonism. Subthalamic nucleus. Subthalamic nucleus mainly very important to control the movement, to limit the movement. If subthalamic nucleus gone, mean violent movement will come. So that is known as hemibalismus. Hemibalismus. So like that, globus pallidus problem, athetosis, striatum, chorea, all are movement disorder only. Okay, but a different name. Subthalamic nucleus, hemibalismus, very important. Then chorea, that is due to striatum. Globus pallidus, that is due to athetosis. Then ventricular system, already rhomboid fossa we have completed. Then lateral ventricle, third ventricle. Okay, third ventricle floor, that is formed by interpendular fossa. So here this is the lateral ventricle, it is a C-shaped cavity. It is a lateral ventricle, it is a C-shaped cavity. It is a C-shaped cavity. It is communicating with the third ventricle through foramen of Monro. Then third ventricle in communication with the fourth ventricle through aqueduct of Sylvius. So this C-shaped cavity is known as what? Lateral ventricle. So now here first we have to know some of the boundaries are important. So here lateral ventricle, if you take section through brain, something here only this is the lateral ventricle, the roof which is formed by corpus callosum. Then very closely fornix is there. Then one membrane which is extending from this corpus callosum to fornix, that is known as septum pellucidum. Here see, here septum pellucidum we are able to see. So these are the medial boundary. Fornix and septum pellucidum forming medial boundary. Then other boundary we can see. So here corpus callosum, below the corpus callosum only, this is lateral ventricle. Roof is formed by corpus callosum. Then here fornix, from fornix to corpus callosum, septum pellucidum, so medial boundary. Then here below there are two nucleuses seen. One is caudate nucleus, another one is thalamus. So caudate nucleus and thalamus both are forming floor. Roof is formed by corpus callosum. Medially it is bounded by septum pellucidum. Another one is this thing, fornix. So these are the boundary for this thing. Third ventricle, the floor is very important. Okay, floor which is found in interpedunclar fossa structure. Then posteriorly it is limited to which one? Pineal gland. So third ventricle posteriorly pineal gland, floor is interpedunclar fossa content. Okay, septum pellucidum is there. Septum pellucidum, if you open, lateral ventricle. So medial boundary for the septum pellucidum, medial boundary for the lateral ventricle, septum ventricle, this thing, lateral ventricle, septum pellucidum. Floor of the lateral ventricle which is caused by caudate nucleus, another one is thalamus. So this is about then some important this thing, embryological fact. Okay, so we will go fastly. So here urinary system, here kidney, which is kidney that is developed from metanephric blastema. Metanephric blastema. One of the source is known as metanephric blastema. So here metanephros, mesonephros, pronephros, mesonephros, metanephros we know. From the first kidney try to develop in pronephros, then mesonephros, then metanephros. So that proper source that is known as metanephric blastema. So that is mainly going to form secretory portion of kidney. Then collecting portion, this ureter and all, which is developed from mesonephric duct. Mesonephric duct, ureteric bud, that is given by mesonephric duct, ureteric bud. So very simply you remember kidney that is formed by metanephric blastema, ureter and all which is formed by ureteric bud, which is developed from mesonephric duct. Then bladder and all developed from urogenital sinus. So here also kidney, metanephric blastema, ureter, mesonephric duct, here urogenital sinus. Okay, so here kidney metanephric blastema which is giving until this level. For example, metanephric blastema going to form glomerulus, going to form proximal tubule, loop of Henle, distal tubule. This is connecting tubule. From the collecting tubule, everything is developed from ureteric bud or mesonephric duct. So definitive kidney become functional at 12th week. So metanephric blastema, which is going to form secretory portion of kidney. What are the secretory portion? Glomerulus, PCT, DCT, loop of Henle, connecting tubule. Then mesonephric duct, I mean ureteric bud, which is going to form collecting portion. That is collecting tubule, minor calyx, ureter and all. Urogenital sinus going to form urinary bladder. Okay, very simple. Make it simple. Okay, so 3 words only urinary system. One is metanephric blastema, another one is mesonephric duct, another one is urogenital sinus. Urogenital sinus going to form urinary bladder. Ureter and all developed from mesonephric duct, that is collecting portion. Collecting portion mean you have to start from collecting duct. So collecting duct itself. So here confusion will come. Collecting duct, usual confusion. This collecting duct is collecting tubule from metanephric blastema or mesonephric duct. Collecting tubule is from mesonephric duct. We have to remember that. Then let us move on to genital system. Genital system in male and female, both primary is developed from. So in male, testis is primary. Here in female, ovary is primary. Both are developed from genital ridge. So genital ridge going to form testis or ovary. In case of male, secondary sexual organs are developed from mesonephric duct. In case of female, secondary sexual organ, I mean uterus, fallopian tube, okay, upper vagina, everything is developed from paramesonephric duct. So it is simple. So genital ridge is the source for the testis or ovary. Genital ridge, common source. In case of male, everything is developed from mesonephric duct. In case of female, paramesonephric duct. Okay, but male has some paramesonephric, because when we grow, we both having mesonephric duct, paramesonephric duct. Okay, but in male, paramesonephric duct will disappear. In female, mesonephric duct will disappear. So male secondary sexual organ are developed from mesonephric duct. Secondary sexual organ, I mean that is epididymis. Another one is vas deferens, ejaculatory duct. Everything is developed. Seminal vesicle, everything is developed from mesonephric duct. Is any remnant of paramesonephric duct in male? Yes. In male, there are 2 remnant of the paramesonephric duct, that is known as prostatic atricle. Prostatic atricle is a remnant of paramesonephric duct. Prostatic atricle. One. Another one is appendix of testis. Appendix. There are small pouch-like structure on the testis. appendix of testis, appendix of testis. So these are paramesonephric duct remnant. In case of female, any mesonephric duct, because everything is developed from paramesonephric, mesonephric duct will disappear. Is any remnant? Yes, that is known as paruphoron, epuphoron, Gartner duct, Gartner duct. All are remnant of the mesonephric duct in female. So here, make it simple, kidney, that is secretory portion. Another one is collecting portion, secreting portion from metanephric blastema, collecting portion from the mesonephric duct, urogenital sinus going to form the bladder. Then primary from genital ridge, male or female. Male secondaries are developed from mesonephric duct. Female secondaries are developed from paramesonephric duct. In case of male, paramesonephric duct remnants are two, prostatic atrial appendix of testis. In case of female, mesonephric duct remnant are paruphoron, epuphoron, Gartner duct. So these are the things we have to remember. Then here some of the thing, genital ridge, which is going to form testis ovary, testis or ovary, genital ridge. Genital tubercle, which is going to form glans penis or glans clitoris. Genital swelling, which is going to form scrotum or labia majora, So genital ridge is very important. That is testis ovary. Genital swelling is very easy, scrotum, labia majora. Genital tubercle, that is genital glans penis or clitoris. Genital fold going to form labia minora, which is going to form labia minora, or which is also can form ventral aspect of penis, which is also can form ventral penis. Then pharyngeal arches. So with this we can conclude our session. So pharyngeal arches, some of the important pharyngeal arches. So pharyngeal arches here, totally pharyngeal arches which is going to form the neck region. So this is the pharyngeal arches which is going to form the neck region. So here pharyngeal arches, if we put section, the picture will be like this. Outer side, this is ectodermal side, this is ectodermal side, this is endodermal side, So here endoderm, this is ectoderm. Okay, in between the core that is formed by mesoderm. So all the derivatives separately we are going to discuss. So ectodermal side, pharyngeal cleft. Ectodermal side, this is known as pharyngeal cleft. So ectodermal side, this is pharyngeal cleft. Endodermal side, pharyngeal pouches. In between mesoderm. So ectodermal pharyngeal cleft, all the other pharyngeal cleft will disappear. Second, third, fourth and disappear. Then first one, which is going to form external acoustic meatus, first cleft. Okay, only one cleft remain, that is going to form external acoustic meatus as well as outer layer of tympanic membrane. Then here opposite side, pharyngeal pouch, first pouch, which is, so this is external acoustic meatus, mean this is going to form middle ear, logical. So which is going to form middle ear in communication with auditory tube. So this is going to form auditory tube, inner layer of tympanic membrane. Then the same thing, this middle ear posteriorly communicating with, here what is this? This is mastoid antrum. This is mastoid antrum. So mastoid air cell, middle ear, auditory tube, inner aspect of tympanic membrane, all are developed from first pouch. So this is middle ear, auditory tube, mastoid antrum. This is external acoustic meatus, logical. All the other things are disappear. The second one, which is going to form the second pharyngeal pouch, which is going to form lining epithelium of palatine tonsil. This is going to form palatine tonsil. The third one, which is going to form, here, the complete list is there. The third one going to form inferior parathyroid and thymus. Fourth one, which is going to form superior parathyroid. So this order is very important. Okay. So here, please remember, this is middle ear and its connection. This is going to form palatine tonsil. This is going to form inferior parathyroid as well as thymus. Okay, this is going to form superior parathyroid. Fourth one going to form superior parathyroid. Third one going to form. So it is reverse, inferior parathyroid as well as thymus. Later, during development, along with thymus, this parathyroid will go down. Okay, so thymus and inferior parathyroid, this is superior parathyroid. Let us move on to the mesodermal derivative. Each and everything, this core going to form what? So that one we are going to discuss. Okay, so here this mesoderm, first mesoderm going to form on cartilage. That cartilage is known as Meckel's cartilage. First arch cartilage is known as Meckel cartilage. Like that, second arch which is going to form on cartilage, that cartilage is known as Reichert's cartilage. That cartilage is known as Reichert's cartilage. This Meckel cartilage, which is going to form mandible, which is going to form malleus incus. So this is very, very important. Malleus incus is a derivative of first arch. Malleus incus is a derivative of first arch. Malleus incus mandible is a derivative of first arch. Okay. Then other thing, this Reichert's cartilage, second arch cartilage is known as Reichert's cartilage, which is going to form stapes, styloid process. So stapes, stapedius. Okay. So stapes is a malleus incus stapes. Stapes is a derivative of second arch. Malleus incus is a derivative of first arch. Please remember, mandible is a derivative of first arch. So like that here, upper half of hyoid bone. Hyoid bone is a combination of two, second and third. So upper half of hyoid bone is also developed from Reichert's cartilage. See here, first arch going to form mandible, first arch going to form malleus incus, second arch going to form styloid process, stapes, styloid process, upper half of hyoid bone, this part only, as well as styloid process to hyoid bone, stylohyoid ligament. Then below, lower half of hyoid bone. Lower half of hyoid bone is developed from third arch. Then thyroid cartilage and all, fourth arch. Cricoid cartilage from sixth arch. So these are the derivatives, mesoderm. Okay. Then what are the muscles are developed from this? First arch, which is going to form muscles of mastication. So first arch nerve is mandibular nerve. So whatever supplied by mandibular nerve is developed from first arch. So what are the things are developed from? Easily we can recall. What are the muscles are supplied by first arch? Muscles of mastication is supplied by first arch. Here, anterior belly of digastric is supplied by first arch. Mylohyoid muscle is supplied by first arch. So all are developed from first arch. So muscles of mastication, anterior belly of digastric. Another one is mylohyoid, anterior belly of digastric, mylohyoid. Everything is supplied by first arch. Then second arch nerve is facial nerve. So what are the muscles are developed from second arch? Muscles of facial expression. Posterior belly of digastric, platysma, auricularis muscle, occipitalis, as well as here frontalis, occipitalis. So everything is supplied by second. Everything is developed from second arch. Third arch, which is the nerve of third arch. Nerve of third arch is glossopharyngeal nerve. So first arch nerve, mandibular nerve. So whatever supplied by mandibular nerve belong to first arch. Facial nerve is the second arch. So whatever supplied by facial nerve is the second arch. Third arch nerve is glossopharyngeal nerve. Glossopharyngeal nerve going to supply only one muscle in our body, that is stylopharyngeus. So third arch going to form stylopharyngeus. Please remember, stylopharyngeus. Then fourth arch, which is actually superior laryngeal nerve. Fourth arch, okay, which is superior laryngeal nerve, but superior laryngeal nerve which is carrying cranial accessory nerve. So fourth arch cranial accessory nerve also we can say, but we can follow our book superior laryngeal nerve, but actually it is carrying cranial accessory nerve. So whatever muscle supplied by cranial accessory nerve is developed from fourth arch. Whatever supplied by cranial accessory nerve is developed from fourth arch. So what are the things are supplied by cranial accessory nerve? Most of the palatine muscle, most of the pharyngeal muscle supplied by cranial accessory nerve. So we know the formula. So all the palatine muscle are supplied by, what is that? All the palatine muscles are supplied by cranial accessory nerve except tensor veli palati. That is one of the palatine muscle, but that is supplied by mandibular nerve. So mandibular nerve supplying tensor veli palati. Yes. So mandibular nerve, if it is supplying tensor veli palati, okay, so it will originating from which arch? First arch. All the other palatine muscle developed from fourth arch. Then please come to the pharynx. All the muscles are the pharynx are supplied by, what is that? Cranial accessory nerve except stylopharyngeus. So stylopharyngeus supplied by third glossopharyngeal nerve. So it is originating from third arch. Another one is cricopharyngeus. Cricopharyngeus is supplied by recurrent laryngeal nerve. Okay. So recurrent laryngeal nerve is the nerve of sixth arch. So cricopharyngeus is developed from sixth arch. Another one is stylopharyngeus, which is developed from third arch. Remaining all the other pharyngeal muscle developed from fourth arch only. So we have to remember that. Okay. So finally here something about face development. Face here, this is can we continue or stop here? Are you there? Please reply. Can you able to follow? Already time 11:30 plus. Are you able to follow? Can we continue? Okay, so here phase development. Here phase, it is developed from two process. We can make it simple. Okay, so here this foregut region that is developed from frontonasal process. Frontonasal process. Only one thing. So here cleft lip. What are the process are failed to fuse? So like that only question will come. So here this is there are two process forming. One is frontonasal process. Another one is mandibular process. So it is very easy. Mandibular process going to form the lower jaw. Mandibular process which is going to form lower jaw. Then here this region frontonasal process. When frontonasal process coming down here below, it is divided into two process. Here some orbital plug codes are developed. Because of this development, here medial nasal fold, another one fold is known as lateral nasal fold. Okay. Then this mandibular process giving one upward extension that is known as maxillary process. Maxillary process. So mandibular process is there, which is giving one upward extension that is maxillary process. So two mandibular process join together and form lower jaw. So one problem over. Then here this mandibular process giving one upper extension that is known as maxillary process. Maxillary process. Now frontonasal process which is going to form foregut region. Then in frontonasal process, lower part which is divided into medial nasal process, lateral nasal process. Medial nasal process, lateral nasal process. Now this growing maxillary and lateral nasal process forming this cheek. See, this is maxillary mandibular process. This region maxillary process. This is lateral nasal process. Lateral nasal process which is going to form cheek. Okay, so this everything lateral nasal process. Then this maxillary process and medial nasal process both are joined together and form upper limb. Upcoming picture we can understand. See here, this is the final fusion. Final fusion. This is medial nasal process, yellow color. Yellow color. This blue color is lateral nasal process. This is mandibular process. This is maxillary process. See here by this picture we can say it very clearly. Mandibular process forming lower lip. Mandibular process. Two side mandibular process join together and form lower lip. Then maxillary process and medial nasal process join together and form upper lip. So upper lip is very important. Upper lip. Upper lip is formed by maxillary process and medial nasal process. Maxillary process and medial nasal process. Then this cheek region here maxillary process and the lateral nasal process. Lateral nasal process. So in case of any cleft in lower lip, in case of any cleft in lower lip, okay, so that is in case of any cleft here, two mandibular process failed to fuse and mean cleft in lower lip. If this maxillary process failed to fuse medial nasal process mean upper lip cleft. See here upper lip we can see the cleft. Upper lip here we can see the cleft. So maxillary process failed to fuse medial nasal process. So this upper lip forming processes are also forming palate. So here again I want to stress upper lip is formed by two process. Maxillary process, medial nasal process, not lateral nasal process, medial nasal process. The same maxillary process and medial nasal process also forming palate, Okay, so cleft lip, unilateral cleft lip also here associated with the palate deformity. Okay, cleft palate. Okay, so like that here this is bilateral. So here maxillary process, this side maxillary process failed to fuse with what is this? Medial nasal process. So this is bilateral cleft. This is unilateral cleft. Okay, bilateral cleft also known as hair lip, which is also known as hair lip. Then here, what is this reason? Here, this area is formed by maxillary process. Here, lateral nasal process. So oblique facial cleft is due to lateral nasal process and maxillary process. So maxillary two mandibular process forming lower lip. Upper lip is formed by maxillary medial nasal process. Then here if lateral nasal process and maxillary, if not fused, mean oblique facial cleft. See, oblique facial cleft is due to failure of fusion of lateral nasal process as well as maxillary. Maxillary and medial nasal process fuse together and form upper lip. So medial nasal process as well as maxillary process also forming palate. So these are the points we have to remember. Then some of the cells, liver development. In liver development, here some cells, liver is developed from septum transversum, mainly septum transversum. So liver stroma and Cooper cell, liver contain Cooper cell. So here see, this is foregut. It is giving liver bed is a derivative of foregut. So this liver bed going to form hepatocyte and biliary tree. So this is endoderm. So septum transversum is mesoderm. So this Cooper cells is a derivative of, okay, Cooper cells is a derivative of, here the question is Cooper cell is a derivative of hepatic butt or septum transversum. Septum transversum forming liver stroma, Cooper cell. All the other hepatocyte biliary tree is developed from hepatic butt. Okay, so this thing we have to know. Then something about this one, midgut rotation. Midgut rotation, here totally, first we have to remember totally 3 rotation taking place, 3 minus 90 degree rotation. So totally minus 270 degree net rotation, So what are the things we have to remember? First rotation, 3 minus 270 degree anti-clockwise rotation. So please remember anti-clockwise rotation, minus 270 degree. Okay, first this is first physiological herniation is taking place because some a small loop which is undergoing enormous growth. So but baby abdomen there is no space, so umbilical herniation is taking place through the here. So this is first, this is midgut loop is coming out along with midgut artery, that is superior mesenteric artery, that is the axis. So superior mesenteric artery mean first initially one segment is above, another one segment is below. So this is pre-arterial segment, post-arterial segment. Okay, so first this initially pre-arterial above, post-arterial below. Now it is undergoing first minus 90 degree rotation. So pre-arterial become right side, post-arterial become left side. This pre-arterial going to form small intestine, post-arterial going to form large intestine. So this is small intestine, this is large intestine, this is cecal butt. So first rotation minus 90 degree rotation. So bringing first initially pre-arterial above, now it is become minus 90 degree. Okay, rotation. So it is right side. Now initially it is lower, now it is become left side. So now this is first rotation. Second rotation, after that, because everything can't enter simultaneously, pre-arterial lobe started to re-enter into abdomen. At the time it is taking one more rotation. See here, pre-arterial segment which is going to form future small intestine, it is re-enter. At the time it is taking one more rotation. Here it is right side, now it is reaching left side, minus 90 degree rotation. Okay, now this post-arterial segment started to re-enter. At the time it is undergoing one more rotation. See here it is now in left side, so it is reaching right side now. Okay, so 3 rotation, first rotation, second rotation small bowel re-enter, third rotation large bowel re-enter. So minus 270 degree anti-clockwise rotation. Wherever arrest is taking place, that will lead to problem. Okay, first problem, non-rotation. Non-rotation is a misnomer. After first rotation, arrest is taking place. See, first rotation, what is taking place? This pre-arterial segment coming which side? Pre-arterial, that is reaching right side. Post-arterial, which is going to form small intestine, left side. Everything re-enter. Arrest is taking place after first rotation. Non-rotation mean only minus 90 degree rotation. So it is everything re-enter. So small intestine will be seen on right side, large intestine seen on left side. See, small intestine, large intestine seen on other side. So this is non-rotation. Only first 90 degree it is a misnomer. Okay, but the second thing, that is reverse rotation. Reverse rotation mean non-rotation. Reverse rotation mean first rotation here, if everything normally taking place, mean here see, this is duodenum. Duodenum should be overlapped by superior mesenteric artery. So this is the normal thing. If everything taking place, Abnormally mean, I mean first rotation normal, anti-clockwise. Remaining rotations are clockwise rotation. So clockwise 180 degree, anti-clockwise 90 degree. So net rotation 90 degree clockwise rotation. What will taking place? Normally duodenum should be overlapped by superior mesenteric artery. In this case, transverse colon is overlapped by, large intestine is overlapped by. So this picture if is given mean that is reverse rotation, reverse rotation. So here transverse colon that should lies anteriorly, but here it is compressed. So reverse rotation. Then one more rotation, that is mal rotation. Here first two rotations are normal. I mean first rotation normal, second rotation normal, but third rotation, it's third rotation only bringing the large intestine into its original position. Correct? No, but here third rotation is arrested. Here see third rotation, the large intestine not reaching this place. So only first two anti-clockwise rotation. So arrest is taking place within the first rotation, that is non-rotation. After 90 degree rotation, arrest is taking place mean non-rotation. After two rotation, arrest is taking place mean mal rotation. First rotation normal, other two rotation reverse direction mean that is reverse rotation. So these are the three things we have to know. Then Meckel's diverticulum. Here pancreatic duct. I mean first pancreas that is developed from two duct. One is ventral pancreatic duct, another one is dorsal pancreatic duct. So ventral, this is ventral bud, dorsal bud. Within that ventral duct is there, dorsal duct. Due to the differential growth of duodenum, both are fused with each other. So dorsal and ventral both are fused with each other. Then duct system started to fuse. Okay, so this is proximal part of dorsal. This is ventral part of dorsal. So ventral part of dorsal duct. Here this anastomosis and dorsal pancreatic duct, everything collectively forming main pancreatic duct, duct of Wirsing. So here's duct of Santorini is formed by this proximal part of dorsal pancreatic duct. So distal part going to form Wirsing, proximal part which is going to form Santorini. Then here commonest pancreatic, these two ductum failed to fuse mean that is pancreatic division, that is the commonest one. Not annular pancreas is the commonest one. This is the commonest one. So this is also we have to remember. Okay, so neural tube, anterior neuropore, posterior neuropore. Anterior neuropore usually closed at 25th day. If it is failed to fuse it mean anencephalic. Posterior neuropore usually fused at 28th day. If it is failed to fuse it mean that is spina bifida. Spina bifida 3 type. Okay, spina bifida, failure of vertebral development. Spina bifida occulta, meningocele, only meninges are coming out. Meningomyelocele, their nervous system also coming out. Meningomyelocele. So these are the three things we have to remember. So identify the clinical condition. Here see, here bulging is seen in the lower vertebra. Here not only meninges, within that nerve seen. So nerves, if it is clear mean meningocele. Here nerves also seen. So meningomyelocele. Then these are the brain development. I mean brain, the neural tube which is divided into prosencephalon, mesencephalon, ramencephalon. Prosencephalon again divided into telencephalon, diencephalon. Telencephalon going to form cerebrum. Diencephalon going to form thalamus and all. Then mesencephalon going to form midbrain. Hindbrain, metencephalon, myelencephalon. Metencephalon going to form pons cerebellum. Myelencephalon going to form medulla. Okay. Okay, so here interatrial septum development. Interatrial septum first initially, two chambers commonly present. These two chambers separated from each other by one septum. That septum is known as septum primum. So septum primum, which is descending down, but in fetal life, always from the right atrium to left atrium, blood flow should occur. Okay, so this is foramen primum. There is a gap, but later this septum primum reaching the endocardial cushion. So completely right atrium and left atrium separated from each other. But later upper part, some of the cells that will disappear and forming one foramen that is known as foramen secundum. So here there is a question. Foramen secundum is a defect of. Foramen secundum is a defect of septum primum only. So septum primum. So right atrium, left atrium separated from each other by septum primum. Upper part, there is a foramen is created. First, initially lower part of foramen, that is foramen primum. Now second foramen, that is foramen secundum. Then one new septum is developed, that is known as septum secundum. So this is septum primum, this is septum secundum. After the development of septum secundum, this space is known as foramen ovale. This space is known as foramen ovale. So you leave all the things, but here the very important one is here fossa ovalis. This is fossa ovalis. So in fossa ovalis, the floor of the fossa ovalis is formed by septum primum. Limbus fossa ovalis is formed by septum secundum. That point we have to remember. Okay. So limbus fossa ovalis. Another one is limbus fossa ovalis from septum secundum. Floor of the fossa ovalis from septum primum. Then heart, which is developed from heart tube. Heart tube, that is 2 in number. Okay, they are fused together and form single heart tube. That single heart tube from upside down forms some dilatation. Okay, so here from above downward, the dilatations are, one is bulbus cordis. One is bulbus cordis. These are the names. Try to get the exposure. Bulbus cordis. Then below to that primitive ventricle, primitive atrium, sinus venosus. So primitive atrium and sinus venosus, which is going to form the atrial chamber. Primitive ventricle and bulbus cordis. Bulbus cordis again divided into truncus arteriosus. Truncus arteriosus is going to form aorta as well as pulmonary trunk. Then conus and proximal one third. These are the things going to form the ventricle. So these are the proper development. Truncus arteriosus. So here from below up, these are the part: sinus venosus, primitive atrium, primitive ventricle, then again bulbus cordis. Bulbus cordis divided into truncus arteriosus, conus, then proximal one third unnamed part. So what are the proper derivative we are going to discuss? Truncus arteriosus, which is going to form pulmonary trunk, aorta, pulmonary trunk as well as aorta. Conus, which is going to form outflow part, smooth part of ventricle. Conus going to form smooth part of ventricle. Ventricle, if you open, this is ventricle. One part is rough, one part is smooth. One part is rough, one part is smooth. So the smooth part is derived from which one? The smooth part is derived from here, this conus. Okay. Then rough part, which is developed from this primitive ventricle. So it is very simple. Aorta and pulmonary trunk both are developed from which one? Aorta, pulmonary trunk both are developed from truncus arteriosus. Both are developed from truncus arteriosus. Then conus going to form smooth part of ventricle. Primitive ventricle going to form rough part of ventricle. Primitive atrium again going to form rough part of atrium. Sinus venosus going to form rough part of smooth part of atrium. So smooth part of atrium, rough part of atrium. Rough part of ventricle, smooth part of ventricle. This is aorta and pulmonary trunk. So these are the derivatives. Okay. Then here, if this is truncus arteriosus, one thing we have to know, aorta and pulmonary trunk. Aorta and pulmonary trunk should not be a common one. So it should be separated from each other. That is done by spiral septum. So from where spiral septum is developed, neural crust cell, derived from neural crust cell. Like that, here, two ventricles are also separated from each other by one septum, that is bulbar septum. Bulbar septum, this is interventricular septum. Bulbar septum and spiral septum both are developed from neural crust cell. Both are developed from neural crust cell. So this one we have to remember. Here, the floor is developed from septum primum, limbus fossa ovalis from septum secundum. Then some of the major vessels. Okay, so here totally 6 arterial arches. Like pharyngeal arches, arterial arches are there. Out of arterial arches, some of the arterial arches will disappear. For example, first one will disappear, second one will disappear, fifth one will disappear. Okay, the remaining, the persistent ones are 3, 4, 6. 3, 4, 6. Okay, so this is aortic sac to aortic sac. So here the next picture here, first we have to derive this arch of aorta. First, arch of aorta formed by what? Arch of aorta is formed by this fourth arch. Arch of aorta is formed by this fourth arch. Which fourth arch? Left fourth arch. Forming arch of aorta. We are drawing arch of aorta is formed by fourth arch as well as this part of aortic sac. This part of aortic sac. So aortic sac, this fourth arch, then this dorsal aorta. Dorsal aorta. all are forming arch of iota. If arch of iota, the branches are arch of iota giving, first if this is arch of iota, here this opposite horn, which is giving brachiocephalic trunk, see here, initially it is giving brachiocephalic trunk. So brachiocephalic trunk is developed from here. If this is aortic sac, it is having aortic sac, it is having two horn, right horn as well as left horn. So right horn of aortic sac, forming brachiocephalic trunk. Right horn of aortic sac is forming brachiocephalic trunk. Now brachiocephalic trunk, which is divided into two, subclavian right common carotid. Please come to this diagram. Here brachiocephalic trunk, which is divided into subclavian here, subclavian here. This is carotid artery. So it is very easy. So first arch of aorta we have to derive. Arch of aorta is derived from here. This is aortic sac. The following structure: aortic sac, left horn of aortic sac, left fourth arch. Both are forming brachiocephalic trunk. Then brachiocephalic trunk, it is giving branches. Right horn of aortic sac giving brachiocephalic trunk. Then right side fourth arch giving subclavian. Right arch third arch giving common carotid. Then here left side third arch giving common carotid. So this is the picture. So here left common carotid artery, right common carotid artery, both are developed from third arch. Arch of aorta, which is developed from left fourth arch. Brachiocephalic trunk, which is developed from right aortic sac. Right subclavian artery is developed from right fourth arch. So left fourth arch is going to form arch of aorta. Right fourth arch is developed from this one. Right fourth arch. Both side. Fourth arch is very important. Fourth arch, right side going to form arch of aorta. Left side, which is going to form right subclavian artery. Right side, it is going to form right subclavian artery. So this is about. So arch of aorta is developed from aortic sac, left horn of aortic sac, left fourth arch, and part of the dorsal aorta. So these are the point. So from here, this is common carotid artery. Here it is giving one outskirt internal carotid artery. So proximal part third arch common carotid artery. Distal part giving internal carotid artery. So like that here also proximal part common carotid artery, distal part internal carotid artery. Then sixth arch usually giving pulmonary trunk. Okay. So subclavian artery is developed from this side fourth arch, also part of the dorsal aorta. Here then seventh intersegmental artery, one more artery. Here it is giving many intersegmental artery, seventh intersegmental artery. So subclavian artery wise difference. So here finally with this we can conclude right side fourth arch forming subclavian artery, left side fourth arch going to form arch of aorta. Then here this side left side subclavian only one source. Left side only one source, subclavian artery from seventh intersegmental artery. Seventh intersegmental. Left side subclavian artery from only seventh intersegmental. But right side it is originating from fourth arch dorsal aorta plus seventh intersegmental. Okay, that's it. So with this we conclude. Thank you. Any doubt? Thank you so much. Sorry for the delay.